Right. Assalamu alaikum warahmatullahi wabarakatuh. Good evening, ladies, or good afternoon, I should say, colleagues. My name is Osama Al-Alami. I'm the regional medical advisor for Novo Nordisk in Qatar. And welcome to the Novo Nordisk Symposium with our esteemed speaker, Dr. Goran Petrovsky, for the talk entitled Faster Aspart and Innovation in Prandial Insulins. Dr. Petrovsky is an endocrinologist and a professor coming from University Clinic of Endocrinology and Medical Faculty at Skopje, Macedonia. He's a consultant endocrinologist at Sidra Medicine in Qatar. And as you can see, a very impressive biography, but without any further delay, it gives me great pleasure and honor to welcome Dr. Petrovsky onto the virtual stage. Dr. Petrovsky, the floor is yours, sir.
Thank you, Osama. Salam. So thank you for this kind invitation to be here with you, unfortunately, online, and to discuss about the faster aspart and innovation in the prandial insulins. And in the next maybe 20-25 minutes, I would discuss some of the studies and where is the place of the new insulin, like the faster aspart. So if you have any questions, please use the chat box and ask, or if you have any comment, and at the end we'll have time in this short period to answer and to comment your questions or the comments. So let's start. Yes, this is my disclosure. And let's discuss a little bit about the burden of the mealtime dosing. Actually, we all know that in the last couple of years, when we have the CGM devices, when we have the insulin pump therapy, with all these new improvements in the innovations in the diabetes, we are not talking more about the glycemic control. We all know that this can improve the glycemic control, but now we are going further to improve the quality of life of this patient, and we all know that there is a burden of the mealtime dosing. This is one interesting paper that was published last year during the ESD, European Association of the Study of the Diabetes. Will explain the burden of the mealtime insulin dosing in adults and children with the type 1 diabetes. When they analyze the data from the adults and the parents of the children with the type 1 diabetes, they found out that the frequency of the completely forgetting to take the mealtime insulin is huge. As you can see here, that almost 11 or around maybe 10% they are forgetting at least once per week to give the insulin. And there's also some percentage that on the daily basis they are forgetting to take the insulin. And of course, this is very, very difficult if you are a parent of the child with the diabetes, and then when you have to administer the insulin 5-6 times per day, that you need to do all these calculations and that you give the insulin even before the insulin. So from this survey, 25% of the adults with the patients and almost 40% of the parents with the children with the type 1 diabetes, they are completely forgetting to give the insulin the pre-meal at least once per week. So from this study, there is also an interesting data which shows what is the preferred timing of taking mealtime insulin when you give the choice. As you can see, most of them, they want to give the insulin immediately before the eating or maybe immediately after the eating. So doesn't matter if it is the adult patient with the type 1 diabetes or it is a parent of the children. So what is the perceived impact of the quality of life of being able to administer the insulin either immediately before or after the meal? So as you can see here, almost 70% of the adult patients and almost 72% of the parents of the children with the type 1 diabetes, they claim that the taking bolus immediately before the meal or after the meal would have the positive impact of their overall quality of life. And I think that this is very obvious. If for the patient with the type 1 diabetes, doesn't matter if it is adult or a child, they're taking several boluses. And we always are saying to our patient, yes, when you see some postprandial hyperglycemia, it's said, okay, you have to give the insulin 15 or 20 minutes before the meal. But if you eat 5 or 6 times per day with snacks, this is very, very unpractical. And this is actually how we can improve the quality of life with these patients with the type 1 diabetes. So let's discuss more about the science behind the faster aspart. This is a very famous curve, how the insulin actually is working. And this is the regular human insulin. We all know that the onset is maybe 1 or 2 hours, and then it take some time the insulin to be active, and there will be 6 to 8 hours that there will be the insulin on board for the regular insulin. And it makes a little bit difficult if you want to give the insulin in between here, that the patients who are not using the insulin pump therapy, they have to consider, yes, I'm 2 hours, the 2 hours postprandial, so I have to consider that there is some active insulin on board. And this is how does it look like the insulin from the normal pancreas. It starts the onset immediately, and after 2 or 3 hours, it's almost gone from the body. The fast-acting insulin that what we have, they moved a little bit right from in this chart, so they are here, and this is why we are saying that yes, you always need to give the insulin before, or sometimes 15 or 20 minutes before the meal, which is a little bit not practical. And look at the ultra-fast insulin, like the faster aspart. So now the curve comparing with the faster insulin aspart, with the fast-acting insulin, the regular aspart, it's moved a little bit left. And this shows us that we can give the insulin immediately or sometimes after or during the meal. So it replaced the insulin secretion in the type 2 diabetes and have a better profile for the insulin pump therapy, because this is the continuous insulin delivery. I will not go into details about the formulation, but this modification in the formula of the insulin aspart, because it's almost the same, but there is improvement because it's the absorption of the absorption, it's modified, so it's a quicker absorption, and there is also added the L-arginine for the stability. So when we compare the faster aspart versus the insulin aspart with the subcutaneous injection, this is how does it look like. With the blue line, the bolt is the faster aspart, and this is the serum concentration after on the 4 minutes, 9 minutes, and the 30 minutes. Look at this shaded area here with the pink one, which shows how much how faster is the faster aspart compared with the insulin aspart. So twice as fast onset of appearance in the bloodstream, and 2-fold higher insulin exposure with the first 30 minutes. So this is the shaded area which shows the best. And of course, it's the 74% greater insulin action with the first 30 minutes of the action of the fasting. So what about the pharmacokinetics and pharmacodynamics in the special population? In children and adolescents with the type 1 diabetes, this insulin was associated with a twice as fast onset of appearance of the 2-fold higher insulin exposure with the 30 minutes. In children with the type 1 diabetes, faster aspart was associated with a significantly greater glucose lowering effect, and we're going to see that one in the next couple of slides. And there were no significant age group differences in the pharmacokinetics and pharmacodynamics parameters between the faster aspart and the insulin aspart. These are the licensed indications: treatment of the diabetes mellitus in Bahrain. In Qatar, I can say that we managed to have a wider application, so it can be used in the adults with the type 1 diabetes, adolescents, and also children with the age of 1 above in Qatar. Additional information that this subcutaneous administration up to 2 minutes before the start of the meal, with the option to administer up to 20 minutes after the starting the meal. This is what we are usually giving the information to our patient, to the parents, those who are a little bit afraid that of the hypoglycemia, especially for some of the parents, they want to give the insulin after. But with the time, when they will be more confident when they are starting with the insulin after the meal, that there is no hypoglycemic events, they will move during or before the meal. And of course, it can be used during the pregnancy. As you can see here, that the portfolio of the clinical settings is wide. It's type 1, type 2 diabetes, multiple daily injection in insulin pump therapy. Unfortunately, we don't have time to go over this all studies. We're going to show the data some of the study. And these are studies with the type 1 and also with the type 2 diabetes. Let's discuss mostly about the faster aspart in the type 1 diabetes, the onset. This is the Buse. He published this article 3 years ago in the Diabetes, Obesity, and Metabolism. This is the trial design. It's not complicated. Actually, it was the double-blinded study. There were 3 different drugs The patients were randomized after the 8 weeks of the run-in period. The first one was the mealtime faster aspart and the insulin deglutec as a background insulin. The second group was the mealtime insulin aspart plus insulin deglutec. So they just wanted to see the differences between the faster aspart and the insulin aspart. And there was also another group, which was the post-meal faster aspart and the insulin deglutec. It was the partially double-blind type 1 diabetes, more than 1 year. Both genders were included, A1C between 7 and 9.5, and they should be not obese, more than BMI more than 35%. And the key endpoints was the change from the baseline to the hemoglobin A1C, 26 weeks after the randomization, and the change from the baseline in the 1 hour postprandial increment, 26 weeks after the randomization. And this is actually the hemoglobin A1C in the run-in phase. All three groups, they decreased the hemoglobin A1C from the average from above 8 to almost 7.5. As you can see here, that at the end of the study, when comparing with the hemoglobin A1C, there was no inferiority of the faster aspart comparing with the aspart. As you can see here, that the faster aspart also it decreases more the hemoglobin A1C comparing with the regular aspart. But this is also a very important point about the postprandial increment and the week 26. This is the regular, actually this is the insulin aspart. This is the postprandial increment in the next 4 hours. This is how does it look like. And this is the bolus dose given of 0.1 units per kg. And look at the faster aspart. Immediately in the first 30 minutes, the postprandial, it was significantly decreased. And the 60 minutes, it was even more higher. And after the 2 hours, of course, it was again a little bit more significant. And then it went after the 4 hours, similar to the aspart. But I just want to focus and just to be focused on this area here, which shows the postprandial curve here, that it's very, very significant because it immediately decreases in the first 2 hours, which what we were expecting in our patient, because usually this postprandial state we are measuring after 2 or 3 hours. With the CGM, we can see also this area here, and we're going to see on the next slides that it's also improvement here. And imagine this is why I want to focus mostly on this slide, because if the patient is hyperglycemic in these 2 hours after each meal, and if there's a child who is eating 5 or 6 times per day, snacks and main meals, so that means that half of the day, 10 to 12 hours, the patient will be in the hyperglycemic states. So this is why it's also showing the improvements in the hemoglobin A1C. What about the hypoglycemia? Even less hypoglycemic events are also shown with the faster insulin, with the faster aspart. What about the meal-related hypoglycemia after the 26 weeks? So it can be said that the faster aspart, comparing with the mealtime aspart, it has the less hypoglycemic events. Both are non-significant. This is a very interesting study, the GO-BOLUS study from Thomas Dane from Germany. And in this year, he published one interesting article. This is the real-world population in the patient with the type 1 diabetes on the multiple daily injections using the flash glucose monitoring, because with the flash glucose monitoring, we can see all these changes in the time spent in the time in ranges. So this is how does it look like. This is the flash glucose monitoring before including the study, and then they started the faster acting insulin aspart given as the multiple daily injections. And after the 12 weeks and the 24 weeks, there was actually the flash glucose monitoring here. So the key inclusion criteria was the age more than 18 years, so adults with the type 1 diabetes more than 1 year, stable insulin treatment by the MDI for more than 6 months. Regular use of the flash glucose monitoring for the 6 months, because it's not only just to add the sensor, it's just to know how to utilize this kind of the data. And the primary objective of this study was the change of the hemoglobin A1C from baseline to the 24 hours, and the secondary was change of the hemoglobin A1C from the base to the 12 weeks, insulin dose, basal bolus ratio, and the QLA questionnaires. This is the extended analysis, which shows that there was improvement in the hemoglobin A1C by 0.2%. But this is the most important slide from this study, which shows that, look at here, the time in target range from 70 to 180, it was increased by almost 46%. So huge improvement in the time spent in the time in range. And this is actually coming from the previous slides that we presented, because the faster aspirate has more aggressive improvement action comparing with the other insulin, and there was also decrease in the time below the range and decrease of the time above the range. What about the type 2 diabetes, faster aspirate? This is the onset 9, double-blinded, treat to target, so similar to the previous study, onset 9, but here are the only two arms: faster aspirate and the deglutec, and the insulin aspirate as a deglutec, and they were randomized in these two groups. Both genders more than 18 years, type 2 diabetes more than 10 years, and treatment with the basal bolus regimen more than 1 year, and the hemoglobin A1C from 7 to 2 years. The primary endpoint was the change from the baseline and in the hemoglobin A1C 16 weeks after the randomization, and they wanted just to see the change in 1 hour postprandial increment. Again, similar to the previous study, the hemoglobin in the run-in phase, it decreased, and it stays almost the same comparing to the aspirate. So there was no inferiority confirmed between of the faster aspirate comparing with the aspirate. Again, there was a slightly more improvement, decrease of the hemoglobin A1C comparing using the faster aspirate comparing with the insulin aspirate. And again, this is similar to the previous study, the postprandial increment. You can see here that, again, similar with the patient with the type 1 diabetes, the faster aspirate has the it has more improvement in the postprandial state, especially after the 30 minutes to 120 minutes, and even lasting longer, up to 3 hours after that. And this is actually significant difference in 1 hour change comparing with the faster with the aspirate. Both insulins, they were very good in the confirmed hypoglycemic events. They were lower, so no significant hypoglycemic events. But overall, with the faster aspirate, actually there was lower episodes of the hypoglycemic events comparing with the aspirate. What about the pediatric population? These are the children and adolescents, onset 7. Similar to the first study, actually they were randomized in the 2 groups: faster aspirate mealtime and the insulin aspirate mealtime in combination with the deglutec. And there is a third arm, which was the faster aspirate postprandial as a post meal together with the insulin. So these were the both genders, less than 18 years old, hemoglobin A1C below 9.5, MDI for sure, and not using the real-time CGM system. And the key points was the change from the baseline in the hemoglobin A1C, 8-point SMBG profile, and a change from the baseline in the fasting plasma glycemia. Again, there was this is the hemoglobin A1C during the study. There was no differences between the groups in the hemoglobin A1C. They were almost a similar result at the end. And this is the change from the baseline in the 1 hour post-meal increment and the 26 weeks. As you can see here, that there was with the faster aspirate, there was improvement by 1 millimole, around maybe 20 milligram per deciliter after the breakfast, mostly significant after the breakfast. It's similar in the male evening compared to the regular aspirate. Again, hypoglycemic events, there were no significant comparing with all 3 groups. These are the adverse events after the 26 of the other safety information, no significant. So it was the conclusion of the study that it was safe to use in the patients with the type 1 diabetes. So at the end, I would like to conclude with this with the following. Ultra fast acting insulin have an earlier onset and earlier offset of action thereby being more physiological. This offers more flexibility with regards to timing of the injection, thereby potentially improving the quality of life in the patient with the type 1 diabetes. Ultra-fast acting insulin provide comparable hemoglobin A1C glycemic control as rapid insulin analogs with significant improvements in the postprandial control in the wider population of the type 1 and the type 2 diabetes using the multiple daily injection. I think that this is my last slide, and I would like to open the discussion if there are any comments from your side or if there are any questions.
Thank you very much, Dr. Petrovsky. Very interesting and very enlightening discussion and presentation. I've actually got a question for you. I mean, from what you talked about, it seems that speed and flexibility are maybe the key of what we are seeing here with this innovation in bolus insulin, prandial insulins. But again, I guess with that, you've got to start to think to yourself, let's go beyond the clinical trials and get into the patient. So from your clinical experience, which patient subtypes would you think would maybe benefit from such a new prandial insulin?
So I can say that, it's a simple, all can benefit. All patients can benefit. But the patient who is on the established therapy, when you have the good hemoglobin A1C, I also want to see the CGM, because the CGM will show you the postprandial curves that are a little bit higher. So those patients who are experiencing postprandial hyperglycemic events and even the hypoglycemic events, especially in children, because some of the parents are a little bit afraid to give the insulin before because of the potential hypoglycemia. They are giving the insulin after the other insulins. And what is expected, they will go into hyperglycemia and they will give the insulin, they will do the correction, and they will go to the hypoglycemia. I think that this is the group of the patient that can mostly benefit of this patient, and those who are also frequent eaters. Small children who want to have several boluses several times per day. And of course, in the pump therapy, it's also much better because it's not only the postprandial, it's also the correction, especially with the automated insulin delivery system. So you can play with active insulin time, so you can play to be the pump to be more aggressive. And in the first 2 or 3 weeks, maximum to 1 month, you can see this more aggressive, I can say, approach in the hyperglycemia reduction. And then you can have the hemoglobin A1C at 6.5 or 7.1, but you can have the amazing time in the range of 91% with this kind of the insulin using the automated insulin delivery. So I can say that those patients who are experiencing this hypo and hyperglycemias, especially the postprandials, they can benefit, of this insulin therapy. And I can say, try it. And then you will see how it will work. And then every physician has its own clinical pathways, and they will find the way which patients are suitable for them. But from my point, this is the group of patients that can benefit a lot.
Lovely. And there's a question asking if it's licensed for use in pregnancy.
Yes, it can be used in the pregnancy. Yes, it's an aspart, the basic one. So that means this is quite good that, you can use it in the pregnancy. And we are very humble because in Qatar, we can use it above the age of 1. So that means we have opportunity to use all the insulins.
Brilliant. And just one final question from a practical point of view. How easy is it to initiate? Is there anything different from, say, aspart or from other bolus insulins if you wanted to initiate in type 1 or even type 2?
1-to-1. It's 1-to-1. I think that you keep the same carb ratio. Usually 95 of the patients are using the multiple daily injection with the basal bolus. So you just use the same carb ratio, 1-to-1 unit. It's a very pity because we are seeing some patients that are on the fixed boluses. This is what I don't like to see because you will not see the benefit of the therapy. So the patient should be on the multiple daily injections with the basal bolus therapy to see the benefits of this therapy.
What strikes me is, we've had a lot of innovations in the basal insulin side of things. Maybe there's been a bit of I won't say lag, but a delay, I guess, in any innovation seen in branded insulin. So I guess it's a welcome change to see such a thing, and especially now with the timing of, as you mentioned, time in range again and again, and technology. And yeah, you're absolutely 100%
Osama, there's
on the
one question here just pop up here from the from this.
brilliant.
Why there is no better hemoglobin A1C control than just the normal fast-acting insulin? I can say that this is a good question, and for me, I don't see only the hemoglobin A1C, because in the last 20 years we're using the CGM. And that means, and even the GO-BOLD study showed almost the same 40% increase in the time in range. And those who are experienced in using the CGM devices, you can have the hemoglobin A1C of 7.5, and in some patients you can have 75% time in range, and in the other one you can have 55% time in range. So that means we have to look at the CGM devices, and then you will see the differences. And there are a lot of papers who are showing that we know that the hemoglobin A1C is the key corner for the glycemic control. But in the patient with the type 1 diabetes, I want to see the CGM device to see the time in range, because with the time in ranges, then you will see where you are, and then you will see a huge improvement in the postprandial. You just add the sensor for 2 weeks, and then you will see before and after improvements in the time in ranges. Maybe not in the hemoglobin A1C, but the time spent in the same hemoglobin in this normal glycemia will be improved.
Excellent. I mean, this is an interesting discussion. However, unfortunately, we do seem to be out of time. But with that, I'd like to thank Dr. Goran Petrovsky for a very, very well delivered talk and excellent discussion at the end. And of course, for all the attendees and the organizers. And with that, I wish you very good luck with the rest of the Congress, and stay well, inshallah. Assalamu alaikum wa rahmatullahi wa barakatuh.
Thank you. Have a nice weekend.
Good afternoon, everyone. Welcome to the GAED second day of GAED Annual Congress. Hope you are enjoying your weekend, and I hope you had a fruitful and informative day yesterday with our first day of the Congress. It gives me a great pleasure to chair today's session, which is the presidential lecture. And what a nice fresh start for today. We're going to go ahead with a topic that covers the lipid field. And gives me a great pleasure and honor to introduce our speaker for this session, my dear colleague, Professor Kosik Ray. Professor Kosik Ray is currently Professor of Public Health, Deputy Director of Imperial Clinical Trials Unit, and Head of Commercial Trials within the Department of Public Health and Primary Care, School of Public Health, Imperial College, London. And he's a consultant cardiologist and Chief Clinical Officer and Head of Trials Discover now, as well as NIHR ARC National Lead of Cardiovascular Disease. Professor Ray received his medical education at the University of Birmingham Medical School, his MD at the University of Sheffield, and postdoctoral fellowship at Harvard Medical School. He's a fellow of the American College of Cardiology, the European Society of Cardiology, the American Heart Association, and the Royal College of Physicians. Professor Ray is also a member of the British Cardiovascular Society and the president of the European Atherosclerosis Society, also serving on the EAS Consensus Panel and EAS Executive Committee. Professor Ray has either been the national lead investigator, principal investigator, or served on committees for several major medical trials, as well as international registries. He is currently involved in 8 ongoing trials in lipids and diabetes, and the PI for Orion 1311. Those of you are aware of the Orion trial, which is studying inclisiran, a PCSK9 inhibition through RNA interference, and also on the BIT on MAZE trial, assessing BIT protein inhibition in patients with ACS. Professor Ray's research interests have focused on the prevention of coronary disease with a focus on lipids, diabetes biomarkers, and risk prediction. He has many publications. These publications were key original contributions which have influenced European and American guidelines, include demonstrating the early benefits of statin therapy post-ACS and the impact of more or less intensive glycemic control on CVD and the risk-benefit of aspirin therapy in primary prevention. Recently, his work on statins and diabetes risk led to a global label change for statins by the FDA and EMEA. Currently, Professor Ray leads the EAS-FH Studies collaboration, which is the first global registry of FH, which includes 7 countries, among them the Gulf countries, and 62,000 cases, as well as being a senior PI for the Together study, looking at the cardiometabolic risk in the vascular health checks in 250,000 people in London. Today, Professor Ray is going to give us a nice talk in a fascinating era in the lipidology, and these are emerging lipid therapies. And primarily, he's going to give us a talk on novel therapies for cholesterol lowering. Please note that this session, there is no Q&A following this session. But if you have any questions, just to remind you that tomorrow, the 3rd day of the Congress, we're going to have a special lipid track that starts at 5:25 p.m. UAE time. Professor Ray is going to be also a speaker in this lipid track, so you can save your questions for tomorrow for the Q&A session that follows the 4 lectures of the lipid track. And now I'm going to leave you with Professor Ray and hope you enjoy his talk.
Thank you very much for the kind introduction and the opportunity to give this presidential lecture. So the title of my talk was Novel Therapies for Cholesterol Lowering. But before we really do that, we need to think about, well, do we have enough therapies already? And if so, what might the future look like? And what are the challenges that we are actually facing with prevention of cardiovascular disease and in particular cholesterol lowering? So these are a list of my disclosure. I obviously do a lot of trials and registries. So none of us are going to go out of business anytime soon. It doesn't matter which region of the world you reside in, whether you're in a low-income country, a lower middle-income country, an upper middle or high-income country. Atherosclerotic cardiovascular disease, which manifests itself either as ischemic heart disease like myocardial infarction or stroke, are near the top of causes of mortality. And even in the low-income countries, they're fairly close to the top. So as societies become more affluent, they often adopt adverse lifestyle features, and these are maintained, which contribute to the risk of cardiovascular disease. So it's not just things like diabetes, but it's also things like hypertension, mixed dyslipidemias, and so forth. So there's a huge challenge that we face. Now, the next thing to think about is we talk a lot about lipids, and you've all got your favorite lipid fractions that you might believe are more or less important. So let's look at that in a bit more detail. So most lipoproteins, and these are shown here, chylomicrons, VLDL, intermediate density lipoprotein, LDL, low density lipoprotein, and HDL, high density lipoprotein, are shown here relatively in terms of their size. They contain both triglycerides and cholesterol as well. And you'll see that if you look at the ApoB containing lipoproteins, which are the first 4 particles here, the amount of triglycerides to cholesterol content changes as we go from left to right. So the LDL particle has very little triglyceride and mostly cholesterol esters, and chylomicrons, a product of diet, and VLDL, the first precursor to LDL that's produced by the liver, contain a lot more in the way of triglycerides. So when you measure triglycerides, it's telling you something about the number and type of particles that are in your bloodstream. We call chylomicrons, VLDL, and intermediate density lipoprotein triglyceride-rich lipoproteins for obvious reasons. They contain a lot of triglyceride. But they all have one ApoB100 on the cell surface. So the people who are non-diabetic, who are not obese, who don't have insulin resistance, the total cholesterol content of these four particles mostly is driven by the cholesterol that's in LDL. But in people with diabetes, high triglycerides, people with lots of triglyceride-rich lipoproteins, these particles carry cholesterol as well. So LDL may not approximate as well to the total cholesterol content. So we can either, if we were looking at the total cholesterol cargo, we can use something called non-HDL cholesterol, or we can count the number of particles. So if you like, B stands for bad. And then you've got ApoA, which is a lipoprotein on the surface of the HDL particle. And the HDL particles contain both cholesterol and triglycerides. And if you look at all of these together, basically they give you this entire picture. Now, your routine lipid panel consists of three things that you measure. Most laboratories will measure total cholesterol. They will measure directly HDL cholesterol and triglyceride. But what they will do is calculate, using the Friedewald formula, the LDL cholesterol levels. And that's shown here. Total cholesterol minus HDL-C minus triglyceride over 2.2 if this is in millimoles, or over 5 if this is in milligrams per deciliter. So you can do this. Now, this equation works very well when your triglycerides are not particularly high. They also don't work so well if your true LDL cholesterol is really low. So you might know that with certain treatments, we see quite low cholesterol levels. And that is in part an artifact of using these formulas. So if you look at direct assays, for example, the real LDL, the true LDL is somewhat higher. Then we have these more advanced lipid panels. I talked briefly about ApoB and ApoA. What I didn't mention was lipoprotein little a. Most laboratories don't measure this, but this is emerging as a causal factor. We don't have treatments that can lower it yet, but this is really quite important because it's probably one of the most common contributors to premature cardiovascular disease. So levels above 70 nanomoles per liter, that should be nanomoles, not millimoles per liter, would signify somebody with higher risk of cardiovascular disease. And routinely LPA is reported in the LDL non-HDL ApoB fraction. So unless you measure it separately, you can't actually tell if it's elevated or not. Now, we have treatments. So if you think about how you lower lipids, it's very simple. You either reduce production, so synthesis, or you increase clearance, catabolism. Most of the clearance that we see occurs through the LDL receptor. So when you give people statins, you increase the upregulation of the LDL receptor, and it clears all ApoB-containing lipoproteins. So it will reduce triglycerides a little bit, which are contained in the very low density lipoproteins, for example, but it will clear LDL, reduce ApoB, and reduce non-HDL cholesterol. So this is really why, irrespective of what your lipid disorder is, even if in a patient with a high triglyceride, you might want to reduce the risk of pancreatitis. But you're using a fibrate to stop the risk of pancreatitis, not really actually affecting ApoB-containing lipoproteins that much. So first-line treatment is always going to be statin therapy. Now, I'm not going to talk too much about elevated triglycerides or elevated lipoprotein little a. I mean, I would need another 1 hour to do that. But essentially, there are specific treatments being tested that are targeting LPA reduction, and there's a trial going on called Horizon, looking at antisense-based technologies that will reduce LPA by 80 or 90%. There's a trial with a so-called SPARM. It's like a fibrate that is being tested, pemafibrate, in the Prominent trial, and that is on a background of statin therapy. So all of these people should be on statins, and they have additional risk factors like an elevated triglyceride or elevated Lp(a). But on the other hand, we are interested in reducing risk. So irrespective of your cholesterol levels, if you've got, for example, a high-risk individual with diabetes, a low HDL, high blood pressure, established cardiovascular disease, absolute risk is very high. And what we know from the cholesterol treatment trialist collaboration is that further reduction in LDL cholesterol, ApoB, or non-HDL will reduce the risk of cardiovascular events. And again, you can either target synthesis. So in some conditions, like homozygous FH, where there is little or no LDL receptor activity, we use drugs like mipomersen or lamictal, which reduce the production of ApoB. And that's how we lower circulating LDL. You can actually increase the clearance on top of statins. So you can use things like ezetimibe, but you can also use PCSK9 lowering therapies. And what they do is make the LDL receptor survive longer. There's also the potential of CETP inhibitors as well. We know from REVEAL that there is benefit related to the absolute reduction in LDL, nothing to do with the HDL. And there are new trials that will be testing that. And we also have ANGPTL3, which basically works on clearance, catabolic process for homozygous FH, where you can see big reductions in LDL cholesterol. And this does not rely on the LDL receptor for activity. The second thing is that we've got to think about is we don't just give lipid-lowering therapies to people with abnormal lipids. What we're interested in, and it's a mindset change, is risk. But risk varies from individual to individual. So all of the guidelines guess and try to estimate and pick out those individuals who are going to be at highest risk of cardiovascular disease. And these may be people who've already had an event, an MI, they've had a bypass operation, particularly if this happens early in life. These people are more vulnerable to recurrent events and progression over the rest of their life. There are people where LDL and lipids aren't necessarily that abnormal, but they have a high risk condition for atherosclerosis, like diabetes or chronic kidney disease. And then there are those people with genetically primary elevations in LDL cholesterol. So the classic example is familial hypercholesterolemia with a prevalence of 1 in 311, or even polygenic hypercholesterolemia, multiple genes contributing to elevations in LDL. Now, if you don't fall into one of these three categories, how do you get to be a high-risk individual? Well, maybe you've got a little bit of this and a little bit of that. Maybe you've smoked a bit. Maybe your blood pressure is a little bit on the higher side. Maybe your HDL is a little bit on the lower side. And what we do is use risk calculators, because none of us can actually guess and predict what somebody's 10-year risk is going to be. So we use these and we put these into a risk algorithm and we estimate 10-year risk. Now, there is no such thing as the perfect LDL. Lower is better. The lower your LDL, the lower your risk. But we don't necessarily need to overtreat low-risk people. But at the same time, you don't want to undertreat high-risk individuals. So if you look at this analysis from CTT, where the vertical axis is the number of events prevented, and this axis here shows you the 5-year risk of cardiovascular disease. And then this axis here shows you the absolute reduction in LDL. So this is about 40 mg per deciliter. This is about 100. If I lower LDL by 100 mg per deciliter, I'm going to prevent more events than if I lower LDL by 40. But this is against a background risk of 1% per year. So lower is better, but the absolute number of events I'm going to prevent is not as dramatic through that additional reduction because they were low risk to start with. Now, if I take an individual who has an annual risk of more than 6% a year, a 40 mg per deciliter lowering, because they've got so much risk, the same lowering is going to prevent many more events per 1,000. But is that enough? Are you going to be happy with 40? The answer is no, because if you now lower in that individual LDL by 100 mg per deciliter, you're going to prevent many more events. So this is basically the principle of risk and benefit are determined by your baseline risk. They're also determined by the absolute reduction in LDL. And you need to know the baseline LDL to calculate the absolute reduction you're going to achieve from any therapy. And you've got to combine these together. Now, in the European guidelines, because we've got now overwhelming evidence that lower is better, but as I said, you don't want to overtreat low risk, you don't want to undertreat high risk. This is why in the updated guidelines, we can see that for low risk individuals, we recommend LDLs of below 116. But that is not adequate for a very high risk individual. And now, in addition to a 50% reduction in LDL, which is an attempt by the guidelines to get you to use more potent doses of statins in those at highest risk individuals, but also to recommend a goal of 1.4, which is 55 mg per deciliter. For high risk, this is now 70 mg per deciliter, and moderate risk is 100. And you can see these are more intensive than the previous guidelines 3 years ago. And then there's this extreme risk group of below where you've got recurrent events in a very short period of time where we're recommending LDLs of below 1 or 40 mg per deciliter. So that's what we should be doing. But how are we doing in reality? Well, this is data from the Da Vinci registry. And this was looking at 18 countries and about 6,000 individuals. And it asked the question, when you treat those 4 groups of patients, what's your approach? And the answer is, in Europe, 84% of prescribing is statin-based monotherapy. There is very little use of combination therapy, whether that's with ezetimibe or with a PCSK9 inhibitor. Now, what that means is, when the old guidelines were relatively easy to achieve, we got there in 1 in 2 patients. But with the new, tougher guidelines, more intensive guidelines, that approach of statin-based monotherapy will only work in 1 in 3. This means we need to become much more like our hypertension colleagues and think about combination therapy. Let's look at that in a bit more detail in the highest risk group. So this is the cohort of people with established cardiovascular disease, about 2,800 patients. And what I've shown you here is what's being used. So combination therapy is not used a huge amount. There's a little bit better use of high intensity statins, and most of the prescribing is moderate intensity statins. So if we look at goal attainment, old goals, new goals, by the type of approach, we can see that, as you would expect, to get below 70, with intensity of treatment increasing, going from low, moderate to high doses of statins, goal attainment improves. If you use combination therapy, first with ezetimibe or with a PCSK9 inhibitor, you do even better. That's in the dark boxes. That's 70. But what about 55? You'll see that because we've changed the goalposts to 55, mathematically, it is impossible in about half of your patients to achieve goals with statins alone or even statins plus ezetimibe. Just simply adding these 2 numbers together will give you in the region of 43 or so %. So you're going to need, in many of these people, if you choose that their goal is going to be 55, you're going to have to start to think about some form of PCSK9 lowering therapy. Now, you might say, well, why don't I just increase the dose of the statins? Well, the problem is that if you increase the dose of the statins, you don't actually get another 50% reduction. You get about 6 to 8% further lowering of LDL. This is the so-called doubling and the rule of 6s. So if you go from 2.3 and you were to increase somebody's dose of statin from moderate to high, you're still going to be above 2, i.e. you are above a level of 80 milligrams per deciliter. So you're not going to be remotely close to your level of 55. So the guidelines talk about often a stepwise approach, but that's problematic because stepwise approaches are often a barrier to early implementation and getting to goal quickly, because nature doesn't care how we do this. So we can add in ezetimibe, we can add in PCSK9 inhibitors, but often what happens is you see some improvement in the numbers, and then you think, well, let me just wait and see. But waiting and seeing may result in an unfortunate event. So what else is in the pipeline? We know that there are many patients that get side effects from statins, that may not be able to tolerate statins. So an oral drug that's been developed with a couple of unique properties might help with that. We do know there are some patients that will be intolerant of statins because of muscle-related symptoms. So bempedoic acid is a prodrug. It works in the same pathway as statins. This is the step of cholesterol synthesis in the liver. This is HMG-CoA reductase, the target of statins. Now, bempedoic acid works on an enzyme, ATP citrate lyase, 2 steps up. What it does is it inhibits this. Therefore, effectively, it's working through the LDL receptor like statins. So it increases the expression of the LDL receptor. And we know that every treatment that does that has ultimately been shown to reduce cardiovascular events. So those outcome trials are ongoing at the moment with bempedoic acid. But the second thing is, because it's in the same pathway as statins, the additional reduction in LDL depends upon how much statin I've got in the background. Because you can imagine if I'm working through the same pathway and I'm using atorvastatin 80, I might get a slightly lower reduction in LDL than if in a patient who can't tolerate statins at all, when I can really squeeze out the most out of this particular step up here. The next key thing about bempedoic acid is it's a prodrug, and it has to be metabolized to the active compound. The enzyme that converts this is only found in the liver and is not found in skeletal muscle. So when it's converted into the active compound, it can't leave the hepatocyte because of a change in charge. So you don't get those muscle symptoms. Now, in the largest trial to date, we showed that the addition of bempedoic acid on top of high or moderate doses of statins gave you a further 18% reduction in LDL cholesterol, with appropriate reductions in non-HDL and total cholesterol and ApoB. In patients who are statin intolerant, either on low or no doses of statins, you can squeeze out more LDL reduction. You can get as much as 25, even up to 28% reduction in LDL cholesterol. And these were basically the 4 trials that were done, 2 against a background of high or moderate dose of statins and 2 in statin intolerant patients. There is also now available a fixed dose combination, which works very well for people with statin intolerance, containing bempedoic acid and ezetimibe. And with this, you get something close to 40% reduction in LDL. So for a statin intolerant patient, if you think about it, combination of bempedoic acid with ezetimibe is giving you something close to the reduction in LDL you'd expect with 40 milligrams of atorvastatin, for example, or 10 milligrams of rosuvastatin. So that's a good improvement in our clinical practice, because we often find patients intolerant to this. And if you look at this pathway, this is genetic data, and it was an accompanying paper in the New England Journal to Clear Harmony. This is the lipidome profile through HMG-CoA reductase, or ACLY, which is the target of bempedoic acid. The lipidome changes in ApoB, the LDL, all of these other lipid profiles are virtually identical through this pathway. So we have strong confidence that outcomes should be beneficial in the ongoing trial. And that's supported by the Mendida randomization genetics. These are what's observed in genetically lower ACLY individuals in terms of risk of cardiovascular disease. And if you compare like for like, 10 milligram lifetime lowering, irrespective of how this is achieved, and these are all the targets for our drugs, essentially they're identical, which means that for us as doctors, we should be able to combine treatments. And that's really supported by this graph here. We know that the greater the reduction in LDL, the greater the relative benefit. And nature really doesn't care how you lower LDL cholesterol, whether you achieve that through a statin, like approach, ezetimibe-like approach, PCSK9-like approach. The lifetime benefit is exactly the same. So for us, that's great. It means that you can add or subtract treatments based on cost, preference, availability. We've got trial data that also suggests, you might say, well, there are pleiotropic effects of statin. Well, MABs lower Lp(a). But the bigger question is, what is the determinant of benefit? Is it mostly LDL, which is what the drugs are designed to do? So to answer that, what we can do is standardize for LDL reductions of 1 millimole to roughly 38 to 40 mg per deciliter, and we can compare the benefit in statin trials with MAB trials in the first year of treatment and the subsequent years of treatment. Now, statin trials have gone up to more than 5 years. MAB trials are relatively short. So we can't compare later years necessarily. But if we look at the early years, in year 1, for a 1 unit reduction in LDL, the benefit is statistically identical in SPIRE, Fourier, and CTT. In year 2 of treatment, it's also statistically identical when you compare Fourier to CTT, meaning the average over the first 2 years, if you like a meta-analysis, is about a 17% reduction in risk if you maintain a 1 millimole difference over 2 years, irrespective of whether you went with a MAB-like approach or with a statin-like approach. So that's helpful for us because it means it makes us confident that we don't have to keep pushing the statin dose up if a patient can't tolerate it. We can add different treatments in. What's more important is getting your LDL down to match your level of risk and keeping it there and making sure it's safe. The problem with add-on therapy with small molecules is that we're reliant on the patient. They have to adhere. We've looked at that and its implications in this study. This is a large study, more than 40,000 individuals in the UK, looking at what the doctor does, i.e. what they prescribe, and what the patient does in terms of whether they're adherent or not. So you can actually create 6 possible scenarios of intensity, of statin lowering, and adherence. And you can see the biggest reduction in LDL is achieved with the highest intensity statins and those who are more adherent. Even if you prescribe the right treatment and the patient's not adherent, you don't get much reduction in LDL. And if you don't take the medications, you can't see a benefit. And this same relationship, this combination of possibilities, is basically identical with the risk reduction. So you can explain prescribing and adherence through LDL reduction and its impact on risk. And what the impact of this is in your population is shown here. These are new cases of cardiovascular disease, and with prescriptions being given and patients adherent or non-adherent, these are the observed number of events that occur. On average, it's about 72 per 1,000 per year. Now, if we had optimal adherence and we had optimal prescribing, it would look like this. That number would fall from 72 to 48 per 1,000 per year. Still not zero, still not perfect, but it's better. So that would be a saving of 12,000 cardiovascular events per year for a population of 500,000, 500,000 individuals. So you can see that, one, we've got a challenge of getting enough reduction, but the next challenge is I'm going to need combination therapy. But then if I'm going to need combination therapy, I'm reliant on a patient being adherent for many, many years. And it's in that context and that background that siRNA-based approaches, I think, will revolutionize how we practice medicine. There are 2 basic forms to think about. Firstly, antisense, and on the right-hand side, small interference RNA. Now, they're very different. Firstly, the drugs used for antisense are given as a single strand. These are all injectable. The aim is the same. The antisense strand, or the active antisense strand in the siRNA, which is given as a double-stranded compound, essentially has to match a message. There are genes, there are proteins produced as a result of those genes but there's an intermediate step, messenger RNA, the message. And what this drug binds to is an identical matching sequence of messenger RNA, 23 base pairs or so. And by binding that, it then triggers catabolic breakdown through an enzyme called RNase H. But the dosing frequency of this is relatively more frequent. It's occurring inside the nucleus. It's monthly dosing that's required. This is being tested for LPA lowering in the Horizon trial. Now, your cells have a natural process for switching off messages that occur in the cytoplasm. And they contain something, cytoplasm contains something called the RNA-induced silencing complex. And this is happening all the time. You're switching off messages and therefore proteins all the time. We can piggyback onto that. We can basically inject a drug given as a double-stranded RNA with a sense and an antisense strand. Two strands separate. The antisense strand is retained in the RNAs in the RISC complex, and this is what makes it very stable. I can give a small amount of drug which sits here protected from breakdown, and it does nothing until it sees a messenger RNA that it's matched to, and then it targets that for catalytic breakdown. And so this approach potentially gives us a long duration, highly specific targeted therapy. The next challenge is, how do I get this into the liver? Because that's where we want to target most of the proteins. Well, the liver expresses a receptor called the asialoglycoprotein receptor. The purpose of this is to bind aging senescent cells and remove them from the circulation. So if they bind to these cells, there has to be something that they recognize. And this is what we are talking about, GalNAc. So I can add this onto any drug, and therefore within 4 hours, it's taken up by the liver. Now what happens is I don't have to use a large amount of drug. Small injection volume, small injection dose, all taken up by the liver, and then it sits in the RISC complex and then targets the specific messenger RNA. So this basically means that we have treatments like statins and bempedoic acid that will help us make more LDL receptors. But there's a second protein called PCSK9, which breaks down these LDL receptors so they don't live as long. Therefore, if you had a way of either binding PCSK9 in the circulation in the way that we've used in the monoclonal antibodies, or to reduce its production, and the way you do that is target messenger RNA, either through antisense or, as we know now and has been approved, with inclisiran and siRNA-based approaches, you can target lowering of the same protein, but through two different approaches. Now, is there an advantage of one approach over the other? Well, let me show you some kinetics. So this is an injection of a monoclonal. So the amount of drug peaks and then it drops away. PCSK9, because everything is bound instantly, drops instantly. And then as drug levels start to fall, PCSK9 levels will start to go up. Because remember, the liver is continuing to produce PCSK9. So effectively, a MAB is like sitting with a bucket, collecting PCSK9, most of which is coming from the liver. You'll see the LDL cholesterol levels fall. They lag, but they actually don't peak straight away after PCSK9 levels go back up. So this is why with dosing schedules, we now have every 2-week dosing schedules for monoclonal with larger amounts of drug, and the dose we use commonly is 140 milligrams of evolocumab. We can get complete binding of PCSK9 in the circulation, but the liver continues to make PCSK9. Therefore, we have to repeat the dosing interval every 2 weeks. And this gives us a relatively steady profile. But the inconvenience is the every 2-week dosing. Now, what we were able to show with inclisiran is that a single injection, because it's working at such an efficient process, essentially reduces PCSK9 by about 80%, but not 100%, because about 80% comes from the liver, and that's what we're targeting. But that is enough to give us a peak reduction in LDL of over 50%. There's a steady return towards baseline at about 2 to 4% per month. So it doesn't make any sense with a long pharmacodynamic effect to look at percentage reduction at day 60 or day 180, because the percentage reduction with a single dose is going to be different at different time points. What's more important is the area under the curve. So with a single injection over 9 months, time average reduction in LDL is 41%. With a second dose given on day 90, and this is the 300 milligram dose I'm showing you, you get a little bit more LDL reduction, but what you get is that saturation of the risk complex, and so you've got a longer duration of action. And if you look at day 270, the percentage reduction is fairly similar to what was observed at day 90, meaning after that second boost, if you will, on day 90, you should be able to go to a 6-monthly dosing interval and maintain a 50% reduction in LDL cholesterol. Well, that's what we hypothesized, and we tested those in 3 landmark studies. Orion 11 was a population that was high-risk primary prevention and secondary prevention, and Orion 10 was only secondary prevention. And in total, we've got over 3,000 patients over 18 months. And you can see that with a dosing schedule of day 1, day 90, and 6 monthly thereafter, you can reduce PCSK9 levels and keep them down. And what that translates into is about a 50% reduction in LDL cholesterol in percentage terms. This is done without really risking safety. So you've got to separate in your mind the pharmacodynamic effect, which is on LDL through that highly specific mechanism. It's a bit like thinking about if I've got a river and I want to stop the flow in the river. If I go downstream, it's very wide. I'm going to have to put a lot of bricks there to stop it. If I go upstream at a source, small brick or pebble might stop the thing. So that's a good way of looking at it. And if you look at various adverse events that we all report in these trials, it's absolutely identical. The only difference that you'll see is a small excess of injection site reactions, about 1% to 2%. These are mild, transient, non-sustained, non-severe. Liver function, kidney function, CK, platelet count, all identical. The real impact of this, though, is going to be on when we add a second treatment on. Statins are going to be first-line treatment. Of course, they're cheap, they're available everywhere, but we know they're not going to be enough for many. And the problem with second treatments is that pill burden or that medication burden. On the left-hand side are 60 patients taking statins where they're supposed to be on a stable dose, and we've measured LDL 6 months apart. Some will go up by 50%, others go down. This is variability due to adherence. Now, long-term, the greater the variability, the worse your clinical outcomes. So what you are wanting really are sustained, stable, safe reductions in LDL cholesterol. So in the Orion 1 trial, when we add in inclisiran on top of statins, even though the patients may be misbehaving with the statin itself in the background, because you are watching physician administered or healthcare professional, nurse administered, everybody responds. But it gives us an opportunity to reinforce adherence of statins in the background. There is also another advantage. We've seen with COVID that many people do not take their medications properly. Many people don't show up for repeat prescriptions. Because of that long pharmacodynamic effect, these are the time courses. These are waterfall plots showing you that after 2 doses of inclisiran, day 1 and day 90, how long they continue to respond in terms of days, and still have a response of more than 20% reduction in LDL. So you can see that from a convenience point of view, the advantage is patient is traveling, can't make the clinic visit. I saw them in a month's time. I really don't have much to worry about, because LDL's only changed by 2 or 4%. Even if it was 2 or 3 months out, I still don't have to worry about it because of this long duration of action. So it really gives us, from a population health perspective, an opportunity to manage cholesterol really well, efficiently, and properly. And that has a huge advantage, because the one thing with most of our prevention strategies is we've not thought about cumulative exposure in time. If you look at trial data, epidemiological data, genetic data, and you look at the absolute reductions in LDL and relative benefits, they are all straight lines. So what's the difference? Well, the difference on the vertical axis is how long the differences have been observed. So a 1 millimole difference over 50 years gives me 50% relative risk reduction. Over 5 years, starting late in life, is only giving me 22% reduction. So that means for many patients, if I can think about starting treatment early and maintain it, I will have bigger treatment effects long term. And this could really change population health, because again, you can either reduce your LDL cholesterol, if we're even thinking about primary prevention in the future, with 365 pills of statins, 26 injections of MABs, or 2 injections of an siRNA, or maybe vaccines or gene editing. The biggest impact you're going to have is overcoming adherence. So you'll get a better area under the curve, and that means your average reduction, your true reduction and average, not just those good days, will actually be quite substantial. You get substantial reductions in LDL. Over 5 years, it's a very modest benefit, but over 50 years, it's going to be a very large benefit in terms of risk reduction. There is one additional thing that you need to think about, and that is the starting treatment early. To illustrate that, I'm going to show you the primary prevention data from CTT. This is a 1 millimole or 40 mg per deciliter lowering of LDL based on observed in the placebo arm 5-year risk. So if you take the people with an annual risk of less than 1%, that same 1 millimole lowering is giving me almost 40% relative risk reduction. If I have more than 6% per year risk, I'm getting less benefit. Why is that? It's logical. The person with greater risk probably has more atheroma burden. If you treat over 5 years, you are with a 1 millimole reduction, you are not necessarily going to overcome that, because that's taken years to get that much atheroma. But if you intervene early with less atheroma burden, you may actually change the life course and disease early. And that, I think, is something that will revolutionize our approach to medicine. We can also look at that with these data from the WASCOPS study. So we took the WASCOPS data and we removed about 1,000 individuals who had angina or had a TIA. So it was a true primary prevention population. And we divided the group into those with primary hypercholesterolemia above 190 or below. Pravastatin, relatively modest, giving you about 25 to a 28% reduction in LDL, reduced the primary endpoint, coronary heart disease, fatal and non-fatal MI. It also reduced MACE. The absolute reduction is greater over 5 years if your LDL is high. And a lot of people said, well, but you don't show mortality benefits. But think about it. It's a primary prevention population. They are at risk of fatal and non-fatal events, but their risk over 5 years of dying is actually quite low. To answer that question, you've got to look over a longer period of time. And we did that because we've got this long-term extension period. And what we were able to show in that long-term extension period of another 15 years or over 20 years of follow-up is that those people with an LDL above 190 get mortality benefit, mostly in the form of CHD death, also in the form of cardiovascular death, and also all-cause mortality reductions. The lower LDL population are going in the same direction, but remember, they're lower risk, so they're just going to get there. It's going to take a few more years to show the same thing. But the people at highest risk benefit clearly much, much earlier. So think about time and duration of treatment. So in conclusion, LDL lowering should be like blood pressure lowering, combination therapy for the vast majority and of people who are at very high or high risk. One size does not fit all. And fortunately for us, nature doesn't care how we lower LDL cholesterol. The real advantage of some of these novel therapies are they give us choice. Our patients are all different. Some people get side effects. Some people need injections because they're not particularly adherent, for example, to medications. And so we have some of these new therapies like bempedoic acid for statin intolerant, injectable therapies like inclisiran that will really overcome many of our day-to-day clinical challenges. So what you choose really depends upon cost, your perception of safety, patient preference, and largely availability. And with that, I think we can have a bright future and really revolutionize prevention of cardiovascular disease. Thank you for listening.
Thank you very much, Professor Ray, for this very informative talk. Just to remind you all that this session is not followed by a Q&A. Again, for those of you with questions to Professor Ray, he's going to be available with us again tomorrow during our lipid track session. Just again, a reminder, tomorrow the lipid track is going to be after the GAED middle session. It's going to start at 5:25 UAE time. And now I'm going to leave you with the rest of the Congress. Please feel free to go from the different tracks through the different tracks. Today, we're going to have the diabetes track, the adrenal and pituitary track, and the third track is for the pediatric endocrinology and adolescent. I wish you a very fruitful rest of the evening. Thank you.
بسم الله الرحمن الرحيم والصلاة والسلام على أشرف المرسلين. طبعا I welcome all of you in the association, Gulf Association of Diabetes and Endocrinology, and the session of the diabetes session. It will be by a speaker from the Saudi Arabia and from the other part of the Gulf, and I will share this session with my colleague Dr. Mohammed Bashir from Qatar, and the first speaker, he will be Dr. Saud Al-Sifri. He's going to talk about the standardized CGM report. Dr. Saud Al-Sifri, he is associated professor in Taif University and consultant endocrinologist, internal medicine in Al-Hada Armed Hospital. He's trained in Canada, endocrinology and internal medicine. Also, he's a co-chairman of Saudi Diabetic Society. And he's going to talk about the standardized CGM report. I welcome all of you for this session. The session will be shared by me and Dr. Mohammed Bashir, and he's going to present the other colleague, and hopefully, inshallah, we'll meet you at the end for the discussion. Dr. Saud, the floor for you.
Assalamu alaikum wa rahmatullah. Thank you very much, Professor Abdurrahman. Thank you very much, Dr. Mohammed Bashir. I'm very happy to be here with you. Again, I would extend my thanks to the scientific committee for having me with you here. And I wish that we are going to have a very pleasant presentation. I'm going to talk about really the standardized report for CGM. And I would have really like reporting and analysis of those standardized metric that I'm going to have in this meeting. So with this, I would start. And again, in the coming 20 or so minutes, I'm going to talk about those standardized CGM reporting and how we would use it. This is just to go back into October 2000. That was the time for the first child who was started on insulin pump therapy in Saudi Arabia. And then I'm going just to have a quick literature review for those who are in Saudi diabetic children, how and when we have used the time and range and the continuous glucose monitoring in those pediatric children. Now we have really we have been using the continuous glucose monitors in the last 20 years, and now it has been reaching a stage where almost everyone who's of type 1 is using it. Now we have got different types of CGM here in Saudi available, the real time, and the other one, which is intermittent scanned CGM, and the blinded CGM, and then the unblinded CGM for our people. Now, before going into the standardized reporting, we have to know what was the benefit of using the CGM. And I think it has been seen in terms of variability reduction, and again, in increasing the time in range for those glycemic control and decreasing the hypoglycemic time in range and improvement in quality of life that we are seeing. So the good thing about CGM that it display all those numerical as well as geographical information about the current and instant glucose level that we are seeing, again, having a trend that would help physicians and healthcare providers to have a better pictures of those. Then again, downloading those retrospective data, it would give you better analysis for them. Now, some of those features of the glucose continuous monitoring is really having an alert or having the data sharing where they can share it with their either parents or their care partners who are doing with them. Now, having a trend arrows that would help patient, again, to make a daily decision on them doing that. Now, how we would have this reference, again, this is just to tell you that with the difference that we are seeing, I'm trying just to catch those, yes, so that it would show you. So here with the different CGM that we have got, it would show you what are the reference for those arrows, whether it was horizontal or it was vertical or it's taking 45 degree. What does it tell you in those patients? Again, for the clinical practice, these are some of the different CGMs. And again, in this, you would see that what are those guide that they might need it in their clinical practice. Now, again, having ambulatory glucose profile reporting is very important. So here it would tell you that time in range, or those who are above time in range, or those who are got below the time in range. And this can tell you how much of the glucose variability. It can be either in this report, or it could be in this, what we call it a graph, where it showed you the median of 50% of them. And then here it would tell you what would be the range that they might have, either in the 90 or 75%. Again, the more variability that you would have, again, the more risk of hypoglycemia that your patient is having, or hyperglycemia that they might have. So here, this is the time and range for time above range, and here is the time below range in those population. And this tells you how much of this percentage has been above the target or below the target or within the target for each individuals, either over 24 hours or over 14 days, or the wear time for that CGM. So in summary, it showed you that the review summary of those, it would tell you that here, for example, this patient, that it had the goal for less than 36% of the time. And here you could see that in 76% of the time, it was time in range. This is what we want. So these are the metric that whenever we are reviewing those ambulatory glucose monitoring, that the data, at least it has to be for 2 weeks, and then the percentage of time that they are looking for, and the coefficient factors, and the indicator, or what we call them glucose management indicators for those. Remember that CGM or having no calibration in that does not mean that they don't need to do glucose monitoring or a glucose check with a finger stick, because at some situations where you have got hypoglycemia or rapid change in the level of blood glucose, or you want to have pre-confirmations for certain of this, or if you feel that patient is having symptoms which is not related to the real reading, then that patient might need to do glucose check by themselves. Now for the data interpretations, again, we have got few steps. Remember, those 7 steps are important, that at least the data is enough, and then having the patient to have their daily self management, what they have been doing, and then what do they think of this AGB reporting, because it comes in different color, and then to look into the hypo, hyper, and then variability that your patient is having. And again, to be reflected that what do they think the cause of these, either high or low blood glucose, and then to develop in collaboration with the patient an action plan for that, and to make a copy with remarks on those one. Now, the recommendation comes from the international consensus on time on range and using those continuous glucose monitoring data interpretations. So the interpretations, again, these are very important. It is a common metric for assessment of the CGM glycemic status. And again, it can tell you the visualization in a graphs about the glucose data and the daily profile that it has got. Again, defining a clear clinical targets are very important. We have to remember that a lot of things can be dated from there. How many days that the CGM has been worn, and what is the percentage of time that it was active, and what was the mean glucose, and estimated A1C is very important. It can come from those repeated data and continuous data of glucose. Then the glycemic variability is very important, and the time which is above range, and in that you have got two targets. In this one, either it is more than 250 or more than 180 milligram per deciliter, and those time in range, or time below range less than 70, or critically below time in below the target, and that's less than 54 milligram per deciliter. And then we have to look into those low or high blood glucose indices. Then the hypoglycemia and hyperglycemia, which has been more than 15 minutes, has to be reported. And then those area under the curve has to be time. Then the time, you could see it either at 12 hours period, which is either those had been in day or night, so in 12 hours, or collectively as 24 hour. So the standardized CGM metric for those clinical care, it has to be remembered that how many of this has to be. So the time above range has to be either level 1 or level 2 based on the target above the range, if it is more than 250 or more than 180. And time in range, it's between 70 and 180 milligram. Below 70, it is level 1, and below 54 milligram per deciliter, this is level 2 for the time below range. Now, we wanted to see what happens with those time in range, or below range, or above range. So here for type 1 and those with type 2, we wanted to have them more than 70% of the time that they have got time in range. Time below range should be less than 4%, and time above range less than 25%. Now, for those individuals who are elderly or who has got a high risk for hypoglycemia, in that we wanted to be more than 50% time in range, and we wanted to be less than 1% time below range, less than 10% time above range. So this is an important in those elderly or high risk for hypoglycemia, whether type 1 or type 2. Now, another category, which is a pregnant lady with type 1, this is again, we wanted more than 70% time in range, and we wanted to be below range less than 4%, or those less than 25% time above range. This is just to show you that, again, in type 1, type 2, This is what we wanted, more than 70% in the green zone, which is time and range, and here not to exceed 30%, while here less than 5%. Now, when you talk about those high risk or elderly for hypoglycemia, then again, this is what we are talking about, more than 50% within the range, time and range, and less than 50% or less than 60%, they should be within time above range, and less than 1% in hypoglycemia. Now, type 1 pregnant, this is what we wanted, more than 70%, they should be time and range. And for those pregnant, either gestational or type 2 diabetes, we wanted really to be more than 90% within time and range. So these are important, and this is now, it is reflected in time and range, is reflected in the estimated HbA1c, which we could get it from there. Now, these are glycemic glucose management indicator, which might be a new term for the estimated A1c, which we could extract it from the glucose, continuous glucose monitoring. Now, the relation between the HbA1c, which is the measured one, and the relation to time and range has to be remembered that here, when you talk about almost 70% whom they have been on time and range, it means almost it is equivalent to 7% of A1c. Now, this is a very important predictors. So remember that when you talk about 50% time in range, we're talking almost about A1c of 8%. So reaching more than 80% of time in range is equivalent almost to almost 6.5% HbA1c. Now, in this, again, in type 1 and type 2, here, if you would see that if we talk about 60%, we are talking about A1c of 7.5%. And always remember that whenever we get increase in 10% of time and range, we are getting almost like 0.8% reduction in A1c calculation. So this is important. We wanted to validate now the time and range, or using this reporting of standardized continuous glucose monitoring as an outcome measure for those diabetes clinical trials. So here, remember that we wanted to evaluate the association of time and range with the developments and progression of those microvascular complications like albuminuria or retinopathy. So in this, they have been taken 1,440 patients, and they wanted to see in this. So the progression of retinopathy was increased by 64%, and developments of microalbuminuria by 40% for each 10% point lower time and range for those patients. So remember that the time and range has been well linked to those microvascular complication linked. Again, remember that the better you would have in time and range, the less frequency of retinopathy or microalbuminuria. Here, when you talk about more than 70% time and range, it talks about almost 5% of progression into retinopathy. Here, again, less 3% progression into microalbuminuria with those more than 70% time and range. Again, less time and range means more frequency of having those microvascular complications. Now, always into achieving goals, we have to remember that you have to be specific, measurable, achievable, and relevant, and time-bound. So this is the SMART approach. And the goal from here to define exactly what you want to achieve, and you can measure it, and then you want patient not to be stretched, that he's challenged in order to meet these targets, and you want to do it over short period of time. So from this in clinical practice, what we have seen that those time and range or below or above range or within the target range is useful clinical targets and outcome measures, which we have seen in the microvascular complications as complements for A1C for a wide range of people. And again, remember that the target values should be always considered as integral component of the CGM data analysis and day-to-day treatment decision-making. Remember always HbA1c has been used as a gold standard for the glycemic control since we had the trial of DCC, and the SMBG has been a cornerstone of diabetes management care. And this is, we could verify the variability on those daily basis in order to see it. HbA1c does not really distinguish between individuals who have got the same average glycemia, but they have got difference in terms of their risk for hypo or hyperglycemic events. Remember that the SMBG, or having a glucose reading, it's a snapshot of glucose value, but it does not really tell you what was the fluctuations between these tests which patient was taking. So we knew it at that time, but if he takes it another 8 hours later, we don't know what happens in between them. Now, the CGM, the daily one, it provides really ability to obtain an immediate feedback on the current glucose level, as well as direction and rate of change in those glucose level. Informations of these data allows those individuals with diabetes to optimize their dietary intake and exercise, and to make the therapy decisions regarding the mealtime or immediate and appropriate for their healthcare providers to prevent those acute glycemic events, whether it is a DKA or severe hypoglycemia, is very important. So with this, really, I reach my end. Thank you very much, Mr. Chairman. Thank you for my dear colleagues. And I hope that was enough to give you this. Thank you very much for having me with you. Thank you.
Thank you very much, Dr. Al-Sifri, for a very nice talk. So our next speaker is Professor Jason Gill. And Professor Gill is a professor of cardiometabolic Health Institute of Cardiovascular and Medical Science, University of Glasgow. He is actually quite active in research and leads a multidisciplinary research group investigating the effects of lifestyle on the prevention and management of vascular and metabolic diseases. Usually he's mostly interested in the epidemiology. He's usually of lifestyle and cardiometabolic disease risk, and on lifestyle intervention for the prevention and management of cardiometabolic disease. Professor Gill is actually a celebrity. He features quite not unfrequently on BBC documentaries, which I did enjoy in the past. And I'm sure we're going to enjoy his talk today, which is titled "Is Seating and New Smoking?" Professor Gill, the stage is yours.
Thanks, Dr. Bashir. I'm delighted to be here. So to start off, I'd like to say that physical inactivity is a really big health problem. If we look at data from the that was published in The Lancet about a decade ago, what we can see is there's a similar number of deaths annually worldwide due to physical inactivity as there is due to smoking. So physical inactivity is a big deal. And because of that, there are guidelines for how physically active we ask people to be. And there's various guidelines from various organizations. These are the most recent. These are the World Health Organization guidelines. And they really have three components. The first is to undertake what we call moderate to vigorous physical activity, doing at least 150 minutes of moderate intensity physical activity or 75 minutes of vigorous activity. To do some muscle strengthening activities on at least 2 days a week. And then finally, there's this fairly vague thing about limiting the amount of time we spend sedentary. And this is not really well described. So what does this mean? And should we worry about how much time we spend sedentary? And I'm just going to talk about that a little bit over the next few minutes. So the first thing we need to consider is, if we use this pie chart and say, this is what the day looks like. So we sleep for about a third of the day, for about 8 hours. And if we meet the moderate to vigorous physical activity guidelines for, we'd be doing moderate to vigorous physical activity for about 2% of the day. So a question is, does it matter what we do in the other 2/3 of the day? And what we can do in the rest of the day is broadly 3 different things. We can either sit down, like I'm doing now, we can be standing up, or we can be moving at light intensity. So one of the key questions is, does it matter what we do in that part of the day if we are doing our moderate to vigorous physical activity, if we're doing our 150 minutes of moderate intensity physical activity per week, does it matter whether we spend the rest of the day sitting down? So what do we mean by sedentary behavior? So sedentary behavior is characterized as any waking behavior, so not while you're asleep, where you are expending a low amount of energy. So the energy expenditure is less than 1.5 METs or metabolic equivalents, where a MET is the amount of energy you expend at rest, and you need to be sitting, lying, or reclining. Is this a big deal? Now, if you look at the internet, they would suggest that it is a big deal. I just had a quick look when I was preparing this talk, and you see all these different, very well put together graphics saying sitting is the new smoking, and we should be really, really worried about how much time we spend sitting down. So what I want to consider over the next few minutes is whether the evidence for sitting actually fits with the rhetoric that we see in the popular press. So the first thing we really need to consider is how much sitting is needed for adverse health outcomes, and is all sitting we do beneficial or harmful, or is there a minimum amount that we need to be beyond before we see increased risk? And if we look at the data, this is a meta-analysis that was published a couple of years ago, and what we've got here is on the y-axis we've got relative risk of mortality from all causes, and on the x-axis is how much time people spend sitting down. And one of the things that you notice is the relationship is not linear. It's curvilinear. So the first 8 hours or so you spend sitting down, you get no increase in risk. And then beyond 8 hours, every extra hour you sit down is associated with about a 4% increase in risk of all-cause mortality. So one of the things I like to say is you get the first 8 hours free. And this differs from maybe what some of the rhetoric is, that all sitting is bad. So sitting for 8 hours, it doesn't really matter what you're doing up to that point. It's only beyond that where we see an increase in risk. One of the key things is people underreport how much they sit by about 1 to 2 hours a day. So if you directly measure how much people sit, they underreport it a little bit. So what does the relationship look like when you directly measure how much people are sitting using an accelerometer, which is a device which can measure your body's movements? And Ulf Eklund did a meta-analysis in 2019, and what you find is it's broadly similar data, but the amount that you need to sit before you get an increase in risk is about 9 hours a day. So sitting for about 9 hours a day seems to give you no risk, and then beyond that you get an increase in risk. The other thing to consider is how much people actually sit. So, this is data from the United States. I'm not sure what the data would look like in Gulf states, but the average adult is sitting about 6 to 8 hours. So a large proportion of the population are sitting an amount which might not be as hazardous as we think. The other thing that we need to do is really put this into perspective. Let's say, for example, you've got somebody who's sitting 10 hours a day. They've got increased risk because they're sitting more than 9 hours a day, and they reduce their risk to 9. They reduce their sitting by 1 hour, so 1 hour less. And what you find is that change in sitting is associated with about a 17% reduction in risk of all-cause mortality. Now, if we get people to walk for 2.5 minutes more, that's also associated with about a 17% reduction in risk of mortality. So on balance, sitting for an hour less is equivalent to walking for 2 hours, walking for 2.5 minutes more. So one of the things that we really need to take into consideration is that you can offset the amount of time you spend sitting by moving more. And open question is, which of these is easier to do? And I'm going to talk about that a little bit further on. The other thing that we really need to think about is this slide here on this side shows risk of mortality with the amount of time you spend sedentary. And on the other side, it's the amount you spend in light intensity activity, which is the low intensity activities that you'll perform when you're sort of moving around throughout the day. And they're essentially mirror images of each other. So some of this is to do with framing. Is sitting bad, or is sitting just marking someone that's not doing low intensity movements throughout the day? A final point that I'd like to make conceptually is that a number of studies have looked at TV viewing as a measure of sitting. So what they do is, in a questionnaire, they ask you how much time do you spend watching television? And that's not the same thing as sitting. And if you look at the relationship between sitting and mortality versus television viewing and mortality, what you find is the relationship is quite a lot steeper for TV viewing. And so there might be a public health argument to say we need to reduce the amount of time we spend watching television. But if you say this means that you have to reduce all the amount of time you spend sitting, I'm not sure that the evidence is particularly there for that. And one of the things that we really need to think about is if you look at the correlation between the amount of time you spend watching television and the amount of time you spend sitting, it's actually a really poor correlation. About R is 0.1. And the other thing is TV viewing, as I'm sure you're all aware, is heavily confounded by dietary intake. So people, when they're watching television, will eat crisps and drink fizzy drinks. And what you might be measuring when you're looking at the adverse effects of TV viewing is actually the adverse effects of this combination of adverse behaviors. So extrapolating that to all sitting, for example, sitting in occupational activities might not be necessarily the case. And sitting is also heavily confounded by other factors like socioeconomic status. So I think we need to be very cautious there about how we extrapolate. But let's move specifically now to type 2 diabetes. And if we look at the association between sitting on the x-axis and risk of type 2 diabetes, it's actually a relatively flat relationship. In contrast, the relationship with television viewing and risk of type 2 diabetes is quite steep. So I think there's a logical case to say we want to try and ask people to limit the amount of television they watch to reduce risk, but maybe not for overall sitting. And the other thing that's clear is if you look at the size of the relationship between what's the association between every hour of sitting and the increased risk of diabetes, what you find is every hour of sitting you do, extra hour, is associated with about a 1% higher risk of developing type 2 diabetes. Whereas if you look at the same data for physical activity, and I won't go through the whole slide here, but basically every minute of physical activity you do is associated with about a 1% lower risk of developing type 2 diabetes. So again, we've got 1 hour of change sitting by 1 hour or change physical activity by 1 minute. And I'm going to argue that changing physical activity by 1 minute is an easier thing to get people to do than getting people to sit less for 1 hour. Another thing that we need to take into account is the adverse association between sitting and risk of adverse health outcomes seems to differ depending on how physically active you are. So this is a meta-analysis published by Ulf Eklund and colleagues in a few years ago. And what they did is they looked at the amount of physical activity people did. So we've divided populations here into 4 levels of physical activity. This is the most active quarter of the population, next most active, and least active quarter. So the least active quarter of the population are doing less than 5 minutes per day of self-reported moderate to vigorous physical activity, whereas the most active are doing more than 65 minutes. And one thing to look at is when you look at these data, if you are active, this is people that do less than 4 hours of sitting, 4 to 6 hours, 6 to 8 hours, or more than 8 hours, the relationship's flat. So no matter how much sitting you do, your risk of mortality is about the same. Whereas if you are very inactive, sitting more is associated with high risk. So these people here would benefit from sitting less. These people here, it doesn't matter. But a question you have is, if you take this person who is sitting for more than 8 hours a day and not doing very much physical activity, how can they reduce their risk? So one option is, well, if they reduce their sitting by 4 hours per day, so they move from this group here that's sitting more than 8 hours a day to this group here, and they get this reduction in risk. But the thing that you find is that if you keep the amount of sitting they do the same, so more than 8 hours a day, but move to the next group for physical activity, so they walk for 20 minutes more per day. And this is self-reported walking. So it's probably maybe 10 minutes of actually measured walking using an accelerometer. You find a similar change in risk. And similarly, if you take the person here who's in the next lowest group, you get a similar reduction in risk. And one of the things that I'm going to argue is that it's actually quite hard in practice to get people to change the amount of sitting that they do. And option 2, which is trying to get them to increase the amount of walking they do, might be easier. These are data from a meta-analysis on interventions to reduce sitting. So this is a systematic review of all the interventions that have been tried. And what you find is, on average, they're able to reduce the amount people sit by about 30 minutes per day. So not very much. So we're struggling to get changes in sitting that would have a substantial effect on risk. And although people say that a lot of people don't like to do physical activity, and getting them to sit less might be easier, what the evidence suggests is it's actually pretty hard. And when you do the proper randomized controlled trials, it's quite hard to change. And I'm going to give you an example with a study that we did, which was called Eurofit. So this is a study that we did looking at top-level football clubs, so soccer clubs throughout Europe. So clubs that you will have heard of, like Everton, Manchester City, Arsenal, Benfica, Porto, PSV Eindhoven. So we took top-level football clubs throughout Europe. And what we did is we tried to get the men who were supporters of these clubs to increase their physical activity, because one of the things that we find is that men often find it, it's really hard to get men to become more physically active. And we use the fact that men often have a very strong affinity to their football club. And so what we did is we trained the coaches of the football clubs to deliver the intervention. So it's been about 1,100 men throughout Europe. And one of the things that we did is we tried to get people to increase their physical activity and to reduce the time spent sitting. And one of the things we used, we developed this device called the SitFit, which sits in your pocket. And because it sits in your pocket and your thigh changes orientation depending on whether you're sitting or standing, with the accelerometer, you can work out whether somebody's sitting or standing or not. So just like a pedometer is used to count people's steps, this is really a sitting pedometer, and what it does is it can measure how much time you spend sitting upright. And we felt that using this sort of device could give people targets for how much time they spend sitting, which they could reduce, as well as increasing the amount of walking they did. And what we found essentially was that we changed sitting by a very, very small amount. So at 12 months, we only changed sitting by about 2 minutes. We managed to change walking by about 6 minutes. Again, you might say that's not a huge amount, but I'm going to talk to you about it because this is directly measured using an accelerometer. The self-reported changes were bigger. So people reported that they changed their sitting by 64 minutes and their physical activity by 31 minutes. But when we actually measure it, what you find is the effects are much smaller. And this is one of the reasons why you need to really measure what people do and not just believe what people say they do. But although we had a relatively modest change in physical activity, we did see substantial metabolic benefits. So we got about a 2.6 kilogram reduction in weight. We reduced blood pressure, reduced insulin sensitivity, reduced triglycerides, improved liver enzymes, despite this relatively modest change. So one of the take-home messages there is this: you don't need to change physical activity by a huge amount to actually cause a reasonable metabolic benefits. The next thing I want to talk about is, well, what is the minimum benefit? What is the minimum increment beyond sitting where you see a metabolic benefit? Because you can be sitting and you can be not sitting by standing up, or you can be not sitting and moving. And if sitting is something that you want to avoid, how much do you have to change your behavior from sitting to see a benefit? And we looked at this in a study in some older adults that we published a couple of years ago. So what we did is we got a group of older men and women to come to the lab for three days. On one day, they sat down all day and we gave them a breakfast and a lunch, and we measured their insulin and their glucose concentrations in response to it. And we had two groups. We had white European people and South Asian people. On another day, what we did is for 5 minutes every 30 minutes, we just asked them to stand up. And then on a final day, we asked them for 5 minutes every 30 minutes to walk up and down the corridor. And it's just a corridor just outside there. Just walked up and down the corridor very, very slowly for 5 minutes every 30 minutes. And long story short, what we found is breaking up sitting with periods of very slow walking reduced insulin and glucose concentrations, but breaking up sitting with periods of standing didn't. So it seems the minimum increment over and above sitting to actually cause a benefit is moving, slow moving, and not standing. And other studies have shown exactly the same thing. So it seems that standing up in itself is not sufficient to cause a benefit. You need to be moving. So in summary, what we say is the minimum increment above sitting to give a benefit is moving, and standing isn't enough. So there's implications of this, because some people have standing desks, and one of the reasons people have standing desks is say we're going to get the metabolic health adaptation, and I think the evidence suggests that's probably not enough. There are other reasons why you might want to have a standing desk, for example, to reduce back pain and things like that. But in terms of metabolic benefits, we probably need to be moving. So I'd argue that saying sit less is actually unhelpful. And I think we should just say that we need to move more and move more frequently throughout the day. So I'm just going to summarize. So I think the evidence is undertaking more physical activity at any intensity is associated with a range of health benefits. And those include reducing risk of mortality, reducing risk of type 2 diabetes, and actually improving glucose control in people that do have type 2 diabetes. But sitting's not special. It's just one end of the activity spectrum rather than a special case. And intervention data suggests that it's really hard to change people's sitting. You have to do it for a long period of time to actually get a sufficient change to induce a metabolic benefit. And at the moment, we can't really do that very well. And it seems that moving rather than stationary standing is likely to be the minimum increment that we need. So I think standing desks are not really a helpful idea. And I think the idea of saying sitting less, which might get people to do I'd say a suboptimal solution, like using a standing desk, is probably not helpful. So I think accumulating more activity throughout the day is a beneficial thing. So asking people to walk maybe for 5 minutes every hour at a slow pace is a much better approach. And I think having a separate focus on saying sitting is a really bad thing and sitting is the new smoking is not helpful. So I think I'd just like to finish off by saying move more often is probably the message which we should be using for everybody. So that's patients who have type 2 diabetes, people at risk of type 2 diabetes, and everybody in the population, and not just focusing on moderate to vigorous physical activity, but all levels of physical activity through the day. Being a little bit more active throughout the day is consistent with the evidence base. And I think that saying that sitting is the new smoking is really not the most helpful thing to do. So I think I'll finish off there, and I think I've kept to time. So thank you very much. And I'll be there with the panel to take some questions later on.
Thank you, Professor Jason, for the nice talk. My colleague. So our next speaker is actually Professor Lee Kaplan. Professor Lee Kaplan is an associate professor of medicine in Harvard Medical School, and is also the director of Obesity, Metabolic and Nutritional Institute in Massachusetts General Hospital. His research interest. It's my pleasure to introduce Professor Lee Kaplan, and I was mute, so thank you, Professor Gill. So Professor Lee Kaplan is an associate professor of medicine He's the director of obesity, metabolism and nutritional institute in Massachusetts General Hospital. His research focus is mostly on the role of gastrointestinal tract and gut microbiota in the regulation of energy balance and metabolic function, and the mechanism of action of bariatric surgery and genetic determinants of obesity and its response to therapy. Professor Kaplan, the stage is yours.
Good evening. It's a pleasure to join you here from Boston. I wish I could be there, but we'll do that in another year. I'm going to talk tonight about GLP-1 agonists in the treatment of obesity. Now, I want to start by emphasizing that obesity is a disease in the classic sense. It results from abnormal physiology, which is caused by changes in the modern environment acting on individuals with susceptible genetics and biology. It's similar to other modern epidemics like allergies and autoimmune diseases, which have become epidemic because of changes in the modern environment, but are diseases because those changes change the internal immunology. In the case of obesity, it's the internal metabolism and the normal regulation that is disrupted by the environment. Like other diseases, it occurs inside the body, even if some of the causes are outside the body. And it's not a condition of choice. It causes pathology, it diminishes health. And as with most other diseases, the patient's job is to seek and engage with care that is based on improving that abnormal physiology, that pathophysiology. Wishfulness and willfulness alone are rarely successful when you have obesity. Now, we're not talking about a few kilograms to lose. We're talking about true obesity, which is excess body fat that causes a risk to health. Now, effective obesity treatment then requires restoring normal physiology. It frequently, but not always, benefits from a stepwise approach, starting with self-directed lifestyle change at the bottom of this pyramid, moving up to professionally guided lifestyle change, which is the same thing, but a professional to help the patient is added into the mix. Then proceeding, if needed, to pharmacotherapy, and in some patients, surgery and post-surgical combinations, surgery and devices, surgery and medications. But the effectiveness of all anti-obesity therapies, including surgery, has generally been limited. And more importantly, even the most powerful show a very profound patient-to-patient difference. So, for example, with bariatric surgery, patients lose as little as 15% of their total body weight and as much as 60% of their total body weight. And we can't yet predict who's going to be in which category. So the effectiveness of all anti-obesity therapies has been fairly static over the last 60 years. If you look here at bariatric surgery, it was as good effectiveness-wise in 1960 as it is today. The safety has improved very dramatically, but the efficacy has not changed significantly. Intensive lifestyle therapy, the same thing. That's much less effective on average. It's about 4 to 5%, or it leads to about 45% weight loss. Again, it's been made easier and more routine, but it hasn't been made better. Drugs, the same thing. You can see that drugs in general have caused about a 5%, maybe 6% weight loss. There was a blip about 25 years ago with fen-phen. But again, drugs are about the same in terms of effectiveness, or have been, as intensive lifestyle therapy. Well, we'll come back to all that in a few minutes, but for now, I want to emphasize that for this talk, I want to talk about GLP-1, glucagon-like peptide 1, which is an important therapeutic target in obesity. It's a 31 amino acid peptide. It's secreted predominantly from L cells, enteroendocrine cells in the gut mucosa. It's also secreted by neurons in the central nervous system, particularly in the hindbrain nucleus tractus solitarius, as well to a more limited extent, neurons in the hypothalamus. It signals widely in the body through G protein coupled receptors. Now, GLP-1 is known to most of you very well as a contributor to the incretin effect. As you can see here, if you give glucose intravenously or subcutaneously, what you'll see is an increase in insulin, but that increase in insulin is far greater if you give the glucose orally. And that's because oral glucose activates the cells that make the GLP-1 and another incretin called GIP, and that leads to greater insulin secretion for the same degree of glucose, or the same glucose load. So this effect is mediated by two peptides, GLP-1 and GIP, as I've talked about. And again, despite the fact that you have this effect, and you have glucose being administered, the glucose in the blood is controlled because of the secretion of insulin, and because that secretion of insulin is appropriate to the amount of glucose that's bioavailable to the body. So you see here on the right that the plasma glucose level is maintained under good control, whether you administer glucose orally or intravenously. Now, GLP-1 itself is secreted in response to food intake. So if you have a meal, your GLP-1 level goes up and it slowly goes back down again. At the next meal, it goes up. At the next meal, it goes up and then slowly goes back down, as shown here. It's also been shown to reduce appetitive drive. So here you have a meal and your satiety level goes down. But if you give GLP-1 infusion, you get a similar effect to a meal, which is that you see this decrease in satiety and an increase in satiety and a decrease in hunger. Now, GLP-1 biology is complex. It binds to cells on the pancreas, pancreatic acidic cells, and it binds to beta cells, and it increases pancreatic protein secretion and pancreatic hormone secretion, particularly increasing insulin and decreasing glucagon, as shown here. And it has a number of effects. It decreases motility of the intestinal tract, so that can cause some nausea, adverse effects. It increases heart rate to a certain degree. It can cause pancreatitis, but on the benefit side, it increases insulin synthesis and secretion. It decreases appetite. It slows gastric emptying, which may have a contribution to decreasing appetite. And it decreases glucose production by the liver. Now, the pharmacological and physiological effects of GLP-1 are dependent upon the circulating concentrations. So, for example, as you get just with lower concentrations, you see the pancreatic effects. With higher concentrations, you see the gastric emptying effects. And only with the very highest concentrations do you see changes in appetite and food intake. And we believe now that that's because for those effects to occur, the changes in appetite and food intake, you actually have to have GLP-1 working in the brain. So when GLP-1 is working in the brain, mostly that's from GLP that's made in the brain. But if you have high enough levels of circulating GLP, or if the circulating GLP has the opportunity to get into the brain and act there, you'll start to see these effects on appetite and therefore on obesity. Now, there are a number of different GLP-1 receptor agonists that you're all very well aware of because of their effects on improving diabetes. There's native GLP-1, of course, that we've been talking about. And if you see that, and it gets degraded so that by DPP-4, so its half-life is only a couple of minutes. There's liraglutide, which is widely available as a treatment for both diabetes and obesity. And that's a modified version of GLP-1 where there is a fatty acid side chain put on the lysine as shown here. And there's a change in amino acid 34. And together what those do is it increases the half-life and makes the molecule more lipid soluble. And that increase in half-life to 13 hours allows the drug to hang around long enough probably to get into the brain. And when you get into it, since it's around a long time, gets into the brain, it has the opportunity to work there. A newer drug that was approved in the United States, not yet approved around the world as widely, but approved in the United States for the treatment of obesity and has been widely approved for the treatment of diabetes is semaglutide. And semaglutide is an even more modified version of GLP-1. Again, you have the side chain. You've got a specialized amino acid in position 8, which blocks the ability of DPP-4 to degrade the molecule. And so what you end up with is a molecule that has a half-life of 7 days rather than 1 or 2 minutes. That long-acting molecule hangs around for a week and has the opportunity to be transported into the brain to a greater extent even than liraglutide. And we believe that that greater brain penetration is what allows it to be a more effective anti-obesity medication. You don't need that effect as much because the effect on diabetes is more directed at the pancreas, which of course doesn't have to cross the blood-brain barrier to be active. Now, if you look at the two, this is from a phase 2 trial that was published 3 years ago. And what you see here is that compared to placebo, liraglutide is quite effective, causing an average of about 7 or 8% weight loss at 52 weeks. Semaglutide at 0.4 milligrams per day, which gives levels that are equivalent to what we use clinically today, about 2.4 milligrams per week, is about double the effectiveness, leading to about a 15% average weight loss at 1 year. Now, the phase 3 program for semaglutide has included several studies. There are actually more than these 4 studies, but the primary ones are these 4 studies. Step 1, looking at weight loss or weight management for patients without diabetes. Step 2, with diabetes. Step 3, in combination with intensive behavioral therapy. And step 4, looking at the sustaining of weight loss with this medication compared to when you take it away. And I'm not going to go through, I don't have time to go through them all in detail. They've all been published at this point. But I want to show you that if you look at the results from these various step trials, you'll see that the average weight loss in patients without diabetes in step 1 was about 15%. In step 2, patients with diabetes was between 9.5% and 10%. In step 3, again, patients without diabetes, but with intensive behavioral treatment was about 16%. It was really little different from without the intensive behavioral therapy in step 1. And in step 4, it was again about 17%, compared if you took away the drug halfway through the trial, you'd see that you actually would get weight regain. So you'd only see a net effect of about 8% weight loss. So if you look at all of them, in patients without diabetes, you see about 15 to 17% weight loss at 1 year, and patients with diabetes about a 10%, 9 to 10% weight loss at 1 year. Now, why is semaglutide so much better than liraglutide? It's not because it binds to the receptor better or activates the receptor better. It appears because it gets into and activates the important pathways in the brain that are necessary for controlling body fat and body weight. And I'm not going to have time to go through them in detail, but I want to show you in this slide that you can see how semaglutide gets deep into the brain. You can see this is a pseudo-colored image of a PET CAT scan. And what you see here is the regions of the brain where semaglutide gets in and where it activates neurons, that's shown here on the right in blue. So where it gets in is in purple on the left, where it activates neurons is in blue on the right, is deep in the brain, far deeper than we see with liraglutide, and certainly much, much deeper than we see with native GLP-1. Now, as I mentioned before, the effectiveness of all anti-obesity therapies has been pretty static, with bariatric surgery being great in terms of effectiveness, becoming more safe. Lifestyle therapy being effective, but at a modest level, and drugs being effective at a modest level. But over the last, and so the overall effectiveness has been somewhere in the range of about 5% to 8 or 9% for medications and for lifestyle therapies. Now, that's good. It prevents diabetes, or at least delays the onset of diabetes, and can improve other comorbidities of obesity, as shown here. But one of the things that's also shown here is that for every one of these comorbidities, the more weight loss that a patient experiences, the greater the likelihood and the greater the magnitude of the benefit for that comorbidity. So fortunately, over the last 10 years, what we've seen is a steady increase in the efficacy of medications with the addition of bupropion and naltrexone, with the addition of lorcaserin, which unfortunately, because of side effects, had to be taken off the market, because of the addition of phentermine and topiramate in combination, and because of the addition of liraglutide. But much more recently, with the introduction of semaglutide, this more powerful GLP-1 receptor agonist, we see now for the first time that the efficacy of anti-obesity pharmacotherapy is starting to move very significantly upward. Semaglutide 2.4 milligrams per week, as I've already shown you, leads to about a 15 to 17% average weight loss at a year. In combination with cagrilintide in phase 1 studies, we see data that suggests it's going to be in excess of 25%. This combination is going to be in excess of 25% weight loss at 1 year, but those data are still coming forward. And another drug by another company called tirzepatide, which is a combination GLP-1 and GIP receptor agonist, so it's a dual agonist, seems to be in the range of semaglutide and cagrilintide, meaning even more effective. So what you see here is finally, after all of these decades, we're seeing by using these analogs of naturally occurring peptides, we're finally seeing effects that are beginning to approach bariatric surgery. Now, just like all other therapies, from surgery on down to lifestyle, including diets and exercise and everything else, there's an enormous patient-to-patient variability. This is the variability for liraglutide, 3.0 milligrams per day. You can see here to the left of the vertical black bar, some patients actually gain weight, and these are data from the phase 3 trials that allowed its approval around the world. Most patients lose a modest amount, between 5 and 10% of weight. Some patients on the far right lose bariatric surgery levels of weight. If you look at semaglutide, you see the curve is shifted to the right. Doesn't look like much on this curve, but it's this shifting to the right is what accounts for the doubling of the efficacy. But again, you see this enormous variability from patients to patients. And for patients that you might see who have diabetes, as many as 30% of those patients will lose 5% of their weight or less. For patients without diabetes, as shown here, it's 7 to 13%. But on the other side, you'll see patients, about 35% of patients who take this drug are going to lose more than 20% of their body weight. And in the phase 3 trials, the step 1 and step 3 and 4 trials, what we see is that about 10 or 11% of patients lose more than 30% of their initial body weight, putting this drug for those patients in the category of bariatric surgery. So in conclusion, I want to emphasize that GLP-1 is a regulator of insulin secretion in the pancreatic islets and a regulator of appetite and fat mass in the brain. Some long-acting GLP-1 analogs, including liraglutide and semaglutide, appear preferentially transferred into the brain, which is, we believe, why they work better for obesity than some of the other GLP-1 receptor agonists. These analogs demonstrate substantially enhanced regulation of body fat, appetite, and thermogenesis, leading to a dramatic improvement in obesity. The advent of these particularly effective and stable GLP-1 agonists provides new opportunities for effective pharmacological treatment of obesity that till this point we haven't seen. These compounds represent the emerging, far more powerful next generation of anti-obesity medications. And I've talked about only a couple of them, but there are many more in the pipeline of various companies working in this area. And they create an exciting new era for the treatment of obesity. They've also been demonstrated to be particularly effective in treating type 2 diabetes and non-alcoholic fatty liver disease. And as I showed earlier in the slide, in the table that I showed, there are so many comorbidities of obesity that are likely to be able to be addressed by treating the underlying obesity when you have these more effective medications. We've already seen that bariatric surgery can have a dramatic effect on most of the comorbidities of obesity. It stands to reason that having medications that approach the effectiveness of bariatric surgery will do the same thing. Thank you very much.
Thank you very much, Professor Kaplan. So the next talk is going to be by Dr. Iba Rozeri. Dr. Iba is the Chief Medical Officer at Dasman Diabetes Institute. She's a consultant diabetes, endocrine, and nutrition. Dr. Iba, is very well known to the group. She is running the obesity service. She's also the director of the Daphne Type 1 Diabetes Education Program. And she is the main center is actually in Kuwait. She is a proliferative writer. She has more than 55 peer-reviewed publications and multiple other chapters in international books. So Dr. Lozeri, the stage is yours.
Thank you so much for the introduction. It's my great pleasure to be with you all here, although wish that we were face-to-face back in life. So today I was given the title is the effective weight loss on obesity complications. So I want to show you what a double digit of weight loss can really lead to obesity complications. So this is the outline of my talk. So before we start, we really want to understand obesity. And we want to look at what is the definition of obesity. As we have seen from Professor Kaplan, obesity is a disease, and it's characterized by excessive adipose fat accumulation with multiple organ-specific complications. We often use BMI as a method of measuring obesity, but I'm sure like BMI will be obsolete in a few years and of no use apart from for population studies. And what we're really concentrating today is the complications of obesity. So as you know, obesity is associated with multiple complications. So just trying to show you the grade and the strength of evidence, we have today more than 229 plus complications affecting almost every organ system within a medical specialties. So people living with obesity and overweight often have comorbidities, and we like to show it in the 3M models. So that's your metabolic, what you're gonna have fatty livers, cancers, asthma, gallstones, infertility, cardiovascular disease, and type 2 diabetes. When we think of mechanical, we think of joint disease, incontinence, sleep apnea, chronic back pain. And when we think of the third M is the mental and well-being, and you'll see of the depression and anxiety. And the complications of excess body fat happens due to where is this body fat deposited. So if you have an increased body fat, you're gonna have increased adipokine synthesis, which will lead to pro-inflammatory cytokines, impaired insulin signaling, increased insulin, and hence the type 2 diabetes. When we look at increased lipid production, you can see that it will end up in non-alcoholic fatty liver disease, coronary artery disease, congestive heart failure, stroke, and chronic kidney disease. So many of these are interrelated and interrelated, and that's how it really causes a lot of the complications. So let's focus, why does a modest weight loss produce really a lot of health benefits? And the effect of weight loss in metabolic function and adipose tissue. And I hope you can see here that how much intra-abdominal adipose tissue you have versus intrahepatic triglyceride and C-reactive protein, and the degree of the reduction of modest weight loss on each of these parameters. You see, 16% loss will be equivalent to 65% reduction in your intrahepatic triglycerides. We really need to emphasize today the importance of life expectancy that decreases as BMI increases. So if you have a BMI of 40 to 50, you have only 50% chance of reaching age 70 compared to normal BMI, where almost 80% of people will reach the age of 70. And when we want to look to the relationship of comorbidities to excess weight, we see that, as this is a steep curve, and as your BMI goes higher from BMI 30 to 40 to 50, you see the increase in risk of your sudden death, diabetes, respiratory failure, and cardiac renal failure. We have seen over the years that the current obesity treatment guidelines have changed. So we have the obesity and the ACC AHA TOS guideline in 2014, which was a BMI-centric, and today we moved from being BMI-centric to complication-centric. That's again from the newer ACE and TOS and ASMBS, or the ESO societies, or the Canadian Obesity Adult Diabetes Guidelines. What we think is obesity is a key driver of morbidity and mortality. You will have, hypertension, cardiovascular disease, peripheral vascular disease. A lot of our HFpEF is today, is related to heart failure. liver in NAFLD, and pancreas in type 2 diabetes, and in kidney in CKD. So management is about improving health and well-being, not just the numbers on the scales. I'm sure many of you are aware of the Edmonton obesity staging system and of the TOS-ACE obesity staging system, where we look into the metabolic benefits and the abnormalities, and again, looking into the 3M, medical, mental, and mechanical, where we have stage 1 with preclinical risk factors, stage 2 where you develop the comorbidities, stage 3 where you end up in end organ damage, and stage 4 in end stage disease. What I want to move on today and really take you through the how we really see the benefit of the weight loss on complications. I'm going to use the King's Obesity Staging Score. That's what I mostly use in my clinical practice. So similar to what we have in diabetes for A, B, C, D, F, you know, we're going to use here the A, B, C, D, E, F, G, H, I, and I'm going to show you how at each stage will it make a difference for us from the modest weight loss that we can achieve. So A stands for airway. And if we see today, we have a randomized controlled trial of surgery versus best medicines for, you know, airway disease, and that's for sleep apnea. And we can see the effect here on both. And also we have a large study, you know, results coming from the scale study from the sleep apnea results as well. So there is no need to be convinced that, you know, a modest weight loss will improve significantly your sleep apnea. We're going to skip the B for the BMI, and I'm going to move to the C. That's the cardiovascular disease, looking at, you know, from the Swedish outcome study, that's, you know, surgery has really a large benefit of the cardiovascular disease. Looking at also the cardiovascular outcome trial with the GLP-1, you know, in type 2 diabetes, and we see the positive significant effect on this. Also, if you want to look at the beneficial effect on weight loss, on HFpEF, and you can see that has been demonstrated, has shown a beneficial effect even in older patients with a chronic stable HFpEF disease. So this is really to show you how a modest weight loss can have a significant effect on your cardiovascular disease. Again, the resolution of metabolic syndrome after a progressive weight loss, and you can see the difference, how it's really resolved when you're looking at more than 25% of 70%. But even if we're looking at, you know, 15%, more than 45% is resolved. If we focus on the D, so we finished A, B, C, and D, that's now I'm going to show you the effect on the moderate weight loss on diabetes. And this came from the earlier studies of the look ahead, where, you know, greater weight loss gives a greater health benefits, and you have seen the changes in the HbA1c by percentage of weight loss category, and the changes in the triglycerides by the weight loss category. And if we look at the look ahead, the outcomes with greater than 10% weight loss over all of the study populations, you have seen, you know, this was a beneficial on, you know, the primary outcomes and the secondary outcomes. If we move to the surgical study, we have the STAMPEDE, which have been shown as a randomized comparison of the medical therapy, sleeve gastrectomy, and gastric bypass. And the 5 years outcomes have shown that the resolution of the type 2 diabetes in overall. And this is the remission of A1C. Now we try to move from the word resolution, and we favor the word remission. We have to be careful at what cutoff in the literature has been standardized, but the remission of A1C of less than 6 or 6.5 without the use of diabetes medication at 5 years. And these are results that you can see for the STAMPEDE trial. If we look at the DIRECT study, I'm sure you're well aware of the DIRECT, which was, you know, a large randomized controlled trial that happened in the GP practice in the primary care of the UK. And we have the DIADEM, similar results in Qatar, and we have also a DIRECT Plus in Kuwait that has shown very similar results as well. So, and this is where we have taken, you know, participants with type 2 diabetes of a BMI of 27 to 45. And you can see that if we have a double-digit weight loss, at least, you know, more than 10 kilograms and 15 kilograms, you can put the majority of people into resolution of diabetes. And you can see here that the percentage of the weight loss and the proportion of people achieving A1C of less than 6%. If you have 10 to 15 kilograms, you can achieve up to 57. If you have more than 15 kilograms, you can achieve up to 84% of resolution. We have, direct, which has been shown now for the proportion of people at 2 years and recently at 3 years results. So this is to look at A is your airway, C is your cardiovascular, D is your diabetes, and if we move next is your economic. And if we look at the health benefits from economic, this is some of the results showing, where is the percentage of people before surgery and after surgery, and the amount that increased in both economic and the means hours worked. If we move next to F, and that is functional, looking at joints problem, so weight loss in people with obesity and osteoarthritis dramatically improves your functional status. Again, if you see the percentage of the weight loss and the percentage of our improvement and the scores, you can see a great benefit in a small number of weight loss. So now I hope I have convinced you from A, airway, B, BMI, C, cardiovascular, D, diabetes, E, economic, F is functional, and next, if we move next to our King's obesity staging system, is we have the gonadal, and that's both looking at gonadal in both males and females. And we have seen that 100% of resolution of menstrual abnormalities, normalization of sex hormone binding globulins, and significant improvement in hirsutism. So there's a lot of benefit, especially when people with PCO and other gonadal problems. And we have seen erectile dysfunctions has also improved in men. If we look at the health status, so that's moving to the H in our categorization and staging. So that's the perceived quality of life. And if we compare to people in both the surgical treatment and conventional treatment, again, you can see a major improvement in your depressions, in obesity, anxiety problems, in social interactions, and in mental perceptions. So, we can see moving across the categories how a modest weight loss can have a huge benefits on complications related to obesity. So weight loss is associated with improvements in health-related quality of life, and that has been shown across, in many of the categories, whether it's medical or surgical or pharmacotherapy or even intensive lifestyle measures. So if we want to come into conclusion and near summary of my talk, we will see that the therapeutic weight loss really reduces complications. So it's no longer about, scale. It's no longer about BMI centric. We're really moving to looking at what comorbidity we're treating and how much weight loss we would need to get the health benefit for these patients. So it's about the health gain more than, the number on the scales. And if we go through this, if we want to prevent diabetes, you're looking at 3 to 10% of weight loss required for therapeutic benefit. You're going to see the maximum benefit at 15%. If we're looking at hypertension, you're needing about 5 to 15%. Blood pressure is still decreasing at a greater than 15%. Many of the modalities today that I have shown you, whether it's direct, or the surgical, these people will be off their antihypertensive medications. For dyslipidemia, you're looking about 3 to 15%, and the triglycerides still decreasing at 15% and above. For the diabetes, we have seen today various models where you have, A1C still decreasing at greater than 15%. You have the NAFLD, where you will improve steatosis and inflammation and mild fibrosis at a 10% weight loss. The sleep apnea, with little benefit at 5%, you're going to see benefit, but you will see it even more at 10%, where they can get rid of their devices. Osteoarthritis, you improve the symptoms and joint and stress mechanics. You can improve the stress incontinence, about 5 to 10% weight loss, and GERD in males, and gonadal problems in females, and PCOS, where lower androgen improves ovulation and increases insulin sensitivity. So our obesity world has changed today. We're no longer BMI centric. We're moving into comorbidities and really moving into how do I treat and how much management we need to change for the weight loss to see the benefits. So moving from 21 to 2022, we have a lot of advances in the treatment today of obesity. And as has been shown by Professor Kaplan, is how we are moving across with the newer therapies that almost, matching our bariatric surgery. I would advise you all to look at our regional recommendation for the treatment and management of adult obesity in the Gulf and Lebanon. This has been now out from the World Obesity Federation, directed by Professor Donna Ryan, and every country is represented in the Gulf, in the region, in the World Obesity in this society. So in summary, when we come to key consideration in obesity, I hope I have been able to show you that, with a double-digit weight loss, we can have significant improvements in obesity comorbidities. We really need to think that obesity is a disease, and it's like any chronic condition. We need to think of sustainable strategy, moving into combination therapies rather than, being a simple thinking that is eat less and move more. A patient best weight may never be an ideal weight, so think of realistic goals. And management is all about improving health and well-being, not just the number on the scales. I hope that I have shown you today that modest, decrease in weight has a significant improvement in health, and success is different for every individual. So we have to think of it, whether it's physical or mental and health gains, and intervention mean really addressing the root causes and overcoming the barriers. And with this, I would like to come to the end of my presentation. And I would like to thank my team back in Dasman Diabetes Institute, of the whole team. This is an institute that publishes yearly at least 70 peer-reviewed article journals. And then I would like to thank my mentors and collaborators, Professor Carl Leroux and Professor Donna Rani. And with this, I would like to thank you all. And it's been great being with you here and looking forward for further discussions and interesting questions. Please feel free to email me if you want any of the slides. Thank you and have a good evening.
Thank you very much, Dr. Iba, and thank you all the speakers for sticking to time. If I may ask you to open your cameras. I think it's been disabled, but shortly it will be enabled. Well, I'm being disabled, I can open it. Yeah, well, great. Thank you very much. I cannot see Dr. Safiri with us. However, I have received just a few questions. So I'm going to start with Professor Jason, Professor Jill. Professor Jill, quick question. So, which is a personal question. My brother works from home, invested on a stand-on desk, so he can stand up and work from there. Should I keep him tormented, or should I ask him to chill out and grab a chair and then go for a walk after that?
I'm not a big fan of standing desks. I think they're a solution to the wrong solution to the problem. I think sitting down for a long period of time continuously might not be the best thing to do, but you need to be moving rather than standing still to counter that. So I think a better solution would be to sit down, but set yourself an alarm. So every hour you go for a walk for 5 minutes and then you go back and sit down. I think that would have the same effect in terms of sitting down for a long time on posture and sort of musculoskeletal effects, but that will also give you a metabolic benefit. So I wouldn't bother with a standing desk, to be honest. So I'd tell your brother to sell his standing desk on eBay and get himself a nice comfortable chair, but make sure get a pair of comfortable walking shoes so he can go for a walk every 5 minutes, every hour.
I'm going to keep him tormented to stand for a few more weeks, and then I'll tell him about that. So one of the things you actually presented in your study, in the data, which is actually interesting, the study in which you put a device in the patient's pocket and ask them to stand up. And then, however, the metabolic benefits does not actually match the reported data that you actually show. There is a huge metabolic benefits in reduction of improvement in insulin sensitivity, while it seems to be more matching of what the patient reported. How accurate is your device? How happy you are with your device? Because the metabolic benefits for a very modest changes is actually I can say disproportionate a bit.
Yeah, so that's really interesting. So I'm doing another talk tomorrow which I will cover some of those data on. But one of the difficulties is we have used data based on self-report to make all our judgments about how much physical activity people should do. And people over-report substantially how much they do. So how much they say they do and how much they actually do are two very different numbers. But what we're doing is basing our evidence on what people say they do. And actually, if you directly measure how much physical activity people are doing using one of these devices, what you find is there's huge benefits from very small amounts of physical activity. I wrote a commentary piece in Nature Medicine last year, and what it works out is on average, 1 minute of measured physical activity during a device is about equivalent to 2.5 minutes of reported activity. So 6 minutes of reported activity is probably 20 odd minutes of actual, 6 minutes is 6 minutes of report of measured physical activity is probably the equivalent, so we saw in this, to 30 minutes of reported activity. So I think the take-home message is don't believe what people say they do, measure what they do. But if you measure what they do, if you measure activity, the amount you need to do is actually quite small. And so if you think about in terms of designing interventions, saying you need to do 5 to 10 minutes more activity today that you directly measure might be something that people are prepared to do, and it might be less daunting than say you need to do 30 minutes. So I think if you say do 5 minutes of walking 3 times a day, but measure it properly using one of these devices, I've got one on my wrist, that might be enough. And that might be less daunting than say do 30 minutes.
All right.
شكرا دكتور محمد. Just if, there is one question for Dr. Professor Kaplan about for how long we can use the GLP for weight reduction for the Professor Kaplan.
Yes, I don't think my video is working, but because I think it's been shut off, but I can talk. Can you hear me?
Yes, yes.
We can.
Oh, now you have it on. Okay, good, terrific. So we routinely will use medications that work indefinitely for life. Now there may be a reason to stop them if there's later a problem. For example, a drug like phentermine, which if it's going to cause a problem, it's going to cause a problem early. It'll cause hypertension, or it'll cause tachycardia. We won't use it for people who have known tachycardia. But if you use it for a very long period of time, as I've used it up to 20 years, people get older, and they may you have to be aware that they may get heart disease over time. So you may have to stop a medication much later because they develop contraindications. But if you stop a medication that works well, the patient will immediately regain the lost weight. And then what we see is almost every patient who does very well with medications, who loses, 10, 20, 30, 40 kilograms, what they'll do is they'll want to stop the medication. And they'll believe that the medication isn't what's doing it, is the medication is allowing them to behave better. They'll stop the medication, they'll rapidly regain weight because they've lost a lot of weight in the first place. And they'll be back in the office realizing, and I've never had a patient who does it twice, because we're selecting out the population who does really well. Now, for a patient who only loses a few kilograms on medications, we're not going to keep them on medications anyway. We're not going to ever put them on long-term medications. We're looking for medication to substantially enhance what lifestyle can do. And as I said earlier in my talk, I didn't emphasize it, but I'll emphasize it now, is we use lifestyle to fix the problem, just like we use medications and surgery to fix the problem. Just eating less doesn't fix the problem. But if you find that somebody is gaining weight or has obesity because they have sleep deprivation, or they have stress, or they have no exercise, or they have an unhealthy diet, if you can fix the underlying problem for their particular type of obesity, you may never need the medication in the first place. But that's relatively rare. So we treat it all the same way. It's just like we treat diabetes, how we treat hypertension. If the medication works, we keep them on it.
There is another question from Dr. Aipa, our colleague, for how much hemoglobin A1C reduction in case of 10% reduction of the weight? How much they affect on the glycosylated hemoglobin in diabetic patients? Well,
of course, these are good anti-diabetes drugs. And it turns out that they're also good anti-NASH drugs. So you see a benefit to that. I think that what I would say is, because of the way of the mechanism of action of the GLP receptor agonists, you don't see a very significant degree of hypoglycemia from the GLP receptor agonist. However, if somebody is on a sulfonylurea or insulin, and they're well controlled on a sulfonylurea or insulin, and you add a GLP receptor agonist, you can throw them into hypoglycemia. It's not the GLP receptor agonist that makes them hypoglycemic. It's the insulin and the sulfonylurea, which are now overdosing the patient. So what you have to do is if somebody's not on any anti-diabetes medications, these are very safe drugs in terms of glucose control. But if they are on some that you just have to be careful about that. So whenever you have good weight loss, doesn't matter whether you do it with lifestyle or drugs or surgery or anything. If you have good weight loss, you have to recognize that you're probably going to put the patient at risk of being overtreated for their underlying diabetes or prediabetes. So you just have to be careful about that.
So just to comment on this is like, you have seen that about 10% weight loss can put people into resolution. So to remission. So we have seen from direct 10 to 15 kilogram weight loss can put people into remission. But we have to take into account that they have to be early into disease, similar to results that of the bariatric surgery. Your chances of being into remission is less if you have been treated on insulin and you have some, reserves on with C-peptide. Of course, in clinical practice, we have seen people who have been in megadoses of insulin have been taken off, the insulin, but they have a less duration of diabetes. So we say your chances is higher if you have a duration of less than 3 years of diabetes. Up to 6 years have been reported in the literature as well.
Yeah, I think that's very important what you're saying. And I think it's also important to note, though, and this talks about the role of the regulators and the governments in deciding how various treatments are covered. You save a lot more money if you get somebody off of insulin and they're on only oral agents than you do if you've got somebody who was never on insulin and you put them in full remission. So the surgeons love to talk about full remission, but full remission is a concept. Getting rid of insulin is a real benefit to the patients and in terms of risk, in terms of cost, in terms of everything. So while I agree with you that going into full remission is much less likely if a patient starts on insulin or has had diabetes for a long time, the actual net benefit to those patients may be even greater than the net benefit to the patients who get caught early. That's not to say you shouldn't catch them early, but if you don't catch them early, it shouldn't be a reason not to use surgery or any other effective therapy.
And I can tell you data from our remission clinic in Kuwait that, more than 70% of people who achieve weight loss would be off their insulin therapy, even if they had insulin for a long time. And that's, exactly what Professor Kaplan has shown, demonstrated to you as, this is a huge benefit, even if they don't reach remission, but getting people off their insulin therapy when they're on 300 units, just by, pharmacotherapy or losing weight is a health cost benefit and economical benefit for the country.
I think, Dr. Aiba, you're talking about type 2.
Type 2, yes.
Absolutely.
Although there is some evidence now for type 1. So there's growing evidence for type 1 that we don't have time now to go into detail, but a lot of patients with type 1 now have obesity. And some people call that type 3, they call it type 1 plus 2, but type 1 is not a disease only of skinny people, the way we thought about it maybe years ago when we were trained. So I think that we do have to consider that the growing population of people who have a need for treating insulin resistance in the setting of type 1 diabetes.
So we have actually just published last week in Diabetology, and there was a presentation in the ESD. I'm one of the co-authors in the Lancet Diabetes Endocrinology, a review on how to treat obesity in type 1 diabetes and, the various factors of obesity around different part of the world. So I would urge you all to look at it, Diabetology it's a Lancet in the Diabetes Endocrinology presentation that was publication was published last week, and it was in the ESD conference presentation.
I think because of the time, we will move to Dr. Gill, because there is one interesting question. For how long you advise type 1 diabetes? What's the maximum times for exercise because we noticed some patients, they develop hypoglycemia after exercise in type 1. So what's the maximum time you advise your patient for doing exercise in type 1?
So I don't think there's people with type 1 diabetes who are professional athletes, professional cyclists in the pro peloton, professional footballers. There's no maximum amount of activity that someone with type 1 diabetes can do, and I don't think they should be limited in the amount of activity to do. What we need to do is understand how physical activity influences their glucose levels and how it interacts with insulin. And one of the issues in type 1 diabetes is the intensity of activity you do actually has opposite effects on your glucose concentration. So if you do long, steady activity, that causes your glucose levels to fall. If you do sprints or high intensity activity, it causes your glucose levels to rise. And so just being aware that different types of activity have different effects. And also the order which you do. So if you have a session where you do some long, steady stuff and some sprints, the order that you do them in has a different effect on what your glucose is, both during the session, but also into the hours afterwards, and particularly into the night. So it's getting some awareness of what happens to your glucose, and actually understanding how much you have to change your insulin. And one of the things with insulin is you say, well, look, if you're going to do some exercise, you need to reduce your insulin a bit. You don't have to reduce your insulin a bit, you reduce it a lot. You take it to 25% of your normal amount. You don't just drop it down a little bit. So it's actually understanding how your activity interacts with your insulin, and understanding how different types of activity actually have opposite effects on your blood glucose that you need to take into account. But with that knowledge, there's no reason why you can't run marathons and be a professional cyclist or do whatever in terms of activity if you have type 1 diabetes. It's just a little bit of knowledge and understanding is what you need.
And I think the auto insulin pump, it will be very helpful in this situation, especially in the exercise. So because it's auto, the amount of the insulin pumping, it will be changed according to the blood glucose level. Yes, Dr. Aipa?
I just want to add, as last year we have conducted a study with a collaborator from Professor Jill Lab team is looking at the timing of exercise in type 1 diabetes while fasting in Ramadan, and the different effect of exercise. So while people are fasting, when do you time it, and how does it have an effect into Ramadan and exercise? So as Professor Jill said, people with type 1 diabetes, a lot of them are professional athletes. It's all about managing, insulin therapy and what exercise we advise people and on what orders and the timing of the day. So there was, very interesting results that we have seen from last year Ramadan study looking at timing and exercise in type 1 diabetes.
Yes, Dr. Muhammad, if there is any other question?
Yeah. So can I ask Professor Kaplan? Taking a skeptic kind of a stand about the long-term use of GLP-1 agonist, which is related to, number one, cost on the long term, number two, compliance. So some of the studies, like, for example, scale diabetes and pre-diabetes, in the extension of the trial, they lost about 50% of the patients. And remember, those people were getting the medications for free, if I'm not mistaken. So in your kind of setting, what are the compliance rate on a longer term basis?
So it is true that they were getting it for free, but they were in a trial. They didn't know how much weight they were going to lose. When you talk about the scale trials, we're talking about a much weaker GLP-1 receptor agonist than we see in the in semaglutide. And so there's a number of things that would cause me or anybody else to say, I'm not getting enough benefit from this to keep going, even though it's free. Then when you get to the real world and it's not free, it's very expensive, then you've got an issue of access, and you've got an issue of equitable access, which is really a problem for these newer drugs. But a few things are going to change. And I think that's what we really need to think about. One is what we saw in the STEP trials was that a lot of people lost a lot of weight. Again, remember, a third of people lost more than 20%. And what happened was that, what happens with these drugs is it lowers the amount of fat the body wants to have. What the body cares about is how much fat it has. It doesn't care whether it's hungry or not. It uses hunger as a tool. But if it wants more fat, it gets hungrier. If it wants less fat, it gets very much less hungry. And so what happened was these patients lower the amount of fat that they want on the drug, sometimes by as much as 25 or 30 kilograms. And then they had to take the drug away because it's the end of a trial. This is a trial of a drug that was not approved. So therefore, everybody had to have the drug or the placebo taken away. And a lot of patients complained viciously to the PIs that they were hungrier than they'd ever been. Well, of course they were, because they're now so much lower than their original weight, which was induced by the drug. But now they're lower than their original weight without the drug, so their body wants to regain all that weight. And what does it do? It gets extremely hungry, they crave. So what's going to happen is that's going to drive long-term use in the patients who do the best. The second thing that's going to happen, which I think is very important, is liraglutide is going to go off patent over the next few years. And there's a better drug, semaglutide, but the whole world can still use liraglutide. And liraglutide is still a good drug, not quite as good as semaglutide. And what we're going to be seeing is with tirzepatide and with cagrilintide and with danuglipron and all these drugs, is over time, we're going to see, as with every other field, there'll be generic ones, there'll be inexpensive ones, and they may not be quite as good as the very best ones, the Rolls Royce of drugs, but they will be available to large parts of the population. I want to emphasize, if a patient doesn't lose weight on a drug, they shouldn't stay on the drug. There's no value to that drug. All the drug is a toxin. But for those patients who, doesn't matter whether it's a drug that typically causes a lot of weight loss or a little, if an individual patient loses a lot of weight on the drug, that's the time when you keep it on. You don't do it just for the joy of it. You do it only when it works.
There is a maximum dose for GLP generally, because every time we see some of they change the maximum dose, like the dulaglutide, semaglutide being increased the doses. So
the reason that they changed the maximum dose is because they're developing it for obesity. In order to get the maximum effect for obesity, the drug has to get in the brain. That's what I was saying earlier in my talk. It doesn't work just on the pancreas. So therefore, you need a higher dose and you need a longer acting drug to be effective in the brain, because the normal GLP-1 that works in the brain is made in the brain. But the GLP-1 that's made in the gut doesn't usually get into the brain. It only lasts a couple minutes. It never has a chance to get in the brain. So these drugs, in order to get in the brain, you need a higher dose of them. And in order to get in the brain at enough dosing to actually have the maximum effect, you need a higher dose. The only reason there are two different doses is because one dose is as effective as necessary for diabetes. The other dose is needed for obesity. And of course, then there's all kinds of other reasons. There are economic reasons why they separate them, but that's a separate issue. But the reason there are two doses is because it does take more of the drug to cause the weight loss.
Yes, Mohammed.
Great. So if I take a hypothetical kind of question, that you have an identical twins and everything is the same. One is heavy and active, the other one is normal and sedentary. And we've had to talk about activity with no cover of the weight, and we have a talk about the weight as well. So which one of them is at high risk of complications in the long term? The higher weight and active or the lower weight and sedentary? Same risk factors.
I'm going to defer to Dr. Gill on this, or Jill. I don't know if you pronounce your name Jill.
Yeah, for diabetes complications, weight trumps.
Let's talk about metabolic complications.
Metabolic complications, weight trumps activity. So I think you're better off, despite being someone who's an activity person, you're better off being normal weight and inactive, I would say, than being heavier and heavier and active, I think, on average.
Can I add to that? This is a false dichotomy. There is nobody who can't exercise in some way, even if you're paraplegic. And so this idea that one has to be more important than the other is not clinically relevant. If you're a thin person and you don't exercise, start exercising. If you have obesity and you don't exercise, start exercising. Now, it would be nice if you have obesity with these newer therapies that we have to become thinner. But these are orthogonal. This is y-axis, x-axis. You don't have to, neither one interferes with the other one. So therefore, don't get into this sort of false debate. The important debate is, are you doing as much as you can be to make yourself as healthy as possible?
Yeah.
That's really what you ought to be doing.
Thanks, Dr. Kaplan. So I sometimes give that answer and saying that basically is diet more important or physical activity? And I say, look, the evidence is both together is better than either on its own. So you do both. I guess this is a slightly different question. So if your person is obese and active, will they gain more from also losing weight, or are they okay being active if they're obese? And I think the answer is they probably should try and lose weight as well. I think there's sometimes an argument that activity is the more important thing, that if you're obese, as long as you're active, you're okay. And I think the evidence suggests that's probably not quite the case. An obese active person is better off than an obese inactive person, but a normal weight active person is better off again. So I think you're absolutely right that doing both things together is important. And but the obese active person is doing something, they probably should lose weight as well to maximize benefit.
I agree with you completely, but I would say that we also have to remember, and this is an agreement with you, that most studies that look at lifestyle, particularly about exercise, are short-term studies. We don't know how long, so even then, so even to expand what you're talking about, we don't know what the long-term effect is. That's number one. And so you really do want to lose the weight on top of being active. Number two, we also recognize that there are more than 200 comorbidities of obesity. We focus on diabetes and all the metabolic ones, but there are many others that are not improved by exercise. All of the cancers and the metabolic are improved by exercise, but there are other ones that you need to lose the weight to fix the knees. You need to lose the weight to be eligible for a transplant for your kidney or your liver. You need to lose the weight for other things. So there's a lot of reasons why by being fit but still having obesity is only part of the solution. I'm just agreeing with Dr. Gill.
That's perfect. Dr. Iba, I have one last question regarding the use of the King's scale in the clinical practice. How do you incorporate it in your activities? This kind of a checklist going through complications, or how do you use this in your clinical practice?
So in every patient that we see, we stage them with A, B, C, D. So, and we have probably shown you in the beginning. So we would ask about airway, sleep apnea. So this is through, questionnaires. So it's either Epworth or the stop bank, depending on, where are you are. And then we have, you would measure the BMI in these people, so you would report it. And then with each, whatever we have put them on modality, so whether we put them on lifestyle or in combination or pharmacotherapy or surgery, you would see how they have moved across. So people who would have sleep apnea might have been resolved. So in every patient that we see, we would put them airway, BMIs, cardiovascular, diabetes, economical, F functional, and we have added more to it. So, health, do you see yourself healthy or not? What do you see when you see yourself in image, in the mirror? Then we have added to it junctional. So do you have a gastroesophageal reflux? We have K kidney diseases. So they have kidney stones, what's their EGFR? Then we added L as liver. So what is their stages in the liver? And then we added to it is M as medication. So every patient that I see in the clinic, we've put it all as a team, no matter who is in the team that's seeing these patients. And that's the easiest way to move through the modalities. And we have the scoring to it associated with it as well. So you can see it moves from 3, 2, 0, 1, and you can see how things has improved. And it's easy things to ask every member of your team, they can use it, and we see a benefit to the patients as well.
That's very good. Not sure we have any more questions. Dr. Abdurrahman, do you want to wrap up the session?
Yeah, I think thanks for all of you. Thanks for our speaker for very interesting, very informative session, and for all the discussion. Thanks for our co-chairman, Dr. Muhammad, and thanks for organizing a committee and scientific committee for selecting the speaker and the session, which is very interesting for all of us. Thank you for our audience, and I think we'll move to the second session, and we'll see you, inshallah. قريب بإذن الله. شكرا. Thanks for all of you.
Thank you for all attending, my colleagues, and thank you for MSD to give me a chance to be among my colleagues. Today, we will speak about the benefit of early initiation of DPP-4 inhibitors class, which is very important class in management of type 2 diabetes. And especially, we will highlight the role of sitagliptin in management of type 2 diabetes from the view of cardiometabolic risk reduction. Let's go to our agenda today. We will speak about some point about diabetes and the role of DPP-4s, especially sitagliptin, which is highly selective DPP-4 inhibitor, and the benefits over sulfonylurea and summary. Let's speak about cardiometabolic risk. Diabetes considered the major cardiometabolic risk and many factors contributing to cardiometabolic risk. If we can imagine that 85% of type 2 diabetes coming from obesity and overweight, and as well insulin resistance, which is highest in our clinic underdiagnosis, can lead to cardiometabolic risk. And also the life in the Gulf, especially sedentary lifestyle, physical inactivity, smoking, and because of the hot weather, the physical activity is very less. This all contributing to cardiometabolic risk, inflammation, and hyperlipidemia, and some genetic factors and family history, all contributing to increase the cardiometabolic risk and increase the global diabetes and the cardiovascular disease. And if we can see, the global burden of diabetes is very growing, and the incidence of diabetes suspected to be in 2045 be double, especially in some hot areas like Americas and Middle East and Africa. So if we can imagine in our Gulf, the first country worldwide in the prevalence of diabetes, Saudi Arabia, which represent about 25%, and our country in UAE, we have about 19% according to the latest data of prevalence of diabetes, which is big among our population. This is all due to the factor we mentioned before of lifestyle and genetics and environmental and obesity, overweight. If we can imagine about the ideal basis of type 2 diabetes. In the past, before the recent guidelines show to us the importance and the difference pathogenesis of diabetes, we are considered diabetes before as a one disease, very simple disease, hyperglycemia, simply, and management in the past is only blood sugar control, hemoglobin A1C reduction. But the recent view of diabetes now give us 4 bases to control our patient. Management of diabetes now, not only hemoglobin A1C reduction. Management of diabetes now is hemoglobin A1C reduction, weight reduction for obesity. As I mentioned before, 85% of type 2 diabetes happen due to overweight and obesity. Dyslipidemia management, especially LDL, and blood pressure control to be threshold for our diabetic patient, always blood pressure below 130/80. So if we achieve these 4 goals, this is meaning this type 2 diabetes management. So type 2 diabetes management is not only blood sugar control and the hemoglobin A1C target. There is other target for our patient for future and prevent the suspected complication in the future. So let's see every component individually, the benefit of weight reduction in type 2 diabetes. If we can imagine 1 kg body weight reduction associated with cardiovascular risk reduction, 6% in women and 3% in men, lowering both systolic and diastolic pressure by 1 millimeter mercury, improve the bad cholesterol, non-HDL cholesterol, and as well improve glycemic control. So this we can achieve from only 1 kg body weight reduction. So that's why in the guideline, they always motivate and recommend the weight reduction medication, or at least prevent the weight gain medication. So also the benefit of hemoglobin A1C reduction, we can imagine every 1% reduction in hemoglobin A1C, this can reduce the long-term diabetes complication 37% reduction of microvascular complication, 21% reduction of all causes of death related to diabetes, and 14% reduction in myocardial infarction. Also, blood pressure reduction as little as 2 millimeter mercury can reduce the risk of cardiovascular event by about 10%. Also, LDL reduction and major cardiovascular risk reduction, every 1 millimole reduction in LDL associated by 22% relative reduction in incidence of any major vascular event at 1 year, which is something very significant for our patient protection and for ideal treatment for our type 2 diabetes. So this is the pathogenesis of happen of diabetes, and there is a time zero of diagnosis of diabetes, which diabetes started by before the time of diagnosis. So beta cell decline of function and progressive nature of type 2 diabetes make type 2 diabetes and complication arises before diagnosis and ongoing by the course of disease due to pathogenicity and progression of type 2 diabetes. If we see here in this diagram, development of macrovascular complication start before diagnosis and development of microvascular complication start after diagnosis. So it's not a simple disease to deal with at the time. We can wide our screening for pre-diabetic and people liable to have diabetes to control them or prevent occurrence or delay the occurrence of diabetes, which can help our patient for not have the early complication as much as we can. So achieving the target control of hemoglobin A1C less than 7 in one study among type 2 diabetic patients, it becomes challenging in many countries, even advanced countries. This is in Europe and in very popular, it's called the Panorama in Europe country, about the achieving hemoglobin A1C on target less than 7. We will find many countries fail to achieve control. We have many countries, the maximum they can go for control is 40% of their patient to achieve target control of below 7. And this is due to many challenges in type 2 diabetes management and diagnosis and the clinical practice. The approach of treatment of diabetes in the past there is like symptomatic approach, which depend on we are intensify medication or change medicine and add another medication as intensify for our patient once the patient started to be symptomatic. And this is called failure approach. When we gave metformin, after failure of metformin and the patient started to be symptomatic, we go for second agent, and after second agent, patient failure and the patient started to become symptomatic, we change this. But the ideal approach, which is in the yellow line, it's hemoglobin A1C approach, which we are always keep change and intensify medication as early as possible, regardless of the patient's symptoms. We are only looking for hemoglobin A1C below 7. If the patient failed to achieve hemoglobin A1C below 7, we go for intensification as early as possible. And this can prevent the patient from future complications. So what are the challenges to achieve hemoglobin A1C in target? Education, motivation and support of the patient on self-management, adherence to medication and the complexity of medication, adherence to guidelines, personal feedback to healthcare professionals, and the effective use of information systems, and developing quality measure for diabetic management and to be patient-centered service for our patient. But the question here, always this is a very common question. What after metformin? What we will do after failure of metformin? When metformin alone is not controlling our patient and not get them to the target, what is the next? Here, according to the old guideline, after metformin, doctor is a decision maker. Like we are in the restaurant, you can choose the second agent according to doctor decision, no any recommendation. So you can go for your choice, like restaurant, you go for pasta, fish, whatever, like choices of medication. The doctor only is a decision maker and no special recommendation for the second agent after failure of metformin. But the recent guideline not give us the chance to make any other anti-diabetic agent to be added as a second line after failure of metformin due to many factors and due to study of the diabetes pathogenesis. And as I mentioned before, diabetes now management is not only blood sugar control. There is many other factors, cardiovascular factor, kidney factor, and weight factor, and many other factors. So that's why we will find after metformin, the line of treatment like GLP-1, SGLT2 inhibitors, and DPP-4 inhibitors, they have the greatest high recommendation of the green line because of the safety and achieving the all goals of type 2 diabetes management, including cardiovascular risk reduction and weight reduction and dyslipidemia management and blood pressure controlling, and have many function and many benefits for our patients. So the guideline now started to be recommend us according to the patient profile, according to cardiovascular profile, and according to safety for our patient, according to weight for our patient, not make more weight gain, which is lead to uncontrolling of our diabetes and pathogenesis of diabetes, and these all factors. And we will find here in the American Association of Clinical Endocrinology, in the monotherapy and dual therapy and the triple therapy, they put sulfonylurea at the bottom of the list. They are the least choices of medication due to the many side effects of sulfonylurea, as weight gain, as hypoglycemia risk, and as also pancreatic exhaustion and beta cell failure. So if we see the profile of anti-diabetic medication, we can find DPP-4 are very unique anti-diabetic agent because of their no side effect, maybe very minimal among all anti-diabetic, and no effect on the weight. There is no weight neutral, and also hypoglycemic risk is neutral, and cardiovascular and kidney also are neutral, except those adjustment in kidney disease according to stage of kidney disease, which we will highlight in our slide, which is the only DPP-4 doesn't need any adjustment in all stages of kidney disease is linagliptin. So here, as a class, according to American Diabetes Association, DPP-4 inhibitors, which is incretin enhancer, they have many advantages of no hypoglycemia, weight neutral, and very minimal disadvantage, which we not find in our clinic, mostly maybe every 2 years, 3 years, if you have simple case of any side effect, not like other anti-diabetic agents. Also, the mechanism of action of DPP-4 inhibitor enhances the physiological effect of incretin hormones, which improve islet cell function and improve as well glycemic control. And it have also improving incretin activity, which become prolonged, not degraded by intestinal lytic enzymes. So DPP-4 not only for diabetes control, not only for blood sugar control, we can think in the future, and there is ongoing studies about the benefit of DPP-4 inhibitors even beyond glycemic control. So it can help in inhibition of dyslipidemia. There is some helping in endothelial healing, prevention of atherosclerosis, and improve the vascular function. About selectivity between the classes of the molecules of DPP-4 inhibitors, we will find the sitagliptin, the highest DPP-4 molecule, have the highest maximum selectivity, 97%. We will find other agents like valdagliptin, allogliptin, saxagliptin, linagliptin, the selectivity of inhibition of DPP4 enzymes, they are less than sitagliptin. So the highest selectivity, it's in favor with sitagliptin, which give us good chance for controlling glycemic control and the benefits of DPP4 as a class. So here, according to FDA, sitagliptin, the first FDA approved DPP4 outside United States, and can be used as a monotherapy and combination therapy. Monotherapy for people have any side effect or contraindication to metformin. Sitagliptin improve pancreatic function and increase insulin production, and also in the liver decrease hepatic glucose overproduction, which working in independent glucose manner. Here also, incretin hormone concentration in healthy adult subject, when we add sitagliptin, it helps to increase the active GLP-1, and when we add metformin to sitagliptin, it will help more and more to increase the total GLP-1 and the active GLP-1, and as well active GIP. So this all helps the incretin activity, which is very important for the cycle of controlling blood glycemic control, and as well also the cycle of improving cardiovascular disease. As we know, there is some DPP4 inhibitors like saxagliptin before they have the risk of heart hospitalization due to heart failure. And after TICUS study, we have now proved that the class, the molecule of DPP4, sorry for screening this issues. So the molecule of sitagliptin have proved by TICUS study no increase in cardiovascular risk with sitagliptin versus placebo in high-risk subject with type 2 diabetes, according to the American Diabetes Association in 2015. So also, here our role as a physician to immediate treatment intensification to improve glycemic control in patients with type 2. As I mentioned before, in the slide of hemoglobin A1C approach and failure approach, the early intensification and the early control to target of hemoglobin A1C, regardless of failure and waiting up to failure and then intensify, this can help to delay and prevent the future complication of type 2 diabetes, which can make something good for our patient to prevent them and make the life expectancy for our patient better and better. And this is the rule here. If we have immediate intensification, have very good impact in hemoglobin A1C, and the delayed intensification also, this has become bad effect in hemoglobin A1C, regardless of this molecule we added, we not also cannot reach the optimum always because we are delayed in decision. So early intensification and immediate intensification can help to protect from type 2 diabetes complication as early as we can possible, and this is our mission. There is some clinical efficacy and safety of sitagliptin therapy in patients with not controlled on metformin alone. There is studies about sitagliptin and sulfonylurea, which is our today discussion. American Diabetes Association risk of hypoglycemia always is be considered in management of type 2 diabetes and hyperglycemia. And always hemoglobin A1C below 7 and not go to hypoglycemia with non-hypoglycemic agent always can reduce the risk and increase the life expectancy and not affecting the possible future complication of our patient. Here also the cost and the severity of hypoglycemia can make our health system and the health care resources utilization for our patient have many costs for us and burden for the economy of our, because patient always have healthcare professional visits and go to emergency according to the level of hypoglycemia, if severe, non-severe, or no hypoglycemia. If with no hypoglycemia, number of hospitalization less, number of healthcare professional visit less, and number of emergency visit less, which can save some of the cost and economy for our country. So to achieve this, we can help our countries and utilization of the healthcare system in our communities. So there is clinical trial of sitagliptin versus sulfonylurea. This, as part of clinical development program, sitagliptin has been compared in randomized controlled clinical trials of up to 2 years duration with glipizide and glimepiride. This one study addition of sitagliptin or glipizide in patient not controlled on metformin. So in one arm, there is glipizide, 5 milligram titrated up to maximum 20 milligram per day. And in other arm, there is sitagliptin, 100 milligram. And this is for 2 years. According to the same efficacy, along 2 years, the hemoglobin A1C, no inferiority or superiority for class over the other. They are similar in controlling hemoglobin A1C. No significance of any difference between the two molecules. So as the point of hemoglobin A1C reduction, they are similar in these 2 years survey. So as regard weight, body weight, there is more weight reduction in the arm not using sulfonylurea on sitagliptin, very significant. And as regard hypoglycemia, there is very minimal hypoglycemia in the arm of sitagliptin over sulfonylurea glipizide. So in glipizide, there is weight gain. In glipizide, there is more hypoglycemia risk. So according to age, using the glipizide and sitagliptin in age group more than 65 years and blue 65 years, both arms of glipizide, they have risk of hypoglycemia, even more than 65 years or less than 65 years. But both arms of sitagliptin in age group less than 65 and more than 65, they are at the same low risk of hypoglycemia. So this is another, I will go very fast because of the time, for comparison between sitagliptin and the glimepiride. Here, hemoglobin A1C, same control. No, they are same according to hemoglobin A1C, but also there is less hypoglycemic risk with sitagliptin and body weight reduction with sitagliptin in comparison to glimepiride, which have weight gain and more risk of hypoglycemia. And all in favor safety of sitagliptin over glimepiride as regarding hypoglycemia. So in this also study, with this study, there is comparison between sitagliptin metformin and sulfonylurea metformin. The number of patients continued medication and have good maintenance of medication with the arm of sitagliptin metformin is highest than people with sulfonylurea metformin due to hypoglycemia and weight gain. As regard hemoglobin A1C, as I mentioned, they are similar or maybe better in the arm of sitagliptin. There is little difference and significance of sitagliptin, but considered non-significant. So they are same as a control, but continuation and risk of hypoglycemia weight gain is more. Also in hypoglycemia and weight, in favor of arm of sitagliptin metformin, less hypoglycemia and more weight reduction, which is benefit our patient, as we mentioned about the benefit of weight reduction. So in comparison between DPP-4 and sulfonylurea, there is low risk of hypoglycemia in DPP-4. In weight, they are neutral or in some time weight loss benefit, and in sulfonylurea, weight gain and increased risk of hypoglycemia. So this is in kidney disease about titration and the dose of using sitagliptin versus the sulfonylurea. Here we can find, according to GFR, if GFR between 30 to 50, we can use sitagliptin 50 milligram, and blue 30 GFR, we use sitagliptin 25 milligram. What about the effect of hemoglobin A1C of 150 and 25 according to GFR? We will find very good, very impressive that 100 milligram once daily equal to 50 once daily as regard hemoglobin A1C reduction, equal to 25. This is in end stage renal disease according to kidney disease. For normal people or doesn't need to reduce the dose, GFR more than 60, no titration. Hemoglobin A1C same, even though we down titrate sitagliptin to 50 or 25, hemoglobin A1C becomes same with all these doses of sitagliptin, which is something unique to sitagliptin. Unlike linagliptin, which can give to all kidney disease, but by the same dose. Here we can give only 25 milligram of sitagliptin of end stage renal disease, have the same efficacy of the 100 milligram of sitagliptin, and as the same efficacy of linagliptin by the maximum dose of 5 milligram. So, but as also okay, our home message here to be sitagliptin potent selective DPP4 inhibitor once daily, one significant reduction in A1C, sustained A1C reduction, improve in multiple measure of beta cell function compared to sulfonylurea, sitagliptin, superior in improving beta cell function, and in comparison to sulfonylurea, it can have less hypoglycemia and more weight reduction, and less risk of hypoglycemia and more weight reduction. Once we choose our medicine for our patient to tailoring the art of management of type 2 diabetes, always we look to right drug in right dose, in right time, in right way. Thank you.
Thank you very much, Dr. Adel. Because of time, we need
Thank
to
you. Thank you.
Thank you very much.
Assalamu alaikum wa rahmatullahi wa barakatuh. It's my pleasure to be a chair of this sessions of the International Conference, the annual virtual Congress for the Diabetes and Endocrinology. Today is the first presenter here is Dr. Bashar Effendi. Dr. Bashar Effendi is the consultant endocrinology and head of endocrinology division, Tuam Hospital, clinical professor, Faculty of Medicine, Health Services in United Arab Emirates University. He graduated from Alibu University, Syria, and then he completed internal medicine internship and residency at the Lutheran Medical Center Research Institute, Brooklyn, New York. And he completed the fellowship in endocrinology and diabetes, hypertension, and metabolism at the State University of New York. He been appointed as a consultant endocrinologist since 2001. Dr. Bashar has been a member of multiple committees. I can just mention some of them. That is the member of the MENA Hyperglycemia and Pregnancy Guidelines Committee 2021, and the Diabetes Guidelines Committee, United Arab Emirates in 2001, 12, and 20. Member of the DAR, which is Diabetes and Ramadan Committee Guidelines in 21 and 20. He is a co-founder of the Emirates Endocrine Club and Al Ain Endocrine Club, past chief endocrine division of the at the Lutheran Medical Center Research Institute, Brooklyn, New York. He has multiple, more than 60 publications in the local and international diabetes endocrine journals. He is a member of many of local and international diabetes and endocrine societies. Professor Bashar Effendi is gonna talk today about challenging hypoglycemia cases. Please, Dr. Bashar.
Assalamu alaikum. Thank you, Mrs. Chairwoman. Good evening to everyone. My great pleasure to present in this meeting. In my talk, I will review the evaluation and management of hypoglycemia in non-diabetic adult patients. I have no conflict of interest in this presentation. I will discuss definition, classification, causes, evaluation, and management of hypoglycemia. And I have three clinical scenarios if time allows, because we lost some time, I could see that. So this is the most common presentation, a young lady with 3-year history of recurrent episodes of hypoglycemia or symptoms actually of sweating and palpitations for 3 years. And usually her symptoms are usually relieved when she eats or drinks juice. She was diagnosed last year as anxiety. Her BMI is 29. She has unremarkable physical examination, normal CBC, and normal thyroid function test. And the question now, what do you think is the most appropriate next step in the evaluation of this patient? Would you check her fasting blood glucose, insulin, and C-peptide? Would you admit her for a prolonged fasting test? Would you do a patient mixed meal test as an outpatient? Would you do the glucagon stimulation test? Or do you have any other preference that you would like to do? Just 1 second to think about it. And actually, the correct answer here is none of the above. Now, we get so many referrals like this patient, and according to literature, only 5 to 10% of these patients have true hypoglycemia. So before proceeding for evaluation of hypoglycemia, you actually must have to confirm hypoglycemia. To confirm hypoglycemia, patients should have the Whipple triad. They should have symptoms. They should have low blood glucose, confirmed one. And thirdly, they should their symptoms should be relieved after raising their blood levels. According to many international institutions, including the ADA, the ESD, and many other institutions, level of hypoglycemia are classified into level 1, when the blood glucose is between 54 and 70 milligram per deciliter, and level 2, when the blood glucose is less than 54 milligram per deciliter, and severe hypoglycemia whenever the patient has any altered mental status or they require assistance. Very important to know how individuals do respond to hypoglycemia. For example, when blood glucose is less than 80, the insulin level will start decreasing. And whenever the blood glucose is less than 60, then you have the glucose, the growth hormone and the cortisol actually will increase. And whenever the blood glucose is less than 55, then patients start getting symptoms. And at that time, insulin is completely suppressed. Also very important to know that lower blood glucose might happen with no sign and symptoms in many people. And as such, these people would not satisfy the Whipple triad definition. Now, symptoms of hypoglycemia are divided into 2 types, the warning symptoms, and these are actually related to sympathetic activation that include tremor, palpitation, sweating, anxiety, and hunger. And the real signs of hypoglycemia, and these are called the neuroglycopenic symptoms, and they are related to glucose deprivation in the brain. And these include confusion, difficulty speaking, dizziness, seizure, loss of consciousness, and coma. Please remember that recurrent hypoglycemia might impair hormonal counter-regulation. So patients will have less secretion of epinephrine and glucagon. Consequently, they might have more hypoglycemia and more dangerous hypoglycemia because of the hypoglycemic unawareness. We have a very long list of causes of hypoglycemia, including medications, malnutrition, sepsis, renal and liver and endocrine disorders, and post-bariatric surgery. Very important to remember here that pregnant women might also have lower blood glucose, especially those with lower age or lower BMI. They might have a blood glucose of less than 40 with no symptoms, of course. Again, we have a very long list of medications that might cause hypoglycemia, including most diabetes medications, heparin, aspirin, many hypertension medications, and antibiotics. Please review any medical reference for that. Very important to know these agents that might cause hypoglycemia. So when evaluating hypoglycemia, full history and physical examination are essential. History is very important, and that includes types of symptoms, timing of episodes, and relation to food intake. You also must review social and past medical history for that patient, and medications and over-the-counter supplements, very important. Only after confirming hypoglycemia and understanding the history for that patient, you could go for lab evaluation. Labs include CBC, kidney and liver function test, cortisol and thyroid function test. And at the time of hypoglycemia, we should check the panel of blood glucose, insulin, C-peptide, and proinsulin, and ketones bodies, and insulin antibodies. And we must check patients for the presence of oral hypoglycemic agents. Now, diagnostic workup include prolonged supervised fasting, which is the gold standard in patients with fasting hypoglycemia. You must admit these patients to the hospital. Usually, fasting should start after the evening meal, and you should hold all non-essential medications. Labs should be done every 6 hours. We should check the blood glucose, the insulin, C-peptide, and proinsulin. And when the blood glucose is less than 60, then we have to monitor these patients closely and check their labs every 1 hour. Please note, and this is really very important, that water and caffeine-free drinks are permitted during the test. And also, we should allow patients to keep active during the test. So we don't ask them for rest during the test. Now, when the blood glucose is less than 50, again, we check the whole panel with the ketones and we stop the test at that time. In special conditions, when we are considering other etiologies, we might check insulin antibodies, anti-insulin receptor antibodies, IGF-1, and plasma cortisol. Limitations of the prolonged fasting test include that normal subjects can have low blood glucose, again, pregnant women as an instance. Also reported false negatives, so these patients will have suppressed insulin in some insulinomas. And also reported false positive, that is high insulin in the presence of insulin antibodies. Very important to keep that in mind. Now, in patients who have reactive hypoglycemia, the procedure of choice is the mixed meal testing over a few hours, and that test should last for 3 to 5 hours. It should be done after an overnight fast, and patients should have a meal that is similar to what provokes their symptoms. We should get a baseline, then every 60 minutes labs for the panel I mentioned earlier, and whenever the patients have hypoglycemia, then we order the panel again and we check the insulin antibodies. Now, the three most important etiologies for hypoglycemia is exogenous insulin secretion. In this, we will have a high insulin, high C-peptide, and high proinsulin. Then we have the endogenous, low insulin, I'm sorry. And then we have the endogenous insulin secretion, in which we have high insulin, high C-peptide, and high proinsulin. And lastly, we have the entity with the oral hypoglycemic agents used, in which we have high insulin, high C-peptide, high proinsulin, but of course in the presence of oral hypoglycemic agents. Imaging is indicated when we're suspecting insulinoma or other tumors or pancreatic hyperplasia. These might include MRI, somatostatin, PET, or GLP receptor scans. We might consider endoscopic or intraoperative ultrasound in many cases, as well as selective arterial calcium injections. Now, what's the management of hypoglycemia? Now, surgical treatment is curative for many patients, including insulinoma, pancreatic hyperplasia, and other tumors. On many occasions, we might consider reversal of bariatric bypass in patients who have resistant hypoglycemia. Dietary treatment is also indicated, especially for patients with reactive hypoglycemia, and these will include frequent feedings, restrictions of carbohydrate. Sometimes you might consider severe restriction down to 2% only, then avoidance of high glycemic index foods and simple sugars, and the addition of protein in every meal. In addition to diet, we might consider many medications. For example, for reactive hypoglycemia, we should consider acarbose and GLP agonists. For patients with autoimmune hypoglycemia, we might consider prednisone. And for fasting hypoglycemia, we might consider diazoxide, calcium channel blockers, and somatostatin analogs. All of these will suppress insulin secretion. Let me now move to a few clinical scenarios. I have 3 scenarios. I'll try to do all of them. This is a 66-year-old lady who had 3 episodes of loss of consciousness within the past month. Each episode actually was preceded with blurred vision, palpitation, and sweating. Her consciousness was fully recovered after she was given glucose in the mouth by her relatives, and she reported no relation of these symptoms to her meals. She has a history of hypertension and history of bariatric surgery 4 years ago. Her baseline BMI was 55. She has a family history of type 2 diabetes, 5 patients in the family. They're all on insulin. And she had, she mentioned that she was not taking any prescribed medications. Her physical examination was essentially normal, and her labs, basic labs, were also all normal. And A1C was also normal. She admitted for evaluation. However, she refused prolonged fasting test. But within 24 hours of her admission, a patient developed symptoms of hypoglycemia, and that was about 3 hours after her breakfast. Labs during that episode revealed a glucose of 2.7, insulin level elevated of 31, C-peptide was elevated at 1.74, and high cortisol, as you expect, and she had negative sulfonylureas. So again, patient had high insulin, high C-peptide, high proinsulin, and negative oral hypoglycemia, hypoglycemic agents, and that is consistent with the endogenous insulin secretion. So what would you think as a second step for this patient? Would you check her insulin antibodies? Would you refer for MRI or PET scan? Would you review her medications that she denied taking any medication, prescribed medications, and review her drug history? So simply, yes, always you have to review other drug history and other supplements that she might be receiving. And in fact, this patient, when we reviewed her history further, she was actually taking this supply of Mancudo, which is considered as antioxidant, but also is used in Southeast Asia as an anti-diabetic medication. So the diagnosis for this patient was mainly herb-induced hypoglycemia. However, probably her bariatric surgery history complicated her symptoms. Management was straightforward. You stop herbal medications, you start diet instructions, and we started acarbose for her. And within the next 48 hours of admission, patient had no recurrence of hypoglycemia. And now, 3 months after the fact, she had no hypoglycemia at all. Let me move to the second case. This is a 67-year-old lady. She has diet control type 2 diabetes, hypertension, hyperlipidemia, reflux. She had idiopathic hypercalciuria and kidney stones. Her medications include indapamide SR 1.5 milligram daily, losartan, atorvastatin, clopidogrel, and she was not on any oral hypoglycemic agents. 2 weeks before this presentation, patients started having episodes of hypoglycemia 2 to 4 hours after meals, blood glucose of less than 50, and she was referred, she was seen in the ER twice and confirmed hypoglycemia at that time in the emergency room. Her lab evaluation confirmed normal UEG, GFR normal, TFTs and LFTs are normal, and her A1C was 6.1. Using flash glucose monitor and also using the meter showed multiple episodes of hypoglycemia. We admitted her to the hospital, and during admission, she was kept fasting after her dinner for 60 hours, and she did not have any hypoglycemia at all. However, when fast was followed by a mixed meal of her choice, patient had a blood glucose of 306 1 hour after that meal, and that was followed by a blood glucose of 2.7 4 to 5 hours after that meal. Labs done during her symptomatic hypoglycemia showed blood glucose of 2.7. Insulin level was very high, 2000. C-peptide was minimally high at 1.7. She had negative ketones. Additional testing confirmed that she was not taking any oral hypoglycemic agents. Now we repeated her labs on the next morning, and her blood glucose after breakfast was again elevated, impaired glucose tolerance, but her insulin was really very high at that time, almost 3000. And again, her C-peptide was not that elevated, only triple the normal range. She had high proinsulin, and her, again, proinsulin was elevated. So she had the summary, she has hypoglycemia, very high insulin, and slightly elevated C-peptide. Now, if you look at this carefully, again, very high insulin level, C-peptide minimally elevated, and if you carefully follow this, you will find that only endogenous insulin and only insulin antibodies that cause this picture of all of these are elevated with no oral hypoglycemic agents. Now, very important point here, and that was the ratio of insulin to C-peptide. Normally, the C-peptide ratio, the insulin to C-peptide ratio is 1 to 5 or even 1 to 15. And that is due to the fast removal of insulin during the passage through the liver. The ratio is 1 or less actually in insulinoma. And however, the ratio usually is reversed and greater than 50 in the presence of insulin antibodies, because the presence of insulin antibodies will keep the insulin in the system, in the circulation for a long time, and it will not be cleared. So we checked the insulin antibodies for this patient, and they were actually very high. So the diagnosis for this patient was insulin autoimmune syndrome after exposure to clopidogrel. Review and history, her history showed that she started this 1 week back before this presentation. Mechanisms of insulin autoimmune syndrome in these patients actually is the sulfhydryl group that interacts with the insulin itself, and it makes it immunogenic. Usually during fasting, the insulin antibodies are available. They're not fully occupied. So when meal is given, then the insulin secretion will increase, and all the extra insulin will be bound to the insulin antibodies, causing postprandial hyperglycemia, because this insulin is ineffective at that time. However, later, whenever we have more insulin and all sites on the antibodies complexes are saturated, then we will have a sudden release of insulin and the development of severe hypoglycemia. Management of these patients will depend on discontinuation of the offending agent. a low carbohydrate diet, and medications that include acarbose to treat the reactive hypoglycemia, but also glucocorticoids. For our patients, you could see here, we stopped the clopidogrel and we started prednisone treatment. Within 48 hours, patients did not have any more hypoglycemia. We, over the past few months, we tapered hair steroids slowly. Over 7 months, insulin and C-peptide went down to normal slowly, and we had negative antibodies in October here. We started in March, and she had no recurrence of hypoglycemia at all. So the conclusion for this case is very important. Insulin antibodies should be actually considered in patients with high insulin and hypoglycemia, especially if the ratio is reversed. Very important to review the ratio of insulin to C-peptide, and very important because in this case you could prevent further evaluation, costly and probably unnecessary dangerous surgery. Let me now move to the third case, last case. This is a 76-year-old man, history of hypertension for 5 years on ACE inhibitor. He has a 3-month history of episodes of sweating, anxiety, and tremor, also visual complaints and dizziness. All disappear after drinking juice. Reviewing his medical records, actually, this patient had a car accident 4 months ago, and in that admission in the emergency room, his blood glucose was 2.4 millimole. His physical examination and labs are basically normal. After 12 hours of fasting, prolonged fasting we attempted, he had a low blood glucose of 2.2. His insulin was 222. C-peptide was also elevated. Proinsulin was elevated. And he had negative ketones, high cortisol, and negative sulfonylureas. He denied taking any herbs or, again, no oral hypoglycemic agents. And again, if you review this, this is actually, again, consistent with endogenous hypoglycemia. We referred this patient for an MRI, and the MRI confirmed a 1 centimeter mass in the tail of the pancreas. We did imaging study. We used the gallium dotatate PET scanning, and that also showed a 1 centimeter, same location, avid area with uptake. And also very nicely and very important, this PET scan showed a 6 centimeter lipoma that should not require any further evaluation. Patient was referred for surgery and had total pancreatectomy and splenectomy. And right after surgery, patient did not have any recurrent hypoglycemia. However, 6 months later, he developed type 2 diabetes. So my summary and conclusions, Mrs. Chairwoman and ladies and gentlemen, the Whipple's trial should be satisfied to make a diagnosis of hypoglycemia. Loss of consciousness is highly suggestive of an etiology, a serious one. Elderly people have fewer symptoms of hypoglycemia when you compare to younger people. Careful history, physical examination, and basic lab evaluation can probably identify most common causes of hypoglycemia. Testing should be done at the time of spontaneous hypoglycemia, and if that is not possible, then we should attempt prolonged fasting or mixed meal test. And that is my last slide. These are my references. Thank you very much for listening. Thank you.
Thank you very much, Dr. Bashar, for your presentation. Please stay with us till the end of this session, and we will have the questions later on. So our next speaker is Professor Andrew Bolton. Professor Andrew Bolton is the Professor of Medicine, University of Manchester, and consultant physician in Manchester Hospital. Professor Bolton is a graduate of Newcastle upon Tyne and subsequently trained in Sheffield and Miami, and then he been appointed at Manchester University. He authored more than 550 peer-reviewed manuscript and book chapters, mainly on diabetes lower limb and renal complications. Among his many awards, he was received the ADA Roger Leadership and the European Association of Study of Diabetes Camillo Prize, and was the first recipient of the International Award on Diabetic Food Research. He was the 2008 winner of the ADA Harold Rifkin Award for Distinguished International Service in Diabetes. He received in 2012 Georgetown Distinguished Achievement Award in Diabetes Limb Salvage. He is the founding chairman of the Diabetic Food Study Group and was previously the chairman of the Postgraduate Education and then the Honor Secretary Program Chair for the European Association of Study Diabetes. Until late 2015, he was the president of the ISAD. Currently, he's the president of International Diabetes Federation, IDF, and the chairman of the EURADIA, European Alliance for Diabetes Research. He's going to talk about the diabetic food, the modern treatment, and the use of smart technology. Please.
Thank you very much for your generous opening. It's a pleasure to be with you. I speak to you from the north of the UK, and it's actually a rather warm, sunny day, and most unusual for this time of the year. It's even 21 degrees today, somewhat cooler than Dubai, but there we are. So, the Americans, the term PITS means it isn't too good, but I would put to you that diabetic foot care is the PITS, and it should be better. And the PITS can stand for prevention, identification, treatment, and service. So I'm going to go through some of these factors. We know who is at risk of foot ulceration from a number of prospective studies, many of them done by my group here and also in Miami. The most at-risk people for foot problems are those with diabetic sensory motor neuropathy and autonomic dysfunction, leading to dry skin, lack of sweating, and increased blood flow in the absence of peripheral vascular disease. The common, of course, if you've had a foot ulcer, you've got a very high risk of getting another one. Indeed, the risk is as high as 30 to 50% per year. Patients on dialysis are very much at risk, and with other microvascular complications. And obviously, if you've had a previous amputation, you're at risk of a foot problem on the remaining foot. Now, it was Dr. Paul Brand, working in India in leprosy, who said quite rightly that you do not need expensive equipment to diagnose the high-risk foot in diabetes. And as I mentioned in my talk yesterday on neuropathy, it is the words of Dominic Corrigan, famous Irish physician. Corrigan signed the collapsing pulse of aortic incompetence. He said that the trouble with most doctors is not that they do not know enough, but they don't see enough. They look, but they don't see. All you need to do is look at this foot to see its high risk. Prominent metatarsal heads, callus from the dry skin and high pressure, pes cavus, clawing of the toes, dystrophic nails, and some small muscle wasting. I rarely show complicated slides. This is the most complicated I will show this evening. Diabetes leads to somatic neuropathy with loss of pain and proprioception, but also motor dysfunction with small muscle wasting in the feet and an imbalance between flexors and extensors. Somatic neuropathy, motor neuropathy I've mentioned, autonomic neuropathy, as I've already said in the picture, decreased sweating, altered blood flow, it's increased due to sympathetic dysfunction, sympathetic nerve dysfunction, leading to the distended the distended foot veins you see on the foot, the warm but insensitive foot with distended foot veins, the sign that we described back in 1983. The dry skin plus high pressures leads to the dry skin, the callus. The callus itself can cause ulcers. And the green circles demonstrate where patient intervention, self-foot care can help. Examining the feet daily, for example, down here on the bottom left. And up here, moisturizing the feet with moisturizers, regular foot care. You've got good podiatry in the Middle East and well-fitting shoes. The commonest cause of foot ulcers in my country is shoes that are inappropriate for the shape of the foot. In other countries, for example, in India, walking barefoot can be very important on the hot ground. And of course, if someone does develop a foot ulcer, it's always a good idea to where the offloading device you're given. So one key question is this: does education alone reduce the incidence of first foot ulcers, for example, in those with high risk due to diabetic neuropathy? And sadly, I cannot prove that it does, even though inherently we all educate our patients in self-foot care. Here's a systematic review from Utrecht in the Netherlands from Dorstein and colleagues. And this concluded that there was insufficient robust evidence to support education alone to prove that this worked in reducing ulcers. Too few trials, poor study design, insufficient numbers, and duration of follow-up. But we should interpret this not as evidence of no effect, but lack of good evidence. Here's another study from the UK, this time a systematic review, again suggesting that there is insufficient robust evidence to support population-based foot screening. We should be screening our patients with diabetes every year, and those with high risk require podiatry and further education. So if you've had a foot ulcer, does education reduce the incidence of getting further ulcers? Sadly, there's no evidence that it does. Here's a study from some friends of mine from Nottingham in the UK, and the patients of newly healed neuropathic foot ulcers were randomized to two groups. One had intensified education, group discussion, hand-to-hand, face-to-face interviews, discussion, how they should look after their feet and so on. The others were randomized to usual care, a handout, look after your feet, if you see a problem, come to the clinic. Now, although those who had the intensified foot education, the intensified group, reported better foot self-care, there was no, sadly, no evidence that this led to ulcer or amputation reduction. Now, I would put it to you that these people, their physical dysfunction is too great for education alone to work. So we need education plus something else. Now, smart technology is helping us in two ways, in measuring pressures and loads under the feet and foot temperatures. Now, that foot pressures are important in the neuropathic foot were confirmed by numerous studies, many of which I did when I was in Sheffield and later here in Manchester. My colleague, Aris Bevis, a Greek fellow who's now professor of medicine at Harvard, and Murray, we've shown in numerous studies that high foot pressures lead to breakdown under the high pressure areas, the metatarsal heads, in insensitive feet. And we know that plantar callus, the hard skin, is associated with high pressures and cause ulcers, but removal of callus can reduce risk. Now, nothing is new in medicine, and here's the late Dr. Paul Brandt, nearly 60 years ago, working in leprosy in India and later in the United States, with very primitive transducers measuring pressures under the neuropathic foot. And he said that pressure is the critical quantity that determines the harm done by the force. Now, today, of course, we've got sophisticated ways of assessing pressures and loads under the feet. And this is like the mountains, as you see, for example, if you fly from here over Germany down to Italy, you cross the Alps and you see these peaks. These are the peaks of high pressures, which we see in many patients with neuropathic feet. Here's a Charcot foot with high pressure under the cuneiform metatarsal area here. And you see the high pressures under the foot, and these are at risk of breakdown. So we did a study recently published in Lancet Digital Health 2 years ago, that we assessed novel plantar pressure sensing smart insoles, intelligence, if you like, to reduce the foot ulcer incidence in high-risk patients with a history of ulcers. And this was done with my very good friend and research colleague, Professor Neil Reeves, from the Manchester Metropolitan University, which has a fantastic GAED laboratory. Now, we know, as I've already told you, that diabetic foot ulcer risk is high foot pressures plus loss of sensation. And pressure is a laboratory measure, but the concept that we can use pressures measured in the shoe to feed back to the patient started about nearly 20 years ago. And some big studies were done in Switzerland and other places. So what we aim to do is to investigate the efficacy of pressure sensing smart insoles for reducing diabetic foot ulcer recurrence. And this is the insole that we used that had in here a number of pressure sensing devices that could feed back wirelessly to a wristwatch that didn't actually tell you the time, but it gave you a pressure contour of the foot. It would demonstrate high foot pressures in red, and the wristwatch would vibrate if the patient, when walking, was putting very high pressure under a particular area. And the endpoint, of course, was a plantar ulcer. And those who had the feedback and those randomized to an active insole were advised to alter their gait or to rest. And they could follow that by looking at the wristwatch to see if that color the red color actually went away. So this simple device led to a foot ulcer reduction in the active group, in the who had been randomized to the insoles that fed back to their wristwatches. This was a randomized study. It led to a big ulcer recurrence that was significant, and even higher in those who actually were very compliant in wearing the insoles and the special shoes all the time. Overall, the study ulcer rate was low, as one sees when you do a study, because patients that tend to be more adherent. But the mechanism is pressure offloading, and this is patient empowerment. So here we have pressure that can be used as feedback to the patient during their normal day-to-day activities and walking. So the other thing we can measure is temperature. And again, I go back to Paul Brand, working at this time in India, in Vellore, the Christian Medical Center, in Karigiri in Tamil Nadu, and later in Carville, the United States Leprosy Research Center in Louisiana. And he said that infrared thermography, in other words, assessing temperatures under the foot, contributes to the care of the insensate limb. It can detect through heat areas of irritated skin prior to breakdown. And therefore, if you spot a high temperature, you might be able to stop the injury before it occurs. And this was from his paper. Here's a thermogram, and this patient could well have been lying on a surgical ward. The patient had neuropathy and the feet weren't being turned, and you see a hot area over the heel. And there's no doubt that this is at risk of breakdown. But what his study showed was the foot warms up before it ulcerates. So one can ask the question, if nerve damage and mechanical stress leads to inflammation, and this leads to breakdown and faulty healing ulcers and could go worse, can we do something to stop at this stage by identifying the foot likely to break down before it actually does, by looking at the temperatures? And here are 3 studies, but just look at the middle one by my friend in Dallas in Texas, Larry Lavery. And this was a study done in patients with a history of foot ulcers, mainly Hispanic patients from South Texas. They were at high risk of developing recurrent ulcers. They had neuropathy with a previous plantar ulcer. And they were randomized to one of 3 groups. The structured group, let's start with the standard group here. These patients, was pretty good care. They saw a podiatrist every 2 months. They were given good shoes, and they were given advice on checking their feet every day, and if they see something, to report to their podiatrist. And they were told what to look for. The structured group had all that, but they were also given a mirror. And being in Texas, patients were rather large, and many people couldn't examine their feet. So the mirror was on a long stick, so they could actually examine under their feet each day. And they were told if they see anything suspicious to report to their podiatrist. The third group was given all this, but they were also given a self-temperature monitoring thermometer. And they measured their foot temperatures comparatively between the 2 feet. And if they were more than 3 degrees Fahrenheit, or I think it was 3 to 4 degrees Fahrenheit warmer than the other, they were asked to rest and go and see their podiatrist. Well, the results were pretty startling. The standard group and the group with the mirror, they had 1 in 3, just under 1 in 3 patients ulcerated in that period of follow-up of 15 months. But the ulcer rate was significantly reduced, as you see here. In the enhanced group with self-temperature monitoring, the recurrence rate was less than 10%, compared with about 1 in 3 in the other 2 groups. So education plus an intervention such as self-temperature monitoring can be efficacious in reducing recurrent ulcers. Nowadays, we have smart mat technology. And here's a study by my good friend Rob Freiberg from Phoenix, Arizona. And in this study, they used a smart bath mat. It's like a pair of scales, but this fed wirelessly by Bluetooth to a central monitoring area. So when the patient stood on this, they could measure the temperatures and see if there was any difference. Now, this was just an observational study in 132 patients with a past history of ulcers. There was no intervention because they had to prove that it worked. We had daily foot temperatures were assessed remotely and plantar temperature asymmetries were analyzed. Over 1 in 4, 29%, had foot ulcer episodes, and one could have predicted the development of these ulcers by a 2.2 degrees or more asymmetry between the foot that ulcerated and the contralateral foot, suggesting that prediction and prevention can be possible. And there are now randomized studies ongoing. So times are changing, as they say in America. What the traditional method is, seeing a patient in the clinic, prescribing drugs, orthotics, whatever, education, assessment of the feet, giving shoes, and so on. But now we've got the spectrum of remote management, where wireless device, we can have remote monitoring of blood pressure, glucose, lipids, remote consultations, which of course have accelerated during the pandemic, remote foot pressure monitoring for pressure, temperature, and pre-ulcerative lesions, as you see here. Remote fitting of shoes with offloading and feedback if the offloading is good, and so on. So the solution may be continuous foot monitoring systems to prevent diabetic foot ulcers, a real-time sensor-enabled wireless device for the diabetic foot. So the smart technologies are thermography, such as this, foot temperature, a smart thermography mat, measuring patients' temperatures, and now if the podiatrist or whoever sees asymmetry, you can call the patient and say, look, this foot's at risk of ulceration, you need to rest, stop walking, and so on. And these temperatures studies are ongoing, and we also have continuous plantar pressure monitoring. So see it, save it. The patient can now see their feet through a smart device, through an app, and look at the pressures and loads under the feet, or they can have this pressure stat, which we've shown to be very effective in assessing high pressures. You can give that to the patient. The darker areas are dangerous, dark is dangerous. That's the area to check under your foot. Seeing is believing. Here's one of the devices that can be used at home, like a bath mat, but this feeds back to the patient. They can see their foot, this hot area here, and this can be transmitted to the patient's cell phone. That this is helpful. This is American humor. I apologize for it, but success is, they're saying, a success because these people have developed smart socks, and they won the Consumer Electronics Show prize of $50,000 for the best invention. And they have smart socks that the patient can wear and can feed back and tell them the temperature, and can look at a temperature differential and identify a pre-ulcerative lesion. So there's a lot of work going on in this area. But I'll leave you with a few quotes of Edward Wilson, who said, "You teach me and I forget, you show me and I remember, but you involve me and I understand." So now patients can be involved in their own foot care using smart technology. Lastly, I'm going to spend a few words about new treatments. I'm running out of time because I've got another engagement in 5 minutes, but let's talk about treatment. We know that a diabetic foot ulcer should heal if there's good arterial inflow, if infection is aggressively managed and pressure is removed from the margin. We're least good at this. But there's been a renaissance in diabetic foot care with new treatments from studies, from articles, reviews saying this is how we should be doing trials, proper randomized controlled trials. Let's have an evidence-based approach. We have the Luca patch system, which has recently been reported, and this is bedside centrifugation without any additional reagents to generate a disc of the patient's autologous leukocytes, platelets, and fibrin. And then you put this plug into the ulcer. And this trial showed faster healing in difficult to heal ulcers. Then we have this other sucrose octasulfate dressing. This is a dressing that's been shown in a randomized controlled trial to be beneficial for neuroischemic ulcers. So we are now having evidence-based medicine to help in our management of diabetic foot. Hyperbaric oxygen has not been shown to be useful. It's rarely used apart from in the United States, and most randomized controlled trials have not supported its use. But now We're having evidence for topical oxygen. They're not all the same, but they're all showing improved results. And here's a result just published again by Freiberg and colleagues: cyclical topical wound oxygen, TWO2 for chronic diabetic foot ulcers, a randomized controlled trial that shows that those who were randomized to topical oxygen, wound oxygen therapy, had superior and faster healing. So there are new treatments on the horizon. Lastly, infection. We still use clinical definition. Here's a Charcot foot. I think there's no doubt in anybody's mind or eyes that this is infected, an abscess under a Charcot cuneiform metatarsal joint here. We use the usual signs of infection. And remember that antibiotics are overused. They're not wound healers, growth promoters, household cleaners, scalpels. If there's pus, let it out and treat when there's clinical sign of infection. Here's a randomized controlled trial from Spain that showed those with local osteomyelitis do just as good on antibiotics than with local surgery. And here's a very important trial published a couple of years ago, showing that intravenous antibiotics are not superior to oral antibiotics in osteomyelitis. And these are going to challenge the current standard of care, these trials. So, although the incidence of foot ulcers continue to increase, major advances have occurred. We can aggressively treat infection. We've got now new technology for a revolution in home-based diabetic foot care, and we've got therapies that have been proven in randomized controlled trials. So remember from the Bible here, before you speak, learn, but before you fall ill, take care of your health. So we can prevent foot ulcers. We can engage the patient much more. And lastly, as last night, I'll remind you of the International Diabetes Federation Virtual Congress, which is occurring this December on diabetic complications, COVID-19 and diabetes, but also the launch of this year's IDF Diabetes Atlas that tells us the up-to-date prevalence and incidence of diabetes across the world. And we have a symposium to celebrate 100 years, in fact, this month, since the first animal was injected with insulin in Toronto in 1921. So thank you very much for your attention. Shukran.
Thank you very much for a very interesting and topic, and with the updated technology for diabetic foot. I'm sorry to keep you late, but if you have to go because you have another commitment, maybe
I can take one or two questions if you wish.
Okay, so I'll see if there is a questions. Well, I don't have questions so far. So
I must have given all the answers then.
yeah, mostly it's been answered. So I don't have, really, I don't have questions right now. So thank you very much. But anyone is interested, maybe we'll send these questions later on to you. Thank you. I do appreciate, and this is our honor to be with us in this session.
Always a pleasure. I wish I was with you in Dubai. It'd be a bit warmer.
Well, I'm in Saudi, but we'll be good.
Well, warmer there too, yeah. My son used to teach at the Brighton College in Abu Dhabi for many years, so I know the area very well.
Oh, okay, it's our pleasure. Maybe because I'm representative of the society, Saudi Society for Endocrinology and Metabolism. So we will have meeting next year. We'll try to make it in person rather than virtual.
It's always nice to meet and share with colleagues experiences, clinical vignettes, and just to see people.
Sure.
Okay.
Thank you. Thank you. Goodbye. Goodbye.
Good night.
Take care.
Goodbye.
Okay.
Thank you.
Bye.
Dr. Bashar, I think I have a question. Did you answer the question that we have it here?
There was one I answered. There is another one. I don't know the answer.
No, the first one, it's not for you, I think for the satellite meeting. But there was other questions before, maybe in the chat, that is the reactive hypoglycemia. Is it by exclusion, or do we have to do something with this? I think I read it in the chat earlier.
Yeah, I mean, reactive hypoglycemia is low blood glucose after meals. So, I mean, usually we depend on history, full history. Then we might use the mixed meal for that. I know it's very hard then to figure out what's the cause of reactive hypoglycemia. So again, history is the most important thing there. Causes of reactive hypoglycemia, very complicated.
So I think there is no more questions. So we will conclude our session today. It was a pleasure to have you here. Thank you very much, and hope to see you in another meetings. Okay.
Thank you, Doctora. Assalamu alaikum. Assalamu alaikum.
السلام ورحمة الله وبركاته. الله معك. مع السلامة.
Good evening, everyone. Thank you for being here tonight. I'm Dr. Haifal Faraidi, a pediatric endocrinologist from King Abdullah Specialized Children's Hospital in Riyadh. And it's my pleasure to introduce to you today Professor Karine de Beaufort, a consultant in pediatric diabetes and endocrinology from the Centre Hospitalier de Luxembourg. She's also president of the ESPAD. Professor de Beaufort completed her MD and PhD in 1986 in Rotterdam, Netherlands. She then completed her pediatric training in the Netherlands, Luxembourg, and France in 1993, followed by training in pediatric endocrinology diabetology in 1999. She also completed a university DU in public health in 1988 in Nancy, France, and participated in the Eurodiab Diabetes Registry. Professor de Beaufort participated in the creation of the multidisciplinary team, the DECCP, for the care of children and adolescents with diabetes in Luxembourg, a dynamic and international team. They've been recognized as a center of reference for pediatric diabetes, as well as a member of the European Reference Network for Rare Diabetes. She received several research grants from the EU, interregional and international funding structures. Her research topics include epidemiology, technology in diabetes care, and the pathogenesis of type 1 diabetes. She has more than 140 publications in peer-reviewed journals and several chapters in books. Between 2012 and 2016, Professor de Beaufort was the Secretary General of ESPAD, and in that function, she was able to meet with many colleagues and patients around the globe, working on improving access to care and quality of care for young people with diabetes. It's our pleasure to have you here with us today, Professor de Beaufort. You'll be speaking to us about the use of technology in youth with type 1 diabetes. Professor, the floor is yours.
Dear colleagues and friends, first of all, I would like to thank the organizers of the meeting to invite me to give this presentation on the use of technology in the treatment of young people with diabetes. I'm Karine de Beaufort. I'm located in Luxembourg, Europe, and I'm a pediatric endocrinologist. I have no specific disclosures except my participation in the e-learning board for the Medtronic. Now, what would I like to address in my presentation? First of all, current situation, type 1 diabetes treatment in young people. And for that, I'll show you some of the data of the SWEET registry. And then, of course, as well, the use in that population of technology. Finally, I would like to address the patient perspective. What are the ideas and the expectations of people with diabetes when they talk about technology, and what do we hope to achieve? Very important, I think, is to remind ourselves that we've got one treatment target in all age groups at all moments, which is a good metabolic control. ESPAD currently recommends an HbA1c below 7%, 53 millimolar per mole. The WHO target is slightly higher. At least the objective is to meet this target in at least 80%, having an HbA1c below 8% or 64 millimolar per mole. Of course, this needs to be associated with a normal physical and psychosocial development, a good quality of life, and all in order to prevent acute and late complications. It's a package deal we need to go for. And essential for this is, of course, to have access to insulin, but as well to strips and to education to use it. I mean, you have to know what the insulin is doing, what the insulin you use, what the profile is, how long is it acting, and you need to know what you're eating. Carb counting is a fixed part of our current treatment approach in our education. And there are so many different things interacting with the effect of the insulin, be it stress, physical activity, intercurrent illnesses, hormonal changes, etc. Now, if you look at the use of technology in different pediatric age groups, and let's start with the smaller kids, the younger ones, you have to realize that for them to really obtain good metabolic control is extremely tough. And here I'm talking about the preschoolers, say kids below 6, 7 years of age. They've got small insulin doses because they're tiny, which means shorter duration of insulin action. The injection sites are just age appropriate, which is small. Remission phase doesn't last very long in the younger kids, and they are very sensitive to insulin. So modification of half a unit or a unit may really have already an impact. And as parent, I think we are all aware of how important it is to have an overnight sleep. And if that one should be over a certain number of hours, let's say 8 to 10 hours, it's very difficult to cope without technology, an appropriate effect of insulin during that time. Short action duration because you've got a small dose. Furthermore, the lifestyle of young kids is very unpredictable. They'll go playing where you don't expect them to, and they'll eat when you don't expect them, or they won't eat when you expect them to. And then we have the frequent intercurrent infections, either by daycare or just by their common environment. So in this population is very difficult to obtain a good metabolic control with injection therapy. Now, school children and adolescents are another population, but we're faced there as well with a number of problems in obtaining or meeting our target of an HbA1c below 7. These unpredictable hypoglycemia, some of them have been solved, I think, by analyzing our continuous glucose monitoring profiles, but some still occur when we wouldn't expect them. Huge hormonal variations, sexual hormones, growth hormone, early morning values frequently going up because you cannot increase the dose more without risking hypoglycemia around 3, 4 o'clock at night, which means that they've got high values in the morning. Extremely important in this age group is, of course, the role of the peer population. Their influence on lifestyle is highly important for young people and will exist whether we want it or not. This and hormonal changes very often leads to a change in metabolic control. And despite efforts, they really are doing efforts, might not always result in what we are trying to get. And this has an influence. I mean, if you continuously have a roller coaster blood glucose profile, you feel tired, you feel grumpy, you feel not the way you would like to feel. And then you get a discussion at home, you get a discussion in the clinic, fed up with bad results, make you sometimes just turn a page and say, I can't be bothered with it now and here. It is too difficult. And then, of course, on the other hand, because of physical symptoms, they sometimes may not be able to participate in the peer-related activities. And let's not forget, everybody is different. And here you've got a fantastic picture made during the Dawn Camp years ago by the group in which Karen Lange, psychologist in Hanover, participated. These are all different characters. We need to individualize. So I think there are a lot of challenges we are faced with when young people need to meet targets. Now, what's the current situation if we use different kind of therapeutic approaches? I don't know whether you're aware of the SWEET registry. This is a global registry, and all the dots represent centers somewhere around the globe who are participating and submitting their clinics' data in order to receive the report with benchmarking possibilities to compare your outcome, your treatment approach with those in the different other countries registered on this map. And you can see it's really a global registry in high income, middle income, and low income countries. We now include over 80,000 patients in this registry. And here you can look at it afterwards, but definitely not if you would see it on a full screen. We would have between 12 and 18 years, around almost 19,000 persons. We've got data between 18 and 25 years, which as well belongs to, I think, young people, more than 6,500 and almost 1,600 in the population above 25. So it's a large number of people, and the data which are included are real live data. This is not an intervention or something specific. It's just the data of all these clinics together. And here you would have the metabolic outcome, and you can see that meeting targets, meeting ISPAT targets is still very limited. Below 7, we've got about 25% in the 0 to 18 years. And from that percentage, it's not most often seen in the population between 12 and 18 years. It's only 22%. And 25% is over 9 with this HbA1c. So no, we're not good enough as clinicians to support and educate the young people to obtain and meet treatment targets. Now, does the pump influence? Here you see in the same population the outcome when people are using a pump or are not using a pump. And again, you can see that the percentage of young people using a pump between 12 and 18 is almost 29%. And there is a difference in HbA1c with or without a pump. Now, again, it's not yet meeting target, but there is a tendency to a lower value. And the same goes if you look at the population between 18 and 25 years. Above 25 years, treatment targets kind of approach what we really want to have, the 7.1. And you see that the difference with climbing age is getting more and more important, whether you use technology or not. So there seems to be an impact using pump, and here I'm talking about pump only. Glucose monitoring, I don't have outcome data yet, because you see that there is a huge change over time. And we've got now about 53% of people using CGM, and in the next years, we definitely hope to analyze whether CGM alone or CGM with pump would have an impact on the metabolic control. So what can we conclude from the SWEET data? We do not meet target in over 70% of young people. Pump treatment shows a little bit lower HbA1c, and we do see in the full population that there is a fast increase in the use of continuous glucose monitoring. But how should we move forward in order to meet targets and provide a better treatment for young people with diabetes? Of course, maybe we should look from an engineer point of view. This is a slide very kindly shared with me through Dr. Andrea Scaramuzza from Cremona. And he was comparing it with a car. First of all, we had the man who was taking all responsibilities for driving the car. The next step would be that part of the work is taking over. We've got the fixed speed with which we can drive, and the information of a sensor, a glucose sensor, as you can see in the circle, is transmitted to the pump, but the pump is not doing anything more with it, except for potentially stopping insulin administration for a fixed period of time to prevent hypoglycemia. But as we know, we shouldn't only prevent hypo, we should prevent as well the hyperglycemia. And this is something, of course, we would expect, and which is now starting to become available with the automatic pilot, where indeed there is an algorithm who will steer insulin administration based on continuous input of glucose sensor values. How can this look? This can look like this, and here a model is the Smart Guard or the Medtronic pump. But I think we still have quite a bumpy road in front of us. Probably we're going down the road, so we are progressing. And I think the road towards this closing the loop, definitely not always smooth, has moved from pump, CGM, to the sensor augmented pump, and now the hybrid closed loop, and some studies on the fully closed loop. And having seen the whole development from 1982, where I started to use with pumps, of pumps in young kids, I think it's a lot of progress. Is it enough? Is it already where we want to be? Let's have a look at what are different things and commercially available hybrid closed loop systems offer us by now. As you can see, there are different kind of algorithms. And there is the algorithm where we've got the fuzzy logic, we've got the PID with the insulin feedback, and that's in the Medtronic pumps. We've got the MPC, the Cambridge algorithm, and we've got the treat to range predictive algorithm, another, again, algorithm which has been developed in the Tandem. So the different systems are Medtronic, 2 systems, CAM apps, and Control IQ from the Tandem. Very important, I think, is as well to look at the different targets which you should achieve, whether it's fixed or not fixed. And I think we still need to have more longer time outcome before we can say what really would be the best way forward. So schematically presented, the closed loop insulin delivery would be, you get a glucose level, which is sensed by the CGM, forwarded in a control algorithm to the insulin delivery, which again leads to the glucose level, etc. Very important to include here, and what you can see as well in the FDI requirement, which has been published, I think it was 2013, for as regulatory criteria for an artificial pancreas, you need to evaluate and provide data on the continuous glucose monitoring, who should be reliable and appropriate computer controlled algorithm, the insulin pump, but as well on the human factor, what can happen and how does it work in real life in patients. And that will be one of the factors very important to create a artificial pancreas system which can be used in a wider population. Would be very nice as well to have that very fast acting insulin. Now, young people, what would they expect? This is a Luxembourg group of young people with diabetes who are moving into the water, which was quite an experience, and they did a brilliant job, of course. Now, what's the patient expectation from the closing the loop or a hybrid closed loop? These are data from an online survey done by Catherine Barnard already some years ago, with a lot of questions in a variable age group and a variable diabetes duration, almost 20 years in some, but you can see the duration was quite variable. Some had pumps, some had CGM, some used it all the time. And that's of course quite an important point, because it's very well documented now that if you use the CGM less than a certain time period, its effect is going to be very limited. And if you would have, say, 50% of use of a CGM while you have a closed loop system, it's not worthwhile to use a hybrid closed loop system. You really should use it over 90%, if not, if possible, almost 100. Now, why would these people use a pump or an artificial pancreas, the hybrid closed loop system? And here you see the wish they would have to get that blood glucose level in a range, no roller coaster anymore, less hypo and hyperglycemia, the variation in glycemic values. The variability is a massive problem. Less worry, the anxiety around low values, whether it is for a child or whether it is for yourself. Sleep better. Sleep is and sleep deprivation, a really important point to consider when you talk about changes in insulin treatment, and less interference with daily life. That's something, finally, what has been demonstrated as well in a latest study published by Garza and colleagues, where they were looking at different perceptions, ideas, reflections, and expectations around the insulin delivery systems. And they were looking at human versus system expectations, technology, the glycemic control, the trust people would have in a system, confidence to use it, control it would take over. The night times, what happens with relationships if you've got another device with you, and also the context in living with diabetes and these hybrid closed loop systems. Would it change quality of life? What would be the features you would consider important? What would be the concerns? And what would you expect to be the burden of the system? And of course, not negligible, not to be put aside is the financial impact. So what did they find? For them, one of the themes they addressed showed that one of the expected outcome would be that there would be in life less discussion about diabetes and more about life, and that it would decrease the stress of the families. And the hope would be that once again, less burden on the person with diabetes, but also less levels of stress within the family. And not, yes, you would still have some carb counting and bolusing, but it would be less imposing attention around meals on this. Have you done your control? Have you done your injection, etc.? And they thought it would be as well something which would have an improved effect on the quality of life, of the relationships, of the family and within the family, reduction of the conflicts around all the daily self-care tasks you have when you are dealing with diabetes. And it can influence your mood. Having that roller coaster blood glucose values where you have the feeling to have no control on really influences your mood. So closed loop system, they expect more sleep, less burden, less manipulation with the system, and of course less injections, because you would have a catheter placed and you would have a sensor measuring continuously. Yes, you have to change them, but there is a difference with 4 to 6 injections per day and a change of a catheter between 3 and 4 days. More flexibility. If there is a continuous insulin and a basal administration covered, whether you eat at 7, 8, or 9, might not have the same impact. And it would be less complex because you only have got one insulin and variation is partially dealt with. Less calculation, less consideration of everything, what has happened. It won't take over everything, but it will influence a lot of these. But of course, every positive has as well some negative or points to consider. And one thing is certainly the alarms. In many of the systems, you can't stop the low glucose alarm. And you can put a strict higher glucose alarm or not, but getting all the times these alerts and alarms can be leading to an alarm fatigue and to not wanting to be bothered anymore. You've got continuous information, which you have to realize can be quite bothersome and tiring. You see, you've got something you can see on the outside that you've got diabetes, which for young people is not always acceptable. You're depending on the device, which you should consider as well, because if the catheter is out, you have no insulin, fast-acting insulin, short, remaining quantity of insulin, so your values go up. And you need to take all the time, all the stuff with you in order to be able to put a new catheter in and so on and so forth. Some people are afraid of devices and devices taking over their life. And of course, every device and every connection can fail and can, at that time point, lead to no insulin admin at all. And then, very important to consider, already mentioned by Joseph in 2013, we're using the skin for all of this. And we need to realize that the skin needs to be well preserved in order to allow appropriate insulin administration and effect and resorption, or resorption and effect. Because if we've got local skin reactions or allergies, that really might influence the resorption of insulin, if already it is acceptable to continue use that specific catheter or sensor with the plaster it has. But on the positive side, sleeping, because of the different devices, is something extremely highly valued. This is not a young person, this is a very young person, because for this population, we didn't have yet any approved combined closed loop systems. And you can see this is the CAMAPS with on the phone algorithm, but as well, you can see the continuous glucose monitoring outcome. There is a small pump, you don't have to manipulate a lot because you will do all insulin administration for meals through the mobile phone. And you can see his face. And here you can see the values in this young person before closing the loop, which were not bad at all. You see the very flat on the lower graph, the very flat basal rate, I hope. And the upper graph shows you the glucose value of the Dexcom. This is 2 o'clock change towards the closed loop. You see how diverse and variable the insulin administration gets, with moments of nothing and moments of up to 3 units. So very important variation and an excellent impact on the glucose values. About 20% basal, a mean value of 135. And you can see that variations remain, but the outcome is really very positive. It led to a lot more sleep of the families, which was something the parents were extremely happy with. And certainly in these young kids, I can tell you all parents cried from happiness when they could continue to use the system after the research project. Now, what's the future going to be? And we're going back now to the young people and not the very young children. I think for the very young children, use of technology should be advised wherever it's available and possible. Now, in the future, we would expect that the outcome improves, metabolic outcome with a more time and range. I think that's definitely something which is more informative, even if we have to learn in the next years about its impact as a surrogate marker on the long-term complications. First data start to come, but we have not a DCCT using time and range. We'll get there. HbA1c, of course, you expect it to remain in the normal range. And of course, less or no increase, at least in hypoglycemia. And I think that's something we, at least in our experience, do see at all levels when we use the hybrid closed loop. It should have as well the psychological benefit, because using a treatment only to get a better metabolic control, which would render the people very unhappy, is not something which is going to be sustainable. It can maybe be used then in a short period of time or to test something, but that's not going to be real life in the long term. But so far, most closing hybrid closed loop systems do provide a better quality of life, better sleep, and reduction of hypoglycemia fear. And this is something we observe in the 780, as well, of course, in that CAMAP use. Too early to talk about the chronic complications. And I think we really need to consider with the different studies which are ongoing, whether we can consider that it will have a long-term economic impact, which I would expect it to have, but thinking is and expecting is one thing. You need hard facts. And furthermore, very important, of course, we need to see how we can get access for these tools for those who might benefit. Not forgetting to get robust long-term data, we also should consider how can we increase access. So if we discuss technology and the current situation in young people, there's definitely a lot of work still to be done. In most young people, we do not meet targets. When we use technology, it's getting better, but it's not good enough. We now need to look whether we really get improved outcome when they use the hybrid closed loops. And with respect to future expectation, partially these are met, and further we need to do for new and more investigations. So there is definitely hope, but we shouldn't sit and wait. We should try to continue to move forward. When should we start technology in young people? I think it depends on the setting of the clinic and on the family. Would it be at onset? It would be my preference, but I know that in our unit at onset, we only start with the very young children directly with pump and CGM, and when we can with the hybrid closed loop, not in the older group, but I wonder whether we shouldn't. I think it depends on the team. You really need to work in collaboration with the family and the person with diabetes and see whether he or she wants to use technology to get a good metabolic control or prefers the conventional injections, knowing that it's going to be at least 4 to 6 injections per day. But I think we have to remain dogmatic about outcome, not about the approach. I don't think for the moment we've got anything which is perfect. Some things seem easier than others, but we have to individualize. Then what age group? I think young children, definitely we need to go and get technology as soon as possible, because it's impossible to do it in, or almost impossible. Nothing is impossible, but it's far more challenging and difficult if you have to provide good diabetes care and meet targets when it's going to be with injection therapy. Of course, you have to look at the family structure and you have to individualize. And certainly for young people, you have to consider their ideas, what they consider an extra or a lesser burden. And sometimes we might be surprised, but their view is going to be essential to include in the treatment we're going to propose them to use. And once again, it needs to be teamwork. And within the team, there needs to be confidence in the use of technology and also a wish to use it and to educate it, because education is going to be key. And then, of course, you can question what kind of technology. Should it be only the pump? Should it be only the continuous glucose monitoring? And some people also say maybe technology is going to come and hybrid closed loop is approaching, but we won't wait. We will individualize according to our needs the systems which are on the market. And there will be within the next months, I guess, very good review paper from written, first of all, by persons with diabetes who have put in place a do-it-yourself or their own closed loop system. And I think it's extremely interesting to see their reflection, which is very well balanced on positive points and potential risks. So in summary, technology in young people, we need to discuss access to it so that it's everywhere at a worldwide level, there for those who need it and who want it. We need to consider human factors. Not everybody is the same, and we should treat to target, individualize. Not all young people will be happy with technology, and other people will be indeed preferring technology on all other options. Education is going to be key, whether it's education of the systems or education of diabetes. It's going to be central in any kind of treatment approach. It needs to be teamwork, and you need to have a 24/7 hotline. And nothing can be done if you don't have a team you work with. And I'm very grateful to the team that they helped me in all the work we've done on technology and, more important, diabetes care every day. Thank you for your attention.
Thank you, Professor Dubofor, for this fascinating presentation. We're going to move on to the question and answer section. The first question is about your experience with the open source systems, like the do-it-yourself systems. What experience do you have about that? What advice do you have for us if we encounter a patient who's using that kind of technology?
Thank you very much for that question. Very interesting. And I think we are evolving. If you would have asked me this 5 years ago, I probably would have said, oh, help. And please let me advise patients against it. I think for the moment that in those, we've got several parents who have started this. And if you look at the outcome, it's incredible, it's impressive. And I think that they managed to do an excellent job. It is, of course, a system for the individual. You need to have parents who are able to cope with it. And I think this is all very well reflected in the review paper, which I hope will come out within the next months. And definitely look for it, because you've got the legal aspects which are not covered. But on the other hand, you see brilliant results from persons with diabetes for themselves or for their children.
Thank you. Our next question is, what should be our approach towards syndromic obesity in children? Should we focus on bariatric surgery, or are there some therapies targeting the hypothalamus?
I think there was an excellent talk before by Khalid Hussain on this perspective. I definitely think that we should look at that what's on getting available now, and there are new drugs in development and new drugs developed, like the melanotide, and there are some other ones who are now being evaluated. Bariatric surgery, I think the verdict is still out because the results might be very short, or we might buy time on one hand, but is that enough? Looking at all the complications, and we shouldn't underestimate the psychological impact of bariatric surgery. And there are some long-term studies in young people who are not that favorable, at least with respect to psychological status. So there are definitely therapies coming, but we need to be careful. And I think we definitely need to screen where we can.
Thank you. I think our last question is, how can we reduce insulin dose in obese children with diabetes?
I think the first thing we need to consider is, why are they obese? Is it because they're trying to be too clever with their insulin and overdosing? Are they hungry because we overdose? And based on that, they need to eat. And sometimes I'm surprised, and that's again, probably in all the answers I should give today, we need to partner with our patients and understand what really is happening. And I can go on a whole evening in how brilliant parents can manipulate pumps. And if you don't really ask and go through the data, you will not understand how they are managing something. And recently, because Luxembourg is regretfully belonging to the more obese population, or at least our population is, recently in some in children with a very high BMI and diabetes, we combined it with liraglutide. And that gave a very good result. First of all, not to reduce the insulin dose, but to reduce the obesity. And through that, say when you reduce insulin resistance, because you've got the mixed form, but it is interesting sport. It's for the moment, the last resort which we are looking for, but it seems to work.
Are you going to be publishing that data anytime soon?
I don't think so, because it's still anecdotal. There are some data published, I think, from probably the US, where they're faced with this problem even more than we are. But presenting as case reports, yes, but it's not enough to publish.
Thank you so much, Professor de Beaufort. It was a pleasure having you. And I look forward to meeting you in other conferences.
Thank you so much for having me.
Good evening, everybody. My name is Dr. Musa Akbar. I'm really honored to participate in this meeting. My talk today will be heart failure across all ejection fraction, with focus on the latest presentation from European Society of Cardiology 2021 on the Emperor Preserved. This is my disclosure. These are my disclosure. So the Emperor Preserved presented in the last European Society of Cardiology meeting 2021, and the Empower program milestone for improving cardiovascular outcome has started from 2015 on the EMPERIC outcome, where the drug empagliflozin showed an effect on cardiovascular morbidity and mortality in patient type 2 diabetes. In 2020, there was a announcing of the Emperor reduced for the effect on hospitalization of heart failure in diabetic and non-diabetic. And now we are glad to have the data from the Emperor Preserve presented in 2021. And upcoming, there is an impulse using of empagliflozin in acute decompensated heart failure, and finally using the drug on post-MI, and this is also an upcoming trial. The new universal definition of heart failure classifies the different heart failure according to ejection fraction. Of those less than or equal 40 is the heart failure with reduced ejection fraction. More than 50%, equal or more than 50% heart failure with a preserved ejection fraction. And in between 41 to 49 is heart failure with mildly reduced ejection fraction. Please note that if there is an if the baseline of heart ejection fraction less than 40 and there is improved more than 10-point increase, it is called heart failure with improved ejection fraction, and the measurement of ejection fraction should be equal more than 40%. We know very well from the epidemiological data that the patients with heart failure with preserved ejection fraction, the HFpEF, suffer from poor outcome. And more than 50% of patients with heart failure suffer from HFpEF, and this proportion is significantly increasing. And approximately 30% of patients with HFpEF die within 1 year of hospitalization of heart failure. Before presenting to today data, there's no clinically proven therapies are available to reduce heart failure outcomes, and the treatment options are limited to the symptoms control and treatment of comorbidity. This is the design, ladies and gentlemen, for the Emperor Preserved study. It's a phase 3 trial in patients with HFpEF, taking ejection fraction more than 40 in type 2 diabetes and no type 2 diabetes, chronic heart failure with NIHA class between 2 to 4, giving 10 milligram once a day of empagliflozin versus placebo, with median follow-up is 26.2 months. There are 3 endpoints. One is the composite primary endpoint, which is time to first event of adjudicated cardiovascular death or adjudicated hospitalization of heart failure. And the 2 key secondary endpoints, they are confirmatory secondary endpoint. The first one is the first and recurrent adjudicated hospitalization of heart failure. And the second one is the slope of change in glomerular filtration rate from the baseline. These are the major inclusion and exclusion criteria. Of note, the main exclusion criteria is the acute decompensated heart failure being excluded, and the glomerular filtration rate more than 20 or requiring dialysis also being excluded from this trial. The baseline characteristics, majority are in class 2, 81%. For the ejection fraction from 40 to less than 450, there is 1/3 almost. And from 50 to 60% is another third, and more than 60% is another or third. And that making more than 2/3 of the patients in the Emperor Preserve had an ejection fraction more or equal than 50%. The main results, ladies and gentlemen, that the empagliflozin demonstrated a clinically meaningful 21% relative risk reduction in the composite endpoint of cardiovascular death or hospitalization for heart failure, with absolute risk reduction 3.3%, number needed is 31. And you can see that there is a separation of the curve earlier in the course of the treatment, and the curve continued to diverge throughout the period of the study, and the p-value is highly statistical significant. The pre-specified group has been found that there is a consistent, clinically meaningful across these pre-specified, and overall age, whether less than 70, more than 30 benefited from the treatment group. Male or female are benefited from the treatment group, as well as those who have ejection fraction less than 50, 50 to 60, and more than 60 are benefited from the group as overall. And this pre-specified subgroup showing a benefit with the p interaction is not significant. And whether you have diabetes or no diabetes, they have benefited from the treatment group. Renal function more than 60 or lower than 60 is also showing benefit from the treatment group. And ischemic and non-ischemic etiology of heart failure showing benefit. More benefit was observed in non-ischemic etiology. And whether heart failure hospitalization in less than 1 or equal 1 year, yes or no, also showing a benefit from the treatment group. And also overall there is a benefit from the following pre-specified subgroup, whether the baseline ACE or ARBs or ARNI showing a benefit, or mineralocorticoid antagonists, they're a benefit, or lowering the anti-brain natriuretic peptide, whether below median, high or higher than median, there is a benefit. Whether you have hypertension or no hypertension, there is a benefit, or history of atrial fibrillation or atrial flutter, there is also benefit. Now, the empagliflozin reduced the first and recurrent hospitalization of heart failure by 27% in the confirmatory endpoint. Again, very highly statistical significant of p-value, with notice of early separation of the curve through the earlier study out period, and continue to diverge the curve throughout the period of the study. For the second confirmatory endpoint, the empagliflozin protected the kidney from significantly slowing the decline in kidney function. As you can see, there is a protective effect. The difference in decline is 1.36, and that is significant p-value. With empagliflozin, the drop per year 1.25, in the placebo 2.65, making that the rate of the glomerular filtration rate decline in patients treated with empagliflozin, was half that of patients treated with a placebo, giving the renal protection of the drug. And this is similar data that was presented with Emperor reduced. So, ladies and gentlemen, the Emperor preserved the specific endpoint for hierarchical testing. All showed confirmatory, the primary endpoint, adjudicated cardiovascular death or hospitalization for heart failure, 21 relative risk reduction with significant p-value. The secondary endpoint, adjudicated first and recurrent hospitalization for heart failure, is confirmatory with a 27% relative risk reduction with significant p-value. And the last of the secondary endpoint is the glomerular filtration slope decline, is confirmatory with a difference is 1.36, giving the significant giving the renal protection and the slowing the decline in renal function with the treatment of empagliflozin. For the exploratory endpoints, the composite endpoint of the primary endpoint, the hospitalization of heart failure and cardiovascular death, was mainly driven by the hospitalization of heart failure. And the other pre-specified outcomes, the change in the Kansas cardiomyopathy score was slightly better in the treatment group. The all causes mortality show no difference between endpoint, as well as the composite and renal endpoint were similar in both groups. For the changes in vital signs and laboratory findings, the glycated hemoglobin was less in the treatment group compared to the placebo group. Hematocrit was more in the treatment group compared to the placebo, as well as the body weight was more or less in the treatment group than in the placebo. Systolic blood pressure more drop in the in treatment group versus the placebo. Uric acid more lower in the treatment group than the placebo, as well as the N-terminal pro-brain-natriuretic peptide more lower in the treatment group compared with the placebo. For the safety outcome, ladies and gentlemen, any adverse effect, as you can see, are comparable between the treatment group and the placebo, as well as the serious side effects. For the hypotension, symptomatic hypotension are more comparable, are comparable in the treatment group as compared to placebo, similar, as well as the complicated UTI and complicated genital infections are comparable between two groups, as well as the ketoacidosis and hypoglycemic effects were similar in treatment group and placebo. And even in patients without diabetes, there is no fear of ketoacidosis or hypoglycemic events, and these are comparable between the treatment group and placebo, confirming the safety profile of drug in this type of population. So to summarize, ladies and gentlemen, the results from Emperor Preserve, the half of all HAF patients have HFpEF and suffer from poor cardiorenal outcome despite optimizing symptom control and treatment comorbidities due to the absence of any clinical proven therapies today. With the Emperor Preserved for the first time in medical history, our treatment showing a beneficial outcomes in patients with HFpEF by reducing the risk of the composite endpoint of hospitalization of heart failure or cardiovascular death. Empagliflozin demonstrated a clinically meaningful 21% relative risk reduction in the primary endpoint of cardiovascular death or hospitalization of heart failure on the top of the background therapy. The benefit was independent of ejection fraction and consistent across the further pre-specified subgroups. In addition, empagliflozin reduced the first and recurrent hospitalization for heart failure by 27% in a confirmatory secondary endpoint. And the empagliflozin protected the kidney by significantly slowing the decline in kidney function. The overall safety data were consistent with the previous finding in cardiovascular patients, confirming the proven safety profile of empagliflozin. Empagliflozin is already indicated to treat patients with heart failure with reduced ejection fraction with a proven risk reduction of cardiovascular death or heart failure. Now they extended to preserved ejection fraction, and if proved for treatment for HFpEF, empagliflozin would change clinical practice by becoming the first and the only therapy to improve cardiorenal outcomes for the full spectrum of heart failure patients, regardless of ejection fraction. Reminding you that this trial, the Emperor Preserve, is published simultaneously in the New England Journal of Medicine in August 27, 2021. And also FDA grants the empagliflozin breakthrough therapy designation for heart failure with a preserved ejection fraction, waiting for the final approval. By this, I end up my talk, and thank you very much for your attention.
Good evening, ladies and gentlemen. First of all, I would like to thank the organizing committee and Servier for giving me this opportunity to share with you the consensus statement from the Gulf Cooperation Council on sulfonylurea, which was published in Diabetes Therapy this year. So this is my disclosure of relationship, and this presentation is sponsored by Servier. My name is Ibtisam Baisa. I'm consultant internist and endocrinologist from Dammam, Kingdom of Saudi Arabia. So as you all know, the prevalence of diabetes in the group of GCC countries is one of the highest in the world, and the use of sulfonylureas is widespread due to their extensive evidence of their efficacy and understanding of their risks, and they have been in use for more than 60 years, and they are also cheap and affordable. The discrepancies between international guidelines on diabetes mostly relates to the recommendation for second-line agents, and this is attributable to the concern regarding the cardiovascular risk and safety of sulfonylurea with the earlier generations, and the potential for body weight and body weight gain, as well as hypoglycemia. So as you know, we had the first generation sulfonylurea, which now is obsolete. They are not in use anymore. And we have the second generation sulfonylurea, glipizide and gliclamide, which are less frequently used. I know there are still some countries using them. And we have the newer generation sulfonylurea, glimepiride and gliclazide, which are most commonly used. The first generation sulfonylurea were introduced in 1950, and the second generation sulfonylurea were introduced in the 1984, and glimepiride was introduced in 1995. And as I mentioned, gliclazide and glimepiride is largely replaced all those first generation sulfonylureas. So this presentation summarizes the present and future role of newer generation sulfonylureas, such as gliclazide MR, in the management of diabetes within the GCC countries. So the GCC task force process consisted of two virtual meetings that was held in 2020 in view of the epidemic era. And the first meeting was held in October 2021. The task force members were assigned topics. For each topic, task force member conducted literature review to identify the most robust, up-to-date literature and relevant systematic review and meta-analysis. The second meeting were held in November 2020, and the task force members described findings of literature review, and an online survey of sulfonylurea use in clinical practice was also distributed among other experts and colleagues within the GCC region. And the literature reviews and survey responses formed the basis of the manuscript on which this presentation is based. And the article, as I mentioned, was published in May 2021. So I had the pleasure also to work in this group, and the main author of this task force was Professor Al-Saleh, where we had the pleasure to work with him. And also I had the pleasure to work with my colleagues from the Kingdom of Saudi Arabia, United Arab Emirates, Kuwait, Bahrain, Qatar, and Oman. This consensus was endorsed by the Gulf Association of Endocrinology and Diabetes, the Bahrain Diabetes Society, the Emirate Diabetes and Endocrine Society, and the Saudi Diabetes Society. The major themes of this paper included the introduction, mechanism of action, the long-term sulfonylurea efficacy and safety, the clinical practice research, data link, the CPRD study, the end organ benefits, cardiac and renal, the risk of hypoglycemia and Ramadan studies, the body weight gain, and then the conclusion. I will start with the mechanism of action. As you know, sulfonylurea differs in their affinities for sulfonylurea receptors in different tissues, such as the pancreas and the heart. And for example, if we take the second generation sulfonylurea gliclazide, which has the high affinity and reversible binding to sulfonylurea receptor 1, which makes it a unique sulfonylurea as compared to other sulfonylureas, especially the first generation sulfonylurea and the older second generation sulfonylurea. So the restoration of the early insulin peak secondary to glucose and the storage, the stronger reversible bindings of gliclazide MR to the beta cell sulfonylurea receptor 1 compared to other sulfonylureas could be responsible for the reduced pancreatic stimulation, which translate later to reduced risk for hypoglycemia. In more details, you can see here the link to the lower risk of hypoglycemia with gliclazide MR. As you know, insulin secretion from beta cell is glucose dependent, and insulin secretion depends on reversibility of binding to ATP sensitive potassium channel on beta cell. As you can see here, with gliclamide and glimepiride, the second generation sulfonylurea glimepiride, they combine the sulfonylurea receptor 1, but this combination is really irreversible. While with gliclazide MR, this binding to the receptor is really reversible. So that translates to the reduced risk of hypoglycemia with gliclazide, and you can see the highest risk for hypoglycemia is with gliclamide, and also amongst the second newer generation sulfonylurea, gliclazide have shown lower risk of hypoglycemia as compared even to glimepiride, second generation sulfonylurea. The potential also mechanism for variability in mortality risk between sulfonylurea, in addition to the reversibility of the binding, also the selectivity of the binding to sulfonylurea receptor 1. So as you can see here, gliclazide selectively binds to the sulfonylurea receptor 1, which is located in the pancreatic beta cell, while other sulfonylurea, they bind to other sulfonylurea receptor 2A and B that is located in the myocardial and the vascular smooth muscle cell. And that again will translate to the what happens with the older generation sulfonylurea, where they have an interference with the adaptive ischemic preconditioning and increase in the myocardial infarction side, which we don't see with the newer sulfonylurea generation glimepiride and gliclazide because of their selective binding to sulfonylurea receptor 1. Also, mortality risk among sulfonylurea, systemic review and network meta-analysis of 18 controlled trial that included a huge number of patients, as you can see here, revealed that the lowest risk occurred with gliclazide in case of all-cause mortality as well as cardiovascular disease-related mortality. So as you can see here, it is lower with glimepiride and gliclazide, and it is lowest with gliclazide. So let us now review the long-term sulfonylurea efficacy and safety with the newer generation sulfonylureas. I'll just only remind you about this important landmark study, the UK BDS. This is an old study that we learned from it a lot, where they have used in the intensive control, intensive group, the sulfonylurea and insulin, and they demonstrated that sulfonylurea as well can result in significant reduction of A1C and achieving glycemic target and result in metabolic memory. So while glycemic control in the cornerstone of type 2 diabetes management, long-term efficacy and safety are paramount consideration when declining on optimal treatment. And the risk and benefit of sulfonylurea are well documented given their established history. And in the advanced trial that included more than 11,000 type 2 patients with diabetes aged 50 and more, and what we have learned from this advanced trial, we learned that tight glycemic control with A1C less than 6.5 can be achieved and maintained for up to 5 years study period using a sulfonylurea-based regimen. In addition, tight control with a sulfonylurea-based regimen gave a 14% reduction in microvascular complication versus a standard therapy. As well, tight glycemic control with a sulfonylurea regimen was deemed safe and practical despite no significant reduction in macrovascular events or mortality from any cause. So let us review the clinical practice research data link, the CPRD study, and with the aim of to compare the safety and efficacy of gliclazide MR versus DDP4 inhibitor sitagliptin post-metformin monotherapy. This is a retrospective observation study using real-time primary care data from the UK in type 2 diabetes patients, almost around 2,000 patients treated for up to 9 years. And what it has been shown that the gliclazide MR was associated with 35% higher probability than sitagliptin of achieving target A1C of less than 7%, and which is significant, statistically significant, and also had similar durability and persistence of glycemic control when reported for both drugs. And the symptomatic hypoglycemia induced rate was low in both groups, gliclazide MR versus sitagliptin, 4.7 for gliclazide and 2.6 events per 1,000 patients a year. So the CPRD helped secure the place of newer generation sulfonylurea in modern type 2 diabetes management. Let us now discuss the end organ benefit and safety, cardiovascular safety. The newer generation sulfonylurea may be considered cardiovascular safe and are not associated with an increased cardiovascular risk compared with the standard therapy. So what we have learned from the advanced trial and the advanced on trial that people who were on the gliclazide MR intensive control group versus the other sulfonylurea, it showed that there is no increased risk for macrovascular event. There is no increased death from any cause and no cardiovascular death. In another study, Carolina, which in this study, they compared linagliptin versus glimepiride, and they found that both drugs were safe from the cardiovascular point of view. So that makes the second generation sulfonylurea, like gliclazide and glimepiride, has low risk for cardiovascular related mortality. And on top of the list, gliclazide followed by glimepiride. In regard to the other cardiovascular safety, the newer generation sulfonylurea may be considered cardiovascular safe and are not associated with increased cardiovascular risk. Sorry, this is a repetition of the slide. So now let us discuss the renal benefit. Several publications have confirmed the renal benefit with gliclazide MR-based intensive treatment versus standard therapy of other sulfonylurea. Again, in the advanced trial, it has been shown that there is a 14% reduction in the major microvascular event and 21% reduction in worsening nephropathy, and this is all statistically significant. In addition, there was 65% reduction in end-stage renal disease, as you can see here, and 9% reduction in albuminuria. And in the advanced on trial, the post-trial follow-up, it has been shown that this renal protection has been sustained and there is continued 46% reduction in end-stage renal disease risk, which is statistically significant. So other groups, such as the Association of British Clinical Diabetologists, only recommended the use of one sulfonylurea, which is gliclazide, but do not recommend sulfonylurea used in type 2 diabetes when the GFR is less than 30. In regard to hypoglycemia in Ramadan, among sulfonylurea drugs, gliclazide poses the lowest risk of major hypoglycemic episodes comparable to risk level of other commonly used second generation sulfonylurea agents. Hypoglycemia risk is a major concern in type 2 diabetes patient choosing to fast during the holy month of Ramadan and was examined in 3 main studies. The first study in 2011 by Asifri et al., which looked at sitagliptin compared to sulfonylureas. In another study published in 2012 by Arvind et al., again sitagliptin versus sulfonylurea, and in 2020 by Hassanein et al., looking at gliclazide MR in Ramadan. So what was the result? In the Asifri et al., he've shown that the symptomatic hypoglycemia occurred in 6.6% in people on gliclazide versus 6.7% in people on sitagliptin. In the Arvind et al., he showed that hypoglycemia occurred in 1.8% in gliclazide group as compared to 3.8% in sitagliptin group. So you have seen the safety of sulfonylurea is not uniform, and gliclazide, as has been shown, is associated with a lower hypoglycemia rate than other sulfonylureas and similar or even better rate than sitagliptin. In Hassanein et al., the Ramadan study, it was found that the overall risk of one or more symptomatic hypoglycemic event is 2.2%, and there was no severe hypoglycemic events occurred over the 14 to 18 weeks study period. In regards to body weight gain, there is no evidence of body weight gain due to sulfonylurea treatment, particularly gliclazide, and analysis of gliclazide recipients in the advanced trial-based medication type and baseline glycemic control found that participants already undergoing progressive titration of gliclazide, an approach consistent with the actual clinical real-life practice, showed no body weight gain. And the study participants lost even weight As you can see here in the Easy Diet study, people with diabetes have lost weight between 0.9 to 2.2 kilogram, and the higher is the BMI, is the higher the loss of body weight. In addition, also in the Diet Ramadan trial, they found that people even lost weight with glycoside, and as you can see here, between 0.5 to 3.9 kilogram with glycoside. So should sulfonylurea remains an acceptable first-line add-on to metformin therapy in patients with type 2 diabetes without renal or cardiovascular risk or disease? The answer is yes. They continue to serve us very well, and the place of sulfonylurea with current guidelines, the guidelines recommendation about sulfonylurea as a class. I'm going to discuss it in the next coming few slides. As you can see here in the UK, NICE recommendation 2020, sulfonylurea remain a drug of choice for first-line intensification and second-line intensification, and as add-on to metformin and other drugs. And the only sulfonylurea that has been recommended in UK NICE guideline is glycoside and glycoside MR. So NICE sulfonylurea may be considered if symptomatic first and second intensification, glycoside or glycoside MR. Again, in the Australian algorithm 2020 for the management of diabetes, sulfonylurea still also plays a major role as first line, second line, and third line recommendations in the management of diabetes, and it's used more commonly than other drugs, as you can see here. Again, in the ACE glycemic control algorithm 2020, after addressing the cardiovascular and renal issues and safety and benefits, sulfonylurea remain one of the drugs that may be used with caution as first and second line to achieve target A1C. In the latest also ADA and ASD consensus statement, after addressing again the cardiovascular and renal benefit, sulfonylurea remain one of the drug if cost is a concern, and also if A1C is not achieved, it may be used as an add-on drug to other classes of drug. And they considered to choose a later generation sulfonylurea to lower the risk of hypoglycemia, and they mentioned in the ADA the glimepiride, which have shown similar cardiovascular safety to the DB4 inhibitor. Glycoside is not available in the USA, so it is not seen in their guidelines and recommendations. So ADA-ASD sulfonylurea is to be considered as first line if cost is a major issue, and second line after addressing other concerns. Also in the Diabetes Care 2014, they have wrote a sentence that the ideal anti-hypoglycemic agent would be easy to administer, unlikely to cause symptomatic side effect, and both barriers to adherence, inexpensive, reliably efficacious, and safe. And by such standards, it can be argued that the remaining modern sulfonylureas do well. So even the EDA recommends sulfonylurea as a good and effective and inexpensive drug. So the current evidence and recommendation would suggest that in the absence of atherosclerotic cardiovascular disease, chronic kidney disease, or heart failure, a later generation sulfonylurea like glycoside and glimepiride is still the most cost-effective first-line add-on to metformin and second-line agents for those patients, even in the first ward setting. Several international guidelines still recommend the use of modern sulfonylurea in patients with type 2 diabetes, even in the presence of cardiovascular risk, because as I have shown you, it demonstrates cardiovascular safety. So sulfonylureas, a proven and still valuable option, still occupies a central position in the recommendation of all the guidelines for treatment of type 2 diabetes, and are likely to continue to be a reliable and effective treatment, particularly as combination therapy. So in conclusion, ladies and gentlemen, the glucose lowering potency of newer generation sulfonylurea is similar to older sulfonylureas, with the advantage of faster glycemic control and a lower incidence of adverse event. And most endocrinologists in the region, including the experts in the therapeutic areas who were involved in the present consensus, are fully aware that not all sulfonylurea drugs are the same, and they continue to prescribe sulfonylureas, especially glycoside MR, as one of the top options for second-line treatments in patients with no known cardiovascular and renal disease. With that, on behalf of the primary author and my dear colleagues, the co-authors, I would like to thank you for attending. Thank you very much.